which just underlines the importance of the best possible utilization of time and resources we have in our hands. In the program today, we'll have a series of enlightening discussions from the esteemed, distinguished, revered personalities in the field of rheumatology, covering a wide range of topics from this ever-changing superspecialty. It is on occasion like this we get to learn and grow together. We look forward to get an exposure about what the best of brains think about various important and relevant topics in this very dynamic branch. I hope that all of you will have the 8 most productive hours of interesting and stimulating discussions. I would like to extend my gratitude to Professor and Head of Department of Rheumatology, Dr. Uma Kumar ma'am, who has been a key person in helping throughout to organize this event and for bringing together such great minds at one place. And as they say, great things happen when there is gathering of great minds. Despite all her commitments and engagements, Dr. Uma ma'am has been able to bring the Department of Rheumatology at AIIMS Delhi to great heights with her undaunted and unwavering efforts. All her achievements are the result of high intention, sincere efforts, intelligent direction, skillful execution, and the vision to see obstacles as opportunities. The list of laurels is indeed endless that ma'am has achieved in such a short span of time, which is truly inspiring and influential. I would also especially like to thank all the distinguished rheumatologists who are on the faculty for today's update, for taking out time from their busy schedules, and for sharing their knowledge and wisdom. As we are celebrating April 2022 as Rheumatic Diseases Awareness Month, would like to kickstart the program with the first session on management of rheumatic diseases. May I please invite on stage Dr. Rohini Handa sir as a chairperson for the first session. Dr. Rohini Handa is a distinguished rheumatologist at Indraprastha Apollo Hospitals, New Delhi. He has 35 years of experience in rheumatology with him, former professor at AIIMS Delhi. He has published more than 330 review articles, book chapters, papers, and abstracts. Vice Dean of Indian College of Physicians and a life member of IRA Delhi, and many more. He has received several awards, J.C. Patel and B.C. Mehta Prize, Dr. J.N. Berry Award, IRA Oration by IRA, etc. I would also like to invite Dr. Vaibhav Ingle, sir, Assistant Professor, Department of General Medicine at AIIMS, on the dais. Please take a seat. May I request Dr. Rahul Jain, sir, also to kindly come and join the chairpersons on stage. He has been a member of EPLAR RA Treatment Recommendation Steering Committee 2013 for the management of RA. His areas of interest are systemic connective tissue disorders and very early spondyloarthritis. I would now like to request the first speaker of this session, Dr. MPS Chawla, sir, to please come on the stage. And would request the respected chairpersons on stage to introduce him. Thank you.
Morning, friends and colleagues, and welcome to this opening session of the annual DRA Rheumatology Update. I think after a long spell of webinars, physical meetings such as this one go a long way in promoting not only the speciality but the camaraderie that we all missed with virtual meetings. Now, kickstarting this meeting is a stalwart, Dr. M.P.S. Chawla, who heads the Department of Medicine at RML Hospital. Without further ado, may I request Dr. Chawla to start with his very apt lecture on the interface between rheumatology and physician. Over to you.
Thank you, sir, for these kind words. And when I first got this topic from Uma, I was not sure what I would speak. Basically, I'm an internist, I'm not a rheumatologist. And even I don't have a special interest in rheumatology. Right from COVID, everything, as an internist, we have to face. So, but when I read the program and then I saw that Professor Rohini Handa is one of the chairpersons, so I was relaxed. So all the audience, if there is any question, ask him, not me. I have no conflict of interest to declare. So what is the importance of this topic? Why this has been chosen? There is change in demographics because of the aging of the population, ever increasing environmental triggers of autoimmunity, and dominance of non-communicable diseases over communicable diseases. Recently, there have been path-breaking discoveries and game-changing treatments. Teaching of rheumatology, I feel, is often marginalized in undergraduate and postgraduate medical curricula. So when these young doctors, they come out, they are not trained, they are poorly prepared to handle the cases with musculoskeletal problems, which are very common. A study carried out from 2004 to 2010 in India revealed that musculoskeletal pain was prevalent in 6.4 to 23.6% of the Indian population. The most prevalent rheumatic problems are non-specific musculoskeletal complaints, followed by soft tissue rheumatism. Inflammatory rheumatic diseases, they had a prevalence of less than 1% each. Rheumatoid arthritis, 0.34% to 0.67%. Undifferentiated inflammatory arthritis from 0.2 to 0.7. Spondyloarthritis from 0.23 to 0.3%. And gout from 0.04% to 0.13%. So there is paucity of data from our country, but still this is the latest one that we have showing that musculoskeletal complaints are very common in general population. So goals in rheumatology, they have changed. Now we are talking about early diagnosis, we are talking about tight control of joint inflammation, and we are talking about inducing remission in early cases of arthritis, and if not possible to induce complete remission, at least, ensure that there is a low disease activity. Now, a treat to target approach, that is what is preferred. Early and aggressive treatment with disease-modifying antirheumatic drugs initiated during the window of opportunity. Now, for example, rheumatoid arthritis is also classified as a time-critical illness, just like acute myocardial infarction, just like sepsis, just like stroke. So you need to assess response to treatment and review treatment plan. You aim for maximum improvement within, say, first 6 months, and 80% of that improvement that should come within the 3 months. So inertia, which is there at the level of treating physicians, that has to be taken care of. You reassess, and if at 3 months the goals that you had set you are not achieving it, please review your treatment and add on further drugs. Control of functional consequences, and you need to prevent long-term harm. And then control of cardiovascular risk factors because of the prolonged and sustained inflammation, which is responsible for 30 to 50% of the deaths. So is the role of physician limited as a gatekeeper? Is he just supposed to refer the patients to rheumatologists? No. He is supposed to assess the patient. He is supposed to initiate preliminary therapeutic intervention in the primary care setting before referral to rheumatologist. because reaching Dr. Rohini Anda or Dr. Malviya or Dr. Ashok Kumar is not an easy job. He is supposed to conduct key laboratory tests because it has been seen that if the patient comes for the first time to a rheumatologist and if he has some baseline investigations, that does save the time for both the rheumatologist and the patient. Then he is instrumental in expediting the diagnosis and in early management of these cases. And he is supposed to coordinate with rheumatologist, which may ultimately lower disease burden and healthcare cost, which is the ultimate aim of each one of us. So musculoskeletal pain, first of all, they have to be trained, they have to be told whether, look for it, whether it is a periarticular pain or whether it is an articular pain. If it is articular, is it non-inflammatory or is it inflammatory? Non-inflammatory, which are especially common in our country, osteoarthritis, hypothyroidism, anemias, high doses of statins that we are using so frequently nowadays. Then if it is inflammatory, you classify whether it is monoarthritis, oligoarthritis, or polyarthritis. Then articular pain usually is deep and diffuse. There is pain during both active and passive movement of the joint, and there is presence of associated factors like swelling, capitation, deformity, instability, locking, or contractures. Non-articular pain, there will always be a point of focal tenderness in areas adjacent to articular structure. It may radiate along the tendon, for example. There will be pain only during active movement of the joint, and physical findings may be present remote from the joint capsule. So if you are able to train them to differentiate between articular and non-articular pain, then probably osteoarthritis, fibromyalgias, they can be handled at the level of primary care physician itself. Then they have to be taught how to differentiate what is the difference between arthralgia and arthritis. The key features that aid pattern recognition, the mode of onset, duration, number of joints involved, distribution, presence of extra-articular features, sequence of events. All these, they have to be taken into account before reaching at a diagnosis. Now, how do you recognize inflammation in joints? Frankly speaking, I am fascinated by two branches, neurology and secondary neurology, because 80% of the diagnosis you reach by taking a careful history, 15% by physical examination, and only 5% of the diagnosis, that is what is done by relevant investigation, that to targeted investigations. That is very important. So in the history, you ask for significant early morning stiffness, improving the activity. You ask if there is spontaneous fluctuation in disease activity, presence of constitutional symptoms, low-grade fever and night sweats, and fatigue. Then in examination, you look for inflammation, and in labs, you have to do acute inflammatory markers like ESR, CRP, platelets, and normocytic normochromic anemia, so-called anemia of chronic disease. So as I told you, focused history is very important. You look for how many joints are involved. Depending on that, you keep certain diagnoses in mind. Onset, pattern, additive and migratory and intermittent. Just I'll give you an example. For example, any patient, especially in the childhood who's presenting to a physician, first diagnosis they keep in mind is that it is a rheumatic fever if he has pains. Because incidentally, he happens to have ASLO titers of more than 200 Todd units. So, but the pattern that is additive or migratory is very important. Migratory, some joints will be involved, then new joints will be involved, but there will be resolution of symptoms in the earlier joints. Whereas, for example, in juvenile JRIA, it will be additive. That is, joints are involved in rheumatoid arthritis, joints are involved, then new joints are involved. Then there are erosions, there are deformities. Then activity effect, what is there on the joint, distribution, whether it is symmetrical or asymmetrical. If there is systemic or extra-articular symptoms present, this is one more indication. If a physician is not able to make out, explain these extra-articular symptoms, probably he should refer such a patient to a rheumatologist. Then monoarthritis, some of the common causes are septic arthritis, tuberculosis, gout and other crystal deposition diseases, spondyloarthritis to begin with, then monoarticular onset of a polyarticular disease. In fact, monoarticular, the dictum is you, until unless it is proved otherwise, treat it as a septic arthritis. Oligoarthritis, gout is a common example, juvenile idiopathic arthritis, psoriasis, spondyloarthritis, and polyarthritis, you are all aware, rheumatoid arthritis, psoriasis, lupus, systemic sclerosis, adult onset, Hill's disease, IBD, and polyarticular gout is not unknown, especially in elderly patients. So again, differentiation between inflammatory and non-inflammatory arthritis. Inflammatory arthritis, examples of rheumatoid arthritis, spondyloarthritis, lupus. In these cases, morning stiffness will be there for more than 30 minutes. There will be pain aggravation even on resting the joint. Spontaneous flares are common, and acute phase reactants, they will be increased. Whereas non-inflammatory arthritis, for example, in osteoarthritis, hypothyroidism, morning stiffness will be less than 30 minutes. Pain will be more on moving the joint. Flares are uncommon, and acute phase reactants, they will be normal. These pattern onsets telling you what kind of disease it is, all of you are aware of it. One more advice I'll give you to the internist, especially keep a nail paint remover in your office always, because these, especially connective tissue diseases, rheumatoid arthritis, they are more common in young females. They will come to you with this. You have to do oxygen saturation, so you need to remove the nail polish. Then you have to see the nail changes, for example, in psoriasis, or you have to do nail fold capillaroscopy. Always keep, because they are not carrying it with them. Lipstick will be there, but this will not be there. So similarly, examination of hand is very important. For example, rheumatoid arthritis, typically involving rest, proximal interphalangeal joints. Distal interphalangeal joints, especially involved in osteoarthritis, the nodular form, a burdens that we are talking about is uncommon in Indian context. Reactive arthritis and psoriasis. Dactylitis is another important thing that will help you in finding out what kind of disease it is. So sometimes you come across patients who have joint pains associated with fever. Keep in mind lupus, juvenile idiopathic arthritis, infective endocarditis, rheumatic fever, various vasculitis, and adult onset till disease. A patient is coming to you with a Raynaud's phenomena and rheumatic condition. Keep in mind systemic sclerosis, which is the commonest cause. Mixed connective tissue disease, lupus, Sjogren's, rheumatoid arthritis, cryoglobulinias, dermatomyositis, and antiphospholipid syndrome. Now, lab investigations which are advised, acute phase reactant, CSR, and CRP, autoantibodies. Again, remember, you have to use autoantibodies very carefully because, as I told you, 95% of the time you will be able to reach your diagnosis by history and focused general examination. And you have to do these autoantibody profiles only to confirm your diagnosis. Rheumatoid factor, anti-CCP, ANAs, which are now called as anticellular antibodies rather than anti-nuclear antibodies, ANCAs, HLA, especially HLA-B27, synovial fluid, and X-rays of the relevant parts. Now, if this is a common fallacy, rheumatoid factor is positive, patient is having joint pain, straight diagnosis that is made by physicians is rheumatoid arthritis. So we must keep in mind that positive rheumatoid factor is also associated with elderly people, other chronic inflammatory rheumatic diseases, primary Sjogren's, mixed hyperglycemia, lupus, then certain infections like infective endocarditis, tuberculosis, viral hepatitis, and some conditions like sarcoidosis, autoimmune hepatitis, they can all lead to positive rheumatoid factors. Rheumatoid factor positive does not mean rheumatoid arthritis. Similarly, ANA is another test that we are using. The method of choice is indirect immunofluorescence. ELISA we are not recommending because there are limited antigens that are picked up by it. And with the use of these newer epithelial cells, HAP2, now it is virtually unknown that ANA negative lupus, it is virtually unknown. So some of the autoimmune diseases in which ANA is positive, lupus in 99% of the cases, systemic sclerosis in 90%, Sjogren's in 90%, mixed connective tissue diseases in almost 100% of the cases. Then inflammatory myositis, rheumatoid, osteoarticular GIA, they can all have this. Now, non-rheumatic diseases where you can find positive ANAs, autoimmune hepatitis, ampullary cirrhosis, myasthenia, infectious mononucleosis, and in fact, 5% of the healthy young women. Infections, they can lead to transient positivity. For example, in post-COVID patients, they're coming to up. Many of them, they are found to have ANA positive. And finally, drugs like procainamide, hydralazine, penicillamine, isoniazid, and anti-TNF drugs. Then, if another common mistake that is done is that ANA is negative and people are altering extended nuclear antigen profile. That is something which should be avoided because this is our country is very much, resources are very important. So only if ANA is positive, then only you go in for ENA profile. If you have high clinical suspicion, then, for example, various types of subtypes are there, anti-Smith, that is specific, or anti-DS DNA, they can even be used to monitor the disease. Otherwise, ANA or rheumatoid factor you have done once, there is no point in repeating them. Though in a long standing case of lupus, ultimately ANA does become negative, but there is no point in getting these tests repeated again and again. So again, to synovial joint fluid examination, most of these, other ascitic peritoneal fluid, what we are doing, that is usually not required for joint fluid analysis. You need to just do about the cell counts and see how many of cells are neutrophils. For example, non-inflammatory, the cell count will be from 200 to 2000, and less than 50% will be neutrophil. Whereas inflammatory, it will be more than 2000 up to 30,000, 2 to 10 WBC per high power field, and more than 50% will be neutrophils. Whereas in a septic arthritis, there will be more than 1 lakh cells and more than 90% neutrophil. Rest of all these things, that we used to do earlier, that is no longer relevant. This is good enough. Gram staining and culture. PCR also is not that helpful unless there is you are thinking about a particular diagnosis. Now, this is basically, I see the stalwart of rheumatology sitting here. My just only point to show this slide is that now even, we earlier used to say for rheumatoid arthritis that more than 6 weeks of duration is that is required. But now even that criteria has been taken off. All these domains, and you give particular scores, and if it is more than 6 by 10, you diagnose it as rheumatoid arthritis. So that is the importance of early diagnosis and early intervention, that is very important. So, we do advise radiographic imaging in low back pain. Some of the fallacies that are committed are, for example, majority of patients with non-specific back pain, they will have normal X-rays. There is something known as clinico-radiological discordance. For example, patients, they will be having impressive radiological abnormalities, but maybe totally asymptomatic. On the other hand, the patient will not give you any symptoms, and he's having marked radiological changes. Nearly 60% of patients with radiographic evidence of lumbar disc degeneration are asymptomatic. So you have to keep in mind what diagnosis you are thinking about. For example, if you're thinking about spondylitis, you get MRI spine. Most of the patients you will find evidence of disc disease. And every physician is very comfortable. This is disc disease, and that is it. They do not, you have to advise them to focus on sacroiliac joints. And even plain X-rays are good enough. Plain X-ray of pelvis is good enough to diagnose if the sacroiliac joint is already involved. Similarly, there are certain pitfalls in diagnosis and treatment of rheumatoid arthritis, which I have already told you, basing the diagnosis of rheumatoid arthritis on serology without clinical correlation, frequently repeating rheumatoid factor, suboptimally utilizing physiotherapy and occupational therapy services, underdosing of methotrexate, injudicious use of corticosteroids, and delaying treatment escalations in face of a flare. Rapid de-escalation rather than it should be gradual, and escalation has to be rapid. Now, methotrexate, I think this is one drug that internists or physicians, they have to be made aware of how to use it, because this is the only drug that has been shown to reduce mortality in rheumatoid arthritis. Not even biologics, they don't reduce mortality. Yes, they do reduce radiographic progression, but mortality advantage is always present with methotrexate. So it is the anchor DMA-RD4 RA, and we must remember these are the doses which are anti-inflammatory doses, which are quite safe, from 7.5 milligram to 25 milligram. If the dose is more than 15 milligram, you break it into 2 doses. If there is a nausea, you may use an antiemetic. In patients with suboptimal relief to oral methotrexate, subcutaneous methotrexate may be used, and it must be stopped 3 months before planning pregnancy. Earlier, there was a concept of a cumulative total dose, but now it is clear that there is no concept, and you can continue to use it indefinitely. Of course, you have to follow up and do the relevant test. So corticosteroids, they are often misused. So what is their place? They are used as a bridge therapy, especially for the earlier 8 weeks or so, where initiating or switching conventional synthetic DMRDs for the treatment of rheumatoid flares, for extra-articular rheumatoid disease like rheumatoid vasculitis, mononeuritis multiplex, ILD. Low dose of 7.5 milligram or less can be used in patients with refractory RA to maintain quality of life. And pregnancy and lactation, remember, this is one of the safe options that is there with you. Then intra-articular corticosteroids, especially if there is oligoarticular involvement. So biologics, if you have a doubt in mind that this particular patient requires biologics, I think it is better to refer to a rheumatologist. So patients who are having aggressive disease with poor prognostic factors, for example, high titers of autoantibodies, high disease activity, and you see there are early erosions. These patients probably require early institution of biologics, and they should be referred to a rheumatologist. Similarly, intolerance to adverse effects, or the patient is not tolerating conventional synthetic DMARDs, and special situations like corneal melt, rheumatoid vasculitis, some patients with RA, ILD. That is, these are the conditions where you would like to initiate biologics early. This is another common, complaint that we come across. In fact, low backache is responsible for 50% of the big four of rheumatology, these conditions that you've seen in this. But fortunately, let us remember that more than 90% of the cases, they are mechanical, non-specific back sprain, herniated disc, osteoarthritis, spinal cord stenosis. These are the causes. Systemic inflammatory conditions contribute to less than 10% of these. So how to differentiate inflammatory from mechanical low back pain? If mechanical low back pain is there, for example, in a herniated disc, it onset may be acute. It can be seen at any age, especially with, even in younger population in this age group when we are sitting for prolonged periods of time. Rest will improve mechanical pain. It will be precipitated by strenuous tasks, for example, weight lifting. Acute phase reactants will be normal. And other features, for example, buttock pain, rib pain, uveitis, peripheral arthritis, they'll be absent. Whereas if it is inflammatory, then usually it will be insidious in onset, patient will be young, more likely to be male, though it is not uncommon in females. Rest will worsen the pain. Patient will usually get up in the night, walk around, and then will feel better. There are no precipitating factors. Acute phase reactants are increased, and other features, extra-articular features, may be present in these cases. So, when to suspect serious disease as a cause of low back pain? Presence of following signs: fever, weight loss, patient pain with recumbency, especially on lying down, nocturnal pain, morning stiffness lying for more than 1 hour, localized bone pain, visceral pain, abdominal pain, age more than 50, if there is a previous history of cancer, especially if there is sphincter incontinence, and if there is neurological deficit. These are the cases that need to be investigated further.
Can I ask you, Dr. Chavla, to wind up?
Yes, sir. Only last 1 or 2 slides. That's it. So another common, thing that is HLA-B27 is advised very frequently. We have to keep in mind that 6% of, especially North Indians, they are positive for HLA-B27. Out of them, only 10%. They are the ones who develop disease. So it is the follow-up is important. And sacroiliitis, I was already told you, is very important. So one gout also, we are commonly coming across certain myths that hyperuricemia and gout are synonymous. So remember, crystal identification is the gold standard. Primary utility of serum urate is monitoring response to treatment. Just like for diabetes, you use HbA1c, use serum uric acid for this. Levels may fluctuate during acute attacks, and it can cause mono, oligo, or polyarthritis. There is no
we
need
leave
to.
some
Yes,
time for discussion.
definitely, sir. Give me just this is last slide. So urate lowering therapy has to be continued. Drugs, you must be careful which are the drugs that are causing hyperuricemia. Thank you so much for your patient hearing.
Thank you very much for giving a bird's eye view of the specialty. And I have a few comments. The first thing that he pointed out was that if you look at the community, non-specific complaints top the list. But by no stretch of imagination should non-specific be equal to non-significant. Non-specific means that you are not able to pinpoint whether it is rheumatoid or spondyloarthritis or a disc disease, but from a patient perspective, it is not trivial. So this is one of the important things. The second thing is that, as he said, rheumatic diseases don't announce their arrival. The patient would more often than not first present to the internist, and the role of the internist is extremely important in picking up the disease early. You need to connect the dots. And I think there are three important things that uh, one would uh, perhaps say that the internist can do. One is early detection. Referrals are needed only if there is a multi-system disease where you are anticipating multi-organ involvement, requires multi-parametric assessment, and you are contemplating biologicals. And it's a symbiotic relationship. The patient can then go back to the physician. So the physician can be the first port of call with occasional inputs from the rheumatologist. Refractory diseases will surely need greater inputs from the rheumatologist. So it's not one to the exclusion of the other. And as he said, it's the team working together, and there is energy in this synergy. Now, comments from the house. Can we have an IL mic, which would be easier? Please identify yourself.
I am Dr. V.K. Gautam, an orthopedic surgeon, and very often I do come monoarticular arthritis in my practice. And sometimes there's a confusion whether it is a septic arthritis or even a pyogenic. So the cell count cutoff values, I think I want a little more elaboration on that, because when we do a synovial cell count, your cutoff was 30,000 and more than 50,000 was infection. Of course, we have to consider many other criteria, but most of the books do not consider this 30,000 to 50,000, but the many literature says that up to 50,000 is also inflammatory. So I'm not saying that this is the ultimate. There are many other things, but what is your view on the cell count for this purpose? That's what I want to ask you.
So usually if you are suspecting septic arthritis, cell counts may be as high as 1 lakh. And in fact, it will be polymorphs, more than 90%. They will be polymorphs. And then ultimately, it is your clinical suspicion. If you are suspecting that you have a focus and you are thinking that it is septic arthritis, you treat even if cell counts are, say, 40,000, 50,000.
Sensitive test. In situations when there is a monoarticular arthritis, and you are really thinking whether it is an inflammatory disease or an infective disease, even before the gram stain, a quick leukocyte esterase, I think I rely quite significantly for this being pyogenic.
Very well taken, Professor Gautam. You are an clinician. I think all inflamed fluids would be intensely cellular. And this cutoff of 2000 for osteoarthritis, I'm not very sure that if there is an inflammation on osteoarthritis, whether the counts will not go up. The reliance is on advanced techniques like cultures or trying to do, gene expert on body fluid, and you have to put everything in totality. I would not be stuck up only on one numerical value.
The situation lies in the fact that if it is acute arthritis, septic arthritis, particularly in infancy, it is an urgency to decompress that joint. We can't even wait for the culture report. So the joint will be destroyed because most of it is cartilaginous, and we have to have something quick to decide. Even a negative arthrotomy, I would say, is not a. This is what I want.
Very well taken. And in reactive arthritis, actually, it's called a pseudoseptic. You just cannot make out whether it is effective. Very well taken. Other comments? Yes, Professor Malviya. I think it would be in the interest of time if we have a IL mic rather than this being where the IL mic could be placed here. It's easier rather than trying to hand over. Sir. Yes.
Okay. My take at infective arthritis is very straightforward. If you ever diagnose infection in a joint, you will have to ask yourself, why am I diagnosing infection? Infection does not occur in the joints. You will be surprised to hear that from me. God has made joints so safe, it doesn't get infected unless there is a reason. So when you diagnose infection, you will have to give a reason. One of the common reasons is people get very busy when everyone else is sleeping in areas that have red lights. There are other reasons like extreme emaciation or extremes of age or underlying damaged joint already existing. Therefore, de novo sepsis in a joint is more often spondyloarthritis or atypical presentation of rheumatoid or gout. Thank you.
Thank you very much, sir. Now we need to wind up this session, and please join me in a big hand to our opening batsman.
Thank you very much, sir, for an informative discussion. It will be a privilege for me to invite on stage our next speaker, Dr. A.N. Malviya, sir, the well-known, the most celebrated. I would request the chairpersons to please introduce him, though he needs no introduction.
Uh, Good morning, all. It's a real privilege to invite such a stalwart and a senior nation. Probably he needs no introduction. Professor Anand N. Malviya is a revered rheumatologist and clinician, not only in India as well as worldwide. Uh, he's a founder member of IIS, one of the earliest members of IRA. He has discovered low-dose methotrexate for treatment of systemic autoimmune diseases, the recipient of several ICMR awards, trained more than 50 students and several chapters in API medicine. I would like to invite him again. And thank you, sir.
Chairpersons,
Sir, one moment. I cannot let this opportunity pass without saying one-liner introduction for my guru. The story of Indian rheumatology starts and ends with Professor Malviya.
thank
The
you.
floor is yours,
Thank
sir.
you. It's a very, chairpersons, very nostalgic feeling to be back at my Karam Bhumi on this stage. I can say 50-50. 50% I gave talks and lectures and CPCs. The other 50% I used to sing. I used to be a singer. And Aja Sanam Madhur Chandni Mein Hum, I sang as a duet with Dr. Prem Chopra right here. So I remember those days when I spent my time here. Without wasting any further time, when I am in difficulty in understanding a subject, so I try to understand and then teach it. That's the best way to learn a subject. Teach it to the students, you will also learn about it. Long ago in D2 ward, a young lupus patient was admitted and she had acute dyspnea. And I was rather perplexed. Why is she having dyspnea? Her heart was okay. She was unable to even talk. And then I went back along with my all the MD students, and we found out that pulmonary hypertension is one of the important considerations in a patient who comes with dyspnea, especially in systemic lupus. And since then, I have liked to teach and learn more and more over a period of time as the new drugs are being found for the treatment of this disease. So, during the next 15 minutes or so, I will try to cover this. Rather difficult, but I will really try to make it very simple. So, pulmonary hypertension is the broad term, but I'm going to localize on pulmonary arterial hypertension, and I will explain it to you in a moment. I have no disclosures for this talk, and I will like you people to remember, maybe she is here, Sandhya Ulukul, one of the brightest young rheumatologists working at St. Stephen. 2 years ago, she gave a talk on pulmonary hypertension, extensive in-depth talk meant for cardiologists and physicians. So using her talk as the background, and she was kind enough to give me the link for that. It's on YouTube, it's available. Then in my own way of thinking about pulmonary hypertension, I have made these slides, which I will share with you. My approach is for a busy rheumatologist in an extremely overcrowded OPD like Sanjeev Kapoor's at Indian Spinal, and he's right there. So this is the crucial slide. And oh, कंप्यूटर पे आ जाता Okay. Now, very simple pulmonary circuit. Everyone knows right heart, then pulmonary arteries, the lung, then pulmonary veins, left heart, and then the systemic circuit from infra vena cava and superior vena cava to the right heart and back to lung. Now, we can divide pulmonary hypertension very easily in the WHO groups. Group 1, that is the area that we are interested in. Almost entirely, I'm going to talk about this area because the diseases, systemic immunoinflammatory rheumatic diseases that we deal with, they affect the pulmonary arteries and arterioles, and that pulmonary arterial hypertension I'm interested in. The second one, of course, is for the cardiologist. It's right there. The left heart diseases, when they put back pressure, the pulmonary artery pressure goes up, but that goes primarily to cardiologists. And I'm not going to discuss that except one passing reference to one disease that we might be interested in. And then we have group 3, because many of the systemic immunoinflammatory rheumatic diseases also involve lungs. And because lungs are involved, that is the third type of pulmonary hypertension due to chronic lung disease, like interstitial lung disease, but more often bronchiectasis, chronic carpulmonale, and other things. So group 3 primarily goes to pulmonologists, but there is a subgroup of interstitial lung disease that we handle. But in them, the major problem is interstitial lung disease related issues. But if you look for that, pulmonary hypertension may also be associated with that. But leave aside group 2, 3, and the fourth one is the showers of pulmonary embolus or microthrombi from the rest of the body entering the right heart through superior or mainly inferior vena cava due to DVT in the legs or in the pulmonary, in the pelvis area. That is also not of our interest, except one disease. If antiphospholipid syndrome antibodies are positive, look for showers of microthrombi, and that may be causing pulmonary hypertension. So I'm back to group 1, and type 1 majority remains idiopathic for the general physicians. But for us, all those conditions that we deal, systemic lupus, systemic sclerosis, and others related diseases, we are dealing with group 1, which affects the arteries and arterioles of the pulmonary circuit. And it is shown clearly in group 1 here. There are other conditions also that can involve the group 1 pulmonary artery and their arterioles, but let us stick to the diseases that we are dealing with. And that, sorry. And this one is the one that we are interested in. Forget about pre-capillary and post-capillary, and don't confuse yourself. Just let us look for this. There are many other causes also that I will not be discussing. And so out of hypertension in this circuit, which could be here, which
The background is so bright that
anyway, you can see group 1, group 2, group 3, or group 4. Let us go to group 1, which is called, among the broad spectrum pulmonary hypertension, this is group 1 pulmonary arterial hypertension. That's our area of interest. There is a group 5, which I will not be discussing, rare diseases, cause not known, mechanism not understood. So group 1 is the one that we are interested in. In group 2, that is left heart, only one disease, myocarditis. So forget about it. To even diagnose myocarditis in our diseases, we have to take the help of cardiologists. Group 3 is the commonest interstitial lung disease, but the pulmonary hypertension there, we are not interested. If you treat interstitial lung disease well, pulmonary hypertension also improves. The group 4, the showers of microthrombi, antiphospholipid is the only one of our interest. do a VQ scan, and you can make a diagnosis, and you start treating. So let us now go to pulmonary arterial hypertension, pulmonary artery and arterioles. And when the patient comes with dyspnea in our clinic, what and how clinically we say, is it interstitial lung disease or is it pulmonary hypertension? Because these are the two common causes of presentation of patients with systemic immunoinflammatory diseases in our clinic with dyspnea. Only two conditions. And then we have to take the help of our cardiology colleagues to establish pulmonary hypertension. And I will not worry about this slide because this is meant for cardiologists who do right heart cath. So forget about it. Look at this. I will like to hear from them that on doing right heart cath, Dr. Malviya, your patient has pulmonary pressure which is equal or more than 20 millimeters of mercury. Here we go. We got it. This patient has pulmonary arterial hypertension, and this is gold standard for diagnosing pulmonary arterial hypertension, not echo. Even echo Doppler does not correctly estimate the pulmonary hypertension as estimated by right heart cath. And the cutoff point used to be 25, now it is 20. Remember, anything above 20, we have to pay attention to the patient because the lifespan will be cut short if we don't catch early and treat appropriately. Method of measuring pulmonary arterial, it's a right heart cath. But once you have made the diagnosis, in the follow-up, you can use echocardiography with Doppler. They can give you some estimate whether you are on the right path, patient is or is not improving. But if you want to change the medicine, that it seems that the patient is not responding, and you are going to change the medicine, again, you will have to take the help of cardiologists for right heart cath to tell you precisely whether the pulmonary hypertension has gone up or has gone down, and then you decide on changing, adding, subtracting the drugs for treatment of pulmonary hypertension, arterial hypertension. Now, the workup. Let us see the patient comes to the ward. One of them says, I'm dyspneic, but in addition, patient has hacking cough. And when you put your stethoscope at the bases of the lungs, there is velco crepitation. Everyone will make the diagnosis, straightforward interstitial lung disease. And what will you do? You will do the usual pulmonary function test. You will do a chest radiograph, and you will then confirm with high resolution CT. And you will say, this is ILD. And I'm not going to discuss that because ILD may have pH, but we don't treat that separately. We basically treat ILD. So this patient had dry hacking cough with dyspnea, not pulmonary arterial hypertension. Diagnosis, most likely ILD. The next patient is dyspneic, not having cough, no other reason for dyspnea that we can find out. But on examination, there is accentuated P2. Very much indicative that is it possible that the patient is very sick. Young lady doctor from Jaipur 3 weeks ago came. I can't breathe, doctor. I have been diagnosed lupus. Oh God. All the cardiologists, right heart cath must be done to see what is the pulmonary hypertension level. To cut the long story short, she had severe pulmonary hypertension. We have advised her what is to be done. Accentuated P2, then we will not do echocardiography. We will go straight to the cardiologist. You can do ECG and echo and suspect, but finally give me the exact answer by right heart cath. And if you are doing right heart cath, please give a little bit of nitric oxide also to see whether it is reversible. Why? Because if the pulmonary circuit can get dilated, you can give calcium channel blockers for immediate relief. But the majority of those where there is a proliferation of a smooth muscle and narrowing of the lumen of pulmonary artery and arteriole, there will not be reversibility with nitric oxide. And if you have that, that is the type of patient who needs now treatment that I'm going to discuss in the next 5 minutes. Dilatation test with nitric oxide negative. This is, we need real pulmonary vasodilators, which will change the structure of the pulmonary arterioles, where smooth muscle proliferation has increased and lumen has gone down. We have to reverse that process. So, number two is the left heart. We will not bother. We will send them. They don't come to us anyway. They go to cardiologists. Chronic thromboembolic, majority of them will go to vascular surgeons, except pulmonary, the antiphospholipid syndrome. If that is there, we will have to then go back to cardiologists and find out and do VQ scan to see whether it is showers of emboli. And none of the above, I don't deal with that. So here is a patient who has been now proven. She came with dyspnea. I didn't find any Velcro crepitations, and she had no cough. What she had was only dyspnea, and her diagnosis was lupus. And when I examined her, her P2 was accentuated. I suspected pulmonary hypertension. I sent her to cardiologist. They did ECG, and there's right heart, right axis deviation, right heart dilated. And the echo confirms that there is some pulmonary hypertension. But I insisted upon right heart catheterization to know the exact millimeters of mercury, how much is the pulmonary hypertension. It was 35. That is really bad. And she needed treatment. How to choose the drugs? There are so many of them and so many classes of them. Let us see. There are 3 major classes and 5 groups of drugs. Endothelin pathway is the one, nitric oxide is the second one, and prostacyclin is the third major group. And this slide is taken from a very famous paper in Nature Review Cardiology. And we suppress the endothelin pathway, and I won't go in detail because these are receptors. Endothelin is produced by endothelial cells. It goes and occupies receptor A and B, and we can stop that combination of endothelin with its receptor using drugs that are already mentioned. If it is selective only acting with receptor A, it is ambrisentan. If it's a dual active, we have bosentan, which we cannot use because of liver toxicity. And mesetantan is the more superior one because it is dual activity. It is blocking both receptor A as well as B. So these are the drugs that are available to us. 3 drugs within this class, and we can choose any one of them. And then we go to the next one. Here is soluble guanylate cyclase stimulator, and we will like to stimulate it even further so that the vasodilatation reaches its full capacity. And on the other side, phosphodiesterase 5 is the enzyme that needs to be suppressed so that it doesn't cause constriction. So first group of drug, you suppress. Second, you stimulate. Third, you suppress. And the fourth group is the prostacyclin analogs, or now we have agonists. So you can stimulate that one. So we have basically 3 groups of drug and 5 different categories of drug. This is a nice slide, but I have not used it. Similarly, you can make your own slide using this one, which is superior, but I had already made the previous slide. So now we have prostacyclin pathway stimulator, antagonists, and nitric oxide. So we have now endothelin receptor antagonist and nitric oxide. In prostacyclin pathway now, we have receptor antagonist, selexipag, the first oral drug in the group of prostacyclin pathway. So instead of giving intravenous, we can use oral in the first category of prostacyclin pathway. In the endothelin receptor antagonist, we have 3 drugs and we can choose among them. And then in the last one, nitric oxide, PDE5 inhibitors are the one which is available. The older one, sildenafil, and now tadalafil is much more popular. So these are the drugs, but now already I have given the name of 5, 6, 7 drugs. How to choose which combination, which patient, how to categorize, that will be next 2 or 3 slides. Which one and how to choose them. And here comes what we call assess the risk of the patient and then choose the drug or drug combination. And what are the tools that are available to us to stratify patients? The low risk patient, up to 5% chance of death within 1 year. We don't really have to treat. You treat the underlying disease, the patient recovers. But if it is more than 10% chance of death within the first 1 year, then we have to immediately start treatment. And in some of them, it's an emergency, and intravenous drugs will be needed. Risk assessment tools. The old one is the WHO one, which I will show you. The more recent one is the Reveal 2. But the latest after 2021 is the one which we are using in our clinic now. It is non-invasive, simple to perform in the OPD, and I will show you that. Here is the WHO, no limited activity, slight limitation, marked limitation, severe limitation. The last two, marked and severe, need immediate treatment. The last red one needs emergency treatment with intravenous drug. Now, this is the Reveal registry. By the way, the previous one was used in the famous Ambition trial, 2015, published in New England Journal of Medicine, which gave us the two drugs which are the biggest selling drug in the world at that time. But now we have superseded that, and I will be using Reveal registry. And here you have these items listed there, plus minus. You go to get the total sum, add 6, and you get certain figure, and that figure will tell you what is the risk. 10-year risk will be decided on that based upon this. So if the score is 0 to 6, don't worry, treat the underlying disease. More than 7, intermediate risk, you can be slow, you can give oral drugs, you don't have to admit in emergency and give intravenous drugs. But if it's 7 or 9 or more, you will have to admit that patient and start alprostadil or one of the prostacyclin analogs in ICU. This is the one we are using now in the OPD. Non-invasive, functional class, systolic BP, heart rate, 6-minute walk distance, a brain natriuretic hormone level, and renal parameter. These 6 things will give you figures like this. And if the score is between 1 and 5, don't worry. Treat the underlying disease. More than 6, start the oral treatment. More than 8, you go for, more than 8, admit the patient in ICU and start intravenous alprostadil or one of the prostacyclin analogs. So the initial treatment based upon the intermediate or severe risk. This is the the typographical error. This 2015 famous paper, I'm sure most of you have read. This paper was really so-called hahakari paper. This combination of tadalafil and ambrisentan, even the drug companies have made a combination tablet, which many of you have used on your patients, and this is widely being used and highly recommended. However, now we are in 2022, and things have changed. These are Griffon study and Triton study. Both of them, they say that is old, that will keep on killing the patients despite dual drugs. And thus we have now high risk and Reveal trial. Although it said that you use only 2 drugs, now triple drug has become the norm. And from today onwards, if you have an intermediate risk patient, you will have to start them on macitentan, more pedal edema though, deoxyguat, plus selexipag. Triple drug therapy is now the norm to control intermediate pulmonary hypertension in your patients with systemic immunoinflammatory disease. This is the way you can mark them because the time is over. So in the olden days, the red one, the green one, 2 were used, but now we will shift over to the 3 in red color and combine them to start treatment. I have given all the references also. Remember, never prescribe more than 1 drug within the same group, and these are the 3 major groups shown there already. This is for the fellows and those who are in DM and DNB to remember the drug and how to give them. I don't remember. I always check with that, so I will not go in detail. In conclusion, endothelin pathway, nitric oxide pathway, and prostaglandin pathway, all the 3 should be suppressed or stimulated as the mechanism is to get the sufficient control, satisfactory control of pulmonary hypertension and save death. These are the references, and thank you very much.
Thank you, sir. Can I start with one of my own queries? And then it will be open for question. So just I wanted to ask when should we refer the patient for RHC? Is the doubt which always remains.
Right heart cath.
Yes, sir.
I will do it the moment I wish to confirm the diagnosis to start treatment. I already mentioned that. So at the time of starting the treatment, you have to be sure, because recently we saw a doctor who came walking, laughing, very nice. He said, I have high pulmonary hypertension. I said, rubbish. No, my echocardiogram has shown. We got the right heart cath and Kapoor knows the detail. There was nothing. Her pulmonary pressure was normal. So please, always before you start treatment or make a diagnosis, you must request the cardiologist to do right heart cath. There's no alternative to that. Right heart cath only in follow-up for a rough idea whether I'm on the right path or not. And again, if the drug is failing and you want to see whether really drug is failing, you will have to do right heart cath to see the pulmonary pressure.
Yes, sir.
Kapoor Saab is my teacher in this area and he told me, ये मैसे टेंटान से बहुत होती है आप क्यों लिख
Sir, excellent talk.
really my guru.
No, sir. Excellent talk, sir. I mean, as we have discussed also, like, I mean, the fifth category, that is the idiopathic sarcoidosis. We have seen few cases of sarcoidosis where idiopathic pulmonary hypertension was diagnosed.
Yeah, Kapoor, you say what
Yeah.
happened? Why I didn't, it was shortage of time. Was
Yeah,
there.
yes, sir.
But I
agree.
think sarcoid involving pulmonary, I will refrain treating them because I'm a rheumatologist. I would like to treat sarcoid with joint disease. But you are right, in case by chance any patient comes, I
We
will
have-
ask the pulmonologist to please get involved and then treat along with.
Second thing is that in most of our cases, I mean, it is in 40 to 50% of patients, it is the ILD with pulmonary arterial hypertension
Surely,
dual.
surely.
Because dermatomyositis and scleroderma are the two where pH is also there. So we have to combine the two modalities, that is basically DIPIN or
fully agree.
MDIPIN.
I mean, if you are thinking that the treatment of the underlying disease is not achieving the ideal outcome, you may definitely go for at least do the Doppler echo to get some idea, and then if it shows something, go ahead. Sure.
Thank you, sir.
There is the IL mic.
Are Chaturvedi ji.
Problem is the right heart cath. I don't know who are the cardiologists sitting here. They are so busy in doing the angio. Hardly anybody agrees for right heart cath.
Indian
So-
spinal.
so
Our
what to do?
cardiologist really said, sir, आप कहोगे तो हम उसी वक्त कर दें.
A few points. One is that, as Dr. Kapoor said, sarcoidosis as a cause of pulmonary hypertension is now the leading cause of death in sarcoidosis and not ILD any longer. So we must recognize that. Second is that, as you said, echo is a very, very unreliable tool. We must not only depend on echo, it can both underestimate and overestimate. The third important thing is that when we are treating pulmonary hypertension, there has to be very little scope for tolerability. We have to treat very aggressively and we have to treat to target. Now, let me tell you what is the target. The target is an NYHA class 2, a 6-minute walk distance of at least 400 meters. Unfortunately, the Griffin trial has now shown that even NYHA class 2 is not good enough, because in the patients who were in NYHA class 2, almost 40% of them ended up with hospitalization. So it's very important to understand that a very rigid control over NYHA 6-minute walk distance is very important. What we utilize is the Australia Scleroderma Interest Group, the Asig algorithm, which is very simple. Look at the FEC DLCO ratio. If your FEC is less than 70% and the FEC DLCO ratio is more than 1.8, then you're dealing with a suspected pH. And if your NT-proBNP is more than 210 picograms per ml.
You are
So,
absolutely. You see, I mentioned this in Reveal Light 2. It mentioned 6-minute walk time, and in our hospital we have the measured thing, and we keep doing it all the time. In addition, systolic BP, heart rate, and brain natriuretic hormone. If you can do that in between, and Kapoor really does this exactly as such, it is slightly better than WHO class, which was recommended in the past, and I think we cannot use it now that we have better instruments. Arterial.
Sir, I wish we could have listened 1 hour to you. Sir, two questions. First, any role of immunosuppression in isolated pH in case of chronic disease? Second,
Let me answer that. I have not read any paper, but I think Prasandeep Rath has something.
Only one role of immunosuppressive in pulmonary arterial hypertension, and that is lupus. And we have the paper from NIMS by Dr. Lisa. So we have a series of patients who have used cyclophosphamide in these patients because we believe that it's not just simple intimal fibrosis, unlike scleroderma where it doesn't have a role. But in lupus, you probably have a small vessel vasculitis going on. But in scleroderma and any other disease, there's no role of immunosuppressive. However, if you look at the FARO study, it showed that those patients who were on mycophenolate mofetil surprisingly had less pulmonary hypertension as compared to those who were not. So the FARO study reflects, but there's not been any study to suggest that we know mycophenolate has anti-fibrotic action as well, but it's to be seen whether it really helps. But as of now, other than lupus PH, there is no role of immunosuppressive.
First, the remodeling of the
No, sir.
arterioles.
No, but in lupus, there is a small vessel vasculitis. So NIMS has produced a series of lupus PH where we have
Thank you
used
for
cycling.
telling that. I mean, I was not aware of that because it's a remodeling is the issue, and whether that will act as remodeling. That
I used in lupus, sir. Patient was referred for lung transplant. pH was 100. And now last visit, her pH was 30. So I use MMF. Second question, sir. Any chances of developing pulmonary edema with IV prostacyclin? I've seen one actually. Easily.
So the key is that if you develop pulmonary edema when you're giving prostacyclin, these patients have pulmonary veno-occlusive disease, PVOD. So the key of picking up PVOD, and PVOD is a great mimicker of PAH. The way to pick up PVOD is when you start giving them vasodilators, they start developing pulmonary edema.
That's group 4 you're talking.
Sir, as you said, that of course, gold standard is right heart catheterization. But as Dr. Rath has said, that if the pulmonary function test is showing FVC, DLC ratio more than 1.8, patient pro-BNP is significantly raised, and the patient is having features of right heart failure, NYHA classification 3 or 4, then what to do in those cases where...
I tell you, we have all known that right heart cath has been a problem, and we all use these parameters and somehow have been managing. But over a period of time, with better drugs available, with high efficacy, I think now we have to insist with our cardiologists and convince them that they have to help our patients. That is now our stand. Unfortunately, we have a very cooperative cardiologist who is helping.
Unfortunately, to overcome this problem, Dinesh Khanna and we made an algorithm for India, minus the right heart cath. Unfortunately, that has not been published for various reasons, but we made a very nice algorithm. I'll send it to you. For Indian standards, where the recommendation is that to repeat an echo twice from 2 different people because of the subjectivity, to do the NT-proBNP, and based on that, minus the right heart cath, whom to treat, whom to not treat, and where to do a right heart cath. So a lot of patients can still be treated even without doing a right heart cath. Only a selected sub-few would need a right heart cath. I'll send that.
That will be great.
I'll send.
Let it get published for.
Thank you so much, sir, for giving me this excellent, scintillating and revealing talk on this difficult topic. Teacher of teachers can make this.
Thank you. Welcome.
Thank you very much, sir, for such an informative and enlightening talk. Moving forward to the next session of today's program, which is on drug review in immune-mediated rheumatic disorders. We have chosen the 2 most frequently used biologicals, JAK inhibitors and rituximab, for today's discussion, which are being used left and right in various autoimmune diseases these days. Markets are flooded with various manufacturers pitching in, resulting in reduction of costs of these drugs. The discussion is directed to get more clarity on the issues like efficacy, safety, when to use and when not to use. So may I request the first chairperson of the session, Dr. Priyanka Kharbanda ma'am, to please come on the stage. She's a senior consultant at Fortis Shalimar Bagh, has various national and international publications to her credit, been a winner of EPLA 2010 scholarship as well. It'll be my pleasure to invite on stage Dr. Souvik Das Gupta, sir, to chair this session along with Dr. Priyanka Kharbanda. He's currently working as a consultant rheumatologist at Yashoda Super Specialty Hospital, Kaushambi. He's been a senior resident in rheumatology department at AIMS as well. He has numerous publications in his various journals, wrote various book chapters. Now, may I please invite the speaker of upcoming talk on JAK inhibitors, Dr. Sameer Gulati, sir, on stage, and I would request the chairpersons to kindly introduce him.
I welcome Dr. Sameer Gulati. He is professor in VM's Medical College and Safdarjung Hospital. He has 15 years of experience in rheumatology and critical care medicine, and he is a certified EOLAS course in rheumatic diseases and musculoskeletal ultrasound. He is also the member of editorial board of national and international journals. Over to you, sir. He has many publications in books and international and national journals.
Thank you so much, ma'am, for the kind words. A very good morning to the respected dignitaries on the dais, my respected seniors, my colleagues, and dear friends. The topic that has been assigned to me is to take you through the evidence-based review on the emerging data on safety on JAK inhibitors, particularly for the tofacitinib and baricitinib. So, as it was rightly introduced that this particular group of drugs had created a lot of excitement amongst the rheumatologists and the patients alike. Because of the oral drugs, they could be used easily, and everybody was looking forward for it. And it was in 2012 that FDA gave approval for the drug, and we have almost come 10 years far from the approval that was initially granted for 5 milligram twice a day tofacitinib for rheumatoid arthritis. Subsequently, it has received approval for various other rheumatic diseases as well, such as psoriatic arthritis, ankylosing spondylitis, and there are now fairly advanced trials going on as far as SLE is concerned, and even for scleroderma and for large vessel vasculitis. So, have the initial excitement caused the initial excitement caused by the very good efficacy of these drugs, does that still remains given the safety data that exists now over 10 years? Has the safety data now changed over the 10 years or not? So please permit me to take you through that journey. So because the very fact that it was efficacious because it was blocking the JAK inhibitors has now is the reason for the safety concerns for this drug. Fortunately for us, most of the events are non-serious and ranges from nasopharyngitis, upper respiratory tract infections, headache, nausea, diarrhea. But then there are concerns regarding infectious complications such as severe infections, viral infections. Out of that, herpes zoster virus stands out and has been the concern for all of us. Tuberculosis, especially for a country like ours, where the baseline tuberculosis risk is so much, and then the fungal infections. Malignancies cannot be forgotten, and that stands very solidly amongst the expected complications for the JAK inhibitors. The cardiovascular complications, namely thrombotic and thromboembolism episodes, and the lipid disorders, cardiovascular disorders in the atrovascular sclerotic disorders in particular, had also created concern amongst for this group of drugs in the initial data that was presented at the FDA before its approval in 2012. So I will just take you through these evidence as of now, and then we can decide for ourselves that how safe these drugs are. What was the evidence trail? Well, the evidence trail ranged from the initial JAK inhibitor development program, which included the phase 1, 2, 3 randomized controlled trials, the data that was generated out of that, the safety data, and then it was followed up by the observational studies, which ranged from the like the cohorts like the US health plans, market scan, US corona rheumatoid arthritis registry, and also the long-term extension studies, which were continued from for the patients who were initially included in the randomized control trial, and the recently published oral surveillance trial, which was published in the very important journal of repute, that is New England Journal of Medicine, in this year only, that gave us a very good insights as far as the malignancy and the cardiovascular complications are concerned. So quickly, let me begin with the infectious complications, namely the herpes zoster. So before I'll take you through the data of the herpes zoster, like the various incidence rates and the standardized ratios. It is very important for us to understand what is the baseline risk of herpes zoster in the general population per se, and then in the rheumatoid arthritis group. So as far as the general population is concerned, it is perceived that approximately 1/3 of the general population will develop herpes zoster in their lifetime, the annual incidence rate being somewhere between 0.4 to 1.1 per 100 patient years. And especially the risk group belongs to the age group of 50 to 80 years, and the highest rates were seen in women. Approximately 10% of these patients will develop post-herpetic neuralgia. When we talk about rheumatoid arthritis, they are obviously have a higher risk of herpes zoster, and that might be 2 to 3-fold higher. And that might be related to the activity of disease or the immunosuppression that this group of patients are subjected to. When we add the risk of the oral glucocorticoids or the DMARDs or the TNF-alpha antagonist, but obviously the risk increases additionally by about 1.5 to 2-fold higher. And the biologicals, like the TNF-alpha, amongst the TNF-alpha antagonists, it is perceived that there are difference existed between monoclonal antibodies and the etanercept, but the studies have been shown a mixed result in that. To answer the demographics of the tofacitinib and herpes zoster, this was looked up, and Winthrop et al. Then collated all the studies, phase 1, 2, 3, and the long-term extension studies, and then which included about 4,789 participants. There were mostly 239 episodes of tofacitinib-associated herpes zoster. Most of them were females. The median age was ranged from 57 years. The incidence rate that we see here, the total incidence rate was around 4.31 for tofacitinib overall, which in comparison to the TNF inhibitor adalimumab, which had incidence rate of 2.81, is definitely on a higher side. And this also showed that amongst the two groups, that is 5 milligram and 10 milligram of tofacitinib, the incidence rate was almost similar. However, a sub-analysis in the same study showed that initially in the first 3 months of the treatment, the difference rate amongst the dose groups may differ, and it may be as high as 5.2 in the 10 milligram BID group as compared to 2.1 in the 5 milligram BID group. There were differences in the regional wise also, and the higher incidence rates were seen in the Asian countries, the highest seen in Japan and Korea, and India was not far behind with an incidence rate of 8.9. Fortunately, the severity of herpes zoster infections was not of the concern here. Most of the cases were not multidermatomal. Only one case, that is 0.4%, was multidermatomal, and there were no viscerally disseminated disease or death. And only a few handful of patients were hospitalized or they received intravenous antiviral drugs. When the regression analysis was done, then the important factors which stood apart were just the age and the regional difference. That is, the Asians were more prone to get herpes zoster in comparison to the Western population. When we talk about the additional risk conferred due to the addition of glucocorticoids or the DMARDs, I would like to point out here that the odds of 0.56 in groups having tofacitinib 5 milligram BID without DMARDs or without glucocorticoids rises 10-fold times in a group which has a tofacitinib 10 milligram BID with DMARDs and glucocorticoids. So definitely there was a difference when there was either the dose of the tofacitinib increased from 5 to 10, or there was addition, they were given along with the DMARDs or the glucocorticoids. The risk increased almost 10-fold times. Now, the thing that we have understood so far is that in presence of any infection, the DMARDs should be stopped. But strangely enough, when all these studies were collated and a sub-analysis was carried out, most of these patients either continued taking DMARDs, namely the tofacitinib, or the dose was decreased. And it was found that the outcomes vis-a-vis the time to resolution of the skin leak of the herpes zoster was not very much of concern. So there was not much difference between the groups, which either continued the drug, they stopped it, or they decreased the dose. But the very important takeaway point here is that almost all of them were on antivirals. So if they are on antivirals, the results were very good, and the time resolution was not very much different, both in the rheumatoid arthritis group as well as in the psoriatic arthritis group. As far as baricitinib is concerned for the herpes zoster, since baricitinib received approval only in the year 2017, so we do not have much of long-term extension studies here. But when the phase 1, 2, 3 studies were collated, and with a total of 3,492 patients, the incident rate came out to be around 3.3 per 100 patient years with 170 events. And fortunately, even with baricitinib, there was not much of multidermatomal involvement or much of visceral disseminated herpes zoster reported. So there were not very serious cases of herpes zoster even with baricitinib. More data is being collected, and probably they will shed more light to it. Coming to tuberculosis. Now, tuberculosis is an infection which raises our concern amongst all of us, amongst the internists, among rheumatologists, for the patients alike, because of a very high baseline prevalence rate of tuberculosis in our country. And the tofacitinib per se also, by virtue of the basic sciences hypothesis, it's very much possible, biologically plausible, that tuberculosis can occur because of the concurrent administration of tofacitinib, because it reduces the containment, promotes bacterial replication, inhibits both the adaptive and innate immunity. And it can increase the baseline risk of 5 to 10% risk of LTBI reactivation to a higher percentage. So what does the data show? The data, when we looked into the studies and did a meta-analysis, then the JAK inhibitors versus placebo, the odds ratio was to the tune of 2.66. So definitely tofacitinib was increasing the incidence rate of tuberculosis in the population. And when it was compared with other biological drugs, the incidence rate of JAK inhibitor of about 0.2 lies somewhere in between that of the TNF inhibitors, which are on a higher side, the average being somewhere around 0.47 to 0.35. And on the lower side, we had tocilizumab with an incidence rate of 0.08. So the risk of having tuberculosis with tofacitinib was somewhere in between the risk of the other commonly used biologicals that we use in our clinical practice right now. The meta-analysis study also showed that amongst all the opportunistic infections, tuberculosis was the most common opportunistic infection. And most importantly, what I want to stress here is that the median time between drug start and diagnosis was 64 weeks to about 9 months. And what does it show? It shows that the concern here is not the LTBI reactivation. On the other hand, it is the primary infection that causes the tubercular infection with LTBI. But another point that I want to stress here is mostly this is the Western data. In our population, it might be a little different. Similarly to the herpes zoster, the higher risk of tuberculosis was found in regions with high background TB. And in higher regions, the incidence rate was about 0.75, in the low about 0.02. The meta-analysis also confirmed that the 10 milligram dose had a higher risk of causing tuberculosis in comparison to a lower dose of about 5 milligram with an odds ratio of about 7.39. What was very heartening was that whichever patients of LTBI that were screened before initiating tofacitinib, they responded very well to isoniazid and tofacitinib therapy, and almost none developed active TB in this group. So it is recommended that screening for patients for LTBI before initiation of tofacitinib should be carried on, and that can reduce the risk of active tuberculosis by about 90%, sorry. And these patients should then be monitored serially at least once a year. So whoever tests negative for LTBI, they should then be serially monitored. Another very important thing that we should realize here is that amongst the various regimens that are available to us to treat the LTBI, rifampicin should not be selected, because rifampicin drug-drug interaction exists between rifampicin and tofacitinib, and there can be 80% reduction in bioavailability of tofacitinib, and we might fail to control the activity of the disease. And failing to control the activity of disease is not a very good option available to us, because that can then complicate various other matters. Periodic liver functioning should be conducted during this therapy, because tofacitinib and isoniazid both can cause problems in the LFTs. Coming to malignancy, the baseline risk of patients with rheumatoid arthritis, the overall risk is not very high, with pooled standardized incident ratios of about 1.09. But I would like to point out here that the risk of lymphoma is towards the higher side in these category of patients for obvious reasons, which ranges, which the absolute one is 2.46, for Hodgkin's 3.21, and for non-Hodgkin's is 2.26. So definitely that is on a higher side in comparison to the general population in the group that is rheumatoid arthritis. So even in the arthritis advisory committee, when the data was presented, the incidence rate increased from the first 6 months to after 6 months from 0.79 to 1.93, indicating that obviously the incubation period for malignancy is more, so shorter duration studies will fail to pick up the development of malignancies, and what we need is long-term extension studies and longer surveillance data to make to conclude effectively in this. The overall risk incident rate of this malignancies with tofacitinib was around 0.94, which was comparable with other biological drugs, and there was a certain difference between the doses of tofacitinib between 5 milligram and 10 milligram. So that difference seemed to be significant between the doses as well. The meta-analysis, when we looked into the meta-analysis, amongst the demographics, the most common cancer was lung cancer, followed by breast cancer, lymphoma, gastric cancers, non-melanoma skin cancers, gynecological malignancies, prostate cancer. All of these were documented in the cohort of patients who were receiving tofacitinib, the most common being lung cancer. But now, this particular table is summarizing the standardized incident ratios of these malignancies in rheumatoid arthritis patients who were receiving tofacitinib. And what we notice here is that the standardized incident ratios are not very much different from those of the baseline RA population. So what I mean to say here is that though the risk of malignancies is on a higher side in group of patients who were receiving tofacitinib in rheumatoid arthritis, they are not very much different from the patients of rheumatoid arthritis who were receiving either biologicals, other DMARDs, or they were not receiving anything. So the risk was almost comparable. Okay. As far as baricitinib is also concerned, since we do not have long duration studies, and data pertaining to only 973 cases, there are just 2 reported cases of non-melanoma skin cancers. And so far, no patients have been reported for solid tumors, but it is too early to make any conclusion in this. And probably the data which is being collected in the surveillance studies will shed more light onto this particular question that might arise in our minds. Now, this was a landmark study, oral surveillance study, which got published in NEGM this very much year, and this showed that the risk with tofacitinib was definitely higher than the anti-TNF TNF inhibitor drugs. So the hazard ratio which they reported was to the tune of about 1.48 for the combined doses, and almost similar hazard ratio for the two doses, 5 milligram and 10 milligram doses. So this particular study hence still puts a question mark that whether tofacitinib is safer when we compare it with anti-TNF inhibitor, and probably that red flag still remains, and we have to be on a watch out and collect more data to answer this particular question. Lastly, coming to the cardiovascular protection, this the initial belief was that tofacitinib might give protection to the cardiovascular protection because of its property to reduce systemic inflammation. And certain studies also confirmed that there was a decrease in CIMT, and also, though there was increase in all the components of cholesterol, the predictors of CV events, that is TC by HDL ratio, remained unchanged because both total cholesterol and HDL increased. So with that in mind, the data from all the registries were collected, and the data was extracted for about 4 to 5 years time period, and it was found that all the major adverse cardiac events, there was not much of difference between when we were giving tofacitinib or we were giving biologicals. Similarly, with episodes of venous thromboembolism, DVT, and pulmonary embolism, there was no much difference was found when the data from the US coronary registry was evaluated for these outcomes. Even the meta-analysis surprisingly showed that there was no risk of just two minutes. So there was no more risk of cardiovascular events with tofacitinib. In fact, surprisingly, they showed that there was a better outcomes with 10 milligram of tofacitinib. So why was this difference coming on? This was because probably the incubation period to develop cardiovascular disease was not good enough, was more, and it was not getting picked up by the RCTs. And rightly so, the study A3921-133 then pointed out that definitely there was a difference between 10 milligram and 5 milligram doses, and there were more cardiovascular events with 10 milligram doses, and hence the black box warning came up in the year 2019. Consequent to it, again, the researchers went back and collected data, more of data from the observational studies as well as from the RCTs, clubbed together. All possible observational studies were picked up in this particular study. And then also there was no difference was found out between the incidence rate, between the in the occurrence of cardiovascular events with tofacitinib. But what came out very beautifully here was that when they stratified the data further in the sub-analysis, and then they found out that the patients with cardiovascular risk factors were more likely to experience thromboembolic events than those without. And the incident rates in patients with risk factors were very low in patients who had lower risk factors. So this particular thing stood out, and this was again highlighted in the oral surveillance study, which got published in just now. And this study was by and large a non-inferiority randomized controls trial. And as I pointed out, with reference to the malignancies, other than malignancies, they also found out that the risk of major adverse cardiac events were more in tofacitinib when compared with the anti-TNF agents. So to summarize, what I mean to say is that probably the red flag still remains, and we have to be on a lookout as far as the malignancies and the cardiovascular events are concerned, and probably continue our surveillance program. And meanwhile, what has been suggested by FDA and EMA seems to be good enough. That is, these drugs should be started only in patients who fail to do well in our preliminary choice of conventional synthetic DMARDs, and should be started only in patients after screening them out for the cardiovascular and the venous thromboembolism risk factors. So we should screen them and only start them on only those patients who do not have these risk factors. So I'll just skip that. Tofacitinib and baricitinib, there is not much of difference.
We'd like to keep some time for discussion on this.
Yeah. So to summarize, yes, tofacitinib is a very safe drug, and we can it is a very promising thing. Being oral, we have come so far for 10 years. We have been using it, and most common reported adverse events are non-serious. But with the recent red flags, which has been raised by the oral surveillance study, we should be a little bit cautious and use them in patients who do not do very well with the conventional synthetic DMARDs after carefully ruling out the underlying risk factors.
We'll take one or two questions.
Only one comment. Thank you so much for bringing up that tuberculosis thing in tofacitinib. I think this is exactly what I was discussing with Dr. Uma. In one of the IRACON meetings, we had this discussion, and one of the rheumatologists from the south said, well, why should we do latent TB screening? So please understand, just because a drug is cheap does not mean it is safe. latent TB screening must be done. And as you've shown, the odds ratio is so high in a Western population. In our country, it would be perhaps even more. And I've seen tuberculosis in my patients of TOFA. Thank you.
Take another question.
I have a comment. The prevalence of latent tuberculosis in our country is 40%, if not more. So every person you screen, the chances are 4 out of your 10 patients, bioeligible patients or targeted treatment eligible patients, would be latent TB positive. And that is the surest way of turning them away from uh, rheumatologist to alternative medicine, because they start believing कि आपकी दवा से हमें टीबी हो गई है. And I'm not very sure we need to have a multidisciplinary meeting for this with a high background of 40%. I mean, who should be screened, how they should be screened, and how they should be treated, and the frequency of screening. I mean, it's a matter of debate, but the first thing people say is that it's very difficult to explain to them that latent tuberculosis is not tuberculosis. And now I've started telling them that 40% people will be positive, so don't get surprised.
The art of medicine and the science is different. But let me talk just about the science today. Art is, I agree, there may be compulsions when you're practicing. But the logic is that we must give them, and if 44% are positive, then 40% receive the prophylaxis. That's why if you look at the Australia Rheumatology Association guidelines for latent TB, they clearly treat based on the risk factors. And any patient coming from South Asian country is a high risk. So already they are on, because the risk to benefit ratio has to be seen.
The data also, sir, the very fact that patients who were treated for LTBI did very well. So that is very encouraging. So I think the take-home message for all of us here is that screening for LTBI has to be done. And if they come positive, they should be treated with INH in this particular instance for 9 months. And the tofacitinib can be started after 4 weeks of INH. And then, I mean, they can have very good results. And we should not forget about the risk factors from the patient's perspective also. So like alcohol, malnutrition, and all those things should also be figured in, factored in.
Thank you, sir, for covering the infectious complications. Could you please shed light on the interaction of tofacitinib with hepatitis B as well? For example, with herpes zoster and TB, latent TB, we know, but there's been significant with hepatitis B as well, with some reactivations being reported.
Yeah.
So if you could please.
So thank you very much for that question. I did not include it primarily in my talk because of the time factor. India, definitely there is a high prevalence of hepatitis B, and that remains our concern. And before starting tofacitinib, the workup that needs to be done is to rule out the viral infection, chronic viral infections as well. So we will be doing hepatitis B surface antigen. But and if they are positive, they should be treated for the hepatitis B for 4 weeks, at least 2 to 4 weeks before initiating tofacitinib. And the therapy for hepatitis B should be there for at least 6 months after stopping tofacitinib. So that much precaution we have to take. One very important thing that we should realize here is that the data shows that even the carriers, that is, I'm talking about the group who are surface antigen negative, who are core positive, and have demonstrable hepatitis B virus DNA, they should also be treated, because they also, the data documents that they can also get reactivation of the virus.
Dr. Gulati, how long can we give it?
Thank you so much, sir. We can take question during the lunchtime. Thank you so much.
Thank you so much.
Thank you, sir, for an elaborative discussion. Before moving further, I would just request kindly to the speakers that we have to finish the talk in 15 minutes strictly, so that we have 5 minutes for questions and answers. So moving on, it is an honor to invite Dr. Ashok Kumar, sir, on stage to deliver the next talk. And I would request the chairpersons on stage to kindly introduce him.
I take great pleasure in welcoming Dr. Ashok Kumar here. As we all know, we all know him. He has been professor and head of rheumatology in AIMS, and he is also a recipient of no laureation of Indian Rheumatology Association Award. He has been the president of IRA and editor in Indian Journal of Rheumatology. He is the recipient of Dr. M.N. Pesky Award in IRA for lifetime achievement. He received multiple awards and multiple publications. It's been a great pleasure to listen to him.
Thank you. I think every invite to come and speak at AIMS is a matter of great pleasure as well as honor to me personally. And I'm really grateful to Uma for this present session. And the topic also that has been given to me is quite interesting. I will begin by starting with the statement that the spectrum of disease-modifying drugs has definitely enlarged. Now you can classify them into synthetic and biological disease-modifying drugs. And the first category, as you know, has the old ones, the conventional synthetic DMARDs. I mentioned 4 here, which are commonly used, but you can add iguratimod also to it. The others have been just put in the backbench. And the targeted synthetic DMARDs, the JAK inhibitors, which is the topic of today's discussion. And I will not mention much about the biological DMARDs and biosimilars. Go to the next slide. So the question that has been posed is, are JAK inhibitors a substitute for conventional synthetic DMARDs? To answer this question, obviously we have to speak a little more about the biology of JAK inhibitors, a little more understanding as to what JAK stands for. So JAK is actually nothing but an enzyme. Say, Janus kinase. Janus is the name of Roman god, the god of all beginnings, whether it is day, month, or year, and the month of January is named after Janus, just to give an example. And Janus has 2 faces, so that it can look forward and backward without having to turn around. Now, JAK enzymes are part of the very common intracellular signaling pathway called JAK-STAT pathway. And this involves 4 JAK molecules and 4 type of STAT molecules. STAT stands for signal transducer and activator of transcription. Now, there are 4 different Janus kinases, JAK1, 2, and 3, and one called tyrosine kinase 2. And just good to know about this, that if there is a mutation of JAK3 or tyrosine kinase 2, it can lead to serious conditions like severe combined immunodeficiency. So these are very important molecules. The STAT family includes 7 of them. So they are numbered like STAT1, STAT2, STAT3, 4, 5A, 5B, and 6. Anyway, that much about their biology. Now, what exactly is this intracellular signaling pathway? So if you see this small spherical thing, imagine that this is a cytokine or a growth factor which has to bind to a surface receptor. Now this receptor is shown as these 2 yellow bars. It's a dimeric molecule. It has extracellular and intracellular domains. So once it binds, there is a series of phosphorylation reactions that gets triggered. So first of all, the JAK, Janus kinases associated with that particular receptor, they get phosphorylated. That means they get activated. Then they activate the intracellular domain of the receptor, and then finally STAT molecules. So the actual thing is this STAT. Once the STAT molecules get activated, they then form a dimer. They enter into the nucleus, go and bind to some places in the DNA to activate genes which will produce pro-inflammatory mediators and cytokines or enzymes. So that is how the inflammation gets kicked off. Now the JAK inhibitors have this importance that they can actually stop this reaction completely. So the intracellular signaling will stop 100%. So that is how they are so efficacious and they stop the inflammation very, very effectively. Now, not all cytokines make use of this JAK-STAT pathway. And you can see the right column, such important cytokines like TNF alpha, interleukin 1, interleukin 8, TGF beta, they don't make use of JAK-STAT pathway. So not every cytokine is the other ones which are listed here. So most of the interleukins do make use of JAK-STAT pathway. And as I mentioned, JAK inhibitors are so powerful that they result in robust inhibition of erosions in RA. They inhibit maturation of osteoclasts. This decreases rank ligand production. So they have a potential to actually convert sustained remission into cure. This has also been mentioned as an extreme statement, but then of course, that reflects the intensity of their effects. Now, the cytokines which are amenable to JAK inhibitors in rheumatoid arthritis are shown in this picture. Just to avoid reading these things in small print, I've listed on the left side, you can see, these are the ones. So both types of interferon, type 1 as well as type 2, IL-4, IL-6, IL-12, IL-15, IL-21, 22, 23, and GM-CSF. These are the ones which are amenable to JAK inhibition in rheumatoid arthritis, and they are relevant to rheumatoid. Now, this is, I mean, don't read too much of it, but just to say that the intracellular domain of the receptor associates with JAK molecules not randomly. There are, preferred ones, like JAK1 and JAK2 for interferon gamma. You can see here only JAK2 for growth hormone and for erythropoietin and so on. And similarly, the STAT also there are preferences. So a given cytokine will need a particular set of JAK molecules and a particular set of STAT molecules. But there is a considerable overlap also. And again, you don't have to read the small font. But what I'm trying to say is that the JAK inhibitors have found such wide usage in not only rheumatology, but also allergic disorders and other inflammatory conditions. And trials are in different phases. Like the right column shows phase 3 trials, then the phase 4 trials, and then those which are approved already, those are listed in the first column, and I've just written them in big font so that you can read. So rheumatoid arthritis, polyarticular JIA, atopic dermatitis, psoriatic arthritis, ankylosing spondylitis, ulcerative colitis, and lastly at the bottom, COVID-19, where baricitinib was approved. So more conditions you will find JAK inhibitors finding approval with time. So it's a very active area. Now, 5 JAK inhibitors have been approved for rheumatoid arthritis, which are listed in this table. But you can see tofacitinib and pefacitinib, they are pan-JAK inhibitors. So all get affected. While baricitinib, mainly JAK1, JAK2, upadacitinib and filgotinib, only JAK1, selective. And don't miss at the bottom what I've written, that filgotinib is approved by EULAR, but not by US FDA. US FDA says no, not acceptable, because it has testicular toxicity. There is some effect on male fertility. So for that reason, it has not been approved by FDA. Now, this is a table which basically tries to show that Pfizer tried to sort of conduct trials in all possible formats of use of tofacitinib, giving different names to those trials, like, tofacitinib against placebo, just for 12 weeks. That's oral solo. Then the comparison with methotrexate. Then comparison with adalimumab. And then its effect in preserving radiographic structure, avoiding erosions or protection. Then how it works in combination with other DMARDs. And lastly, as a rescue drug for people who have failed on multiple biologics. So the last one is that, oral step. So everywhere, The efficacy was absolutely, amazing. But there were also glaring side effects, adverse effects. We have just had this talk by Dr. Samir Gulati highlighting the adverse effects. And this particular oral surveillance trial was actually mandated by FDA. Post surveillance, post authorization, open label, randomized but non inferiority and safety endpoint trial. And the results have been published only recently. I mean, they came in print in January this year, but otherwise, online they were available in September itself. And so this was a 4-year trial. And what they found was, what they compared was, there were 3 groups. One getting TOFA at 5 milligram dose, second at 10 milligram, and third getting TNF inhibitor in 1:1:1 ratio. And these were patients who were inadequate responders to methotrexate, suffering from rheumatoid arthritis, 50 years or older, with at least one additional cardiovascular risk factor. So this was the study population. And it was a large study with more than 1,400 patients in each of the 3 groups, very large study. And the incidences of major adverse cardiovascular events and cancer were higher with TOFA group, as you have just heard, 3.4% and 4.2%, as compared to TNF inhibitor, which was 2.5% and 2.9%. So this gave a hazard ratio of something like 1.33 and 1.5, significant. Opportunistic infections like TB and zoster, as well as non-melanoma skin cancer, were more with tofacitinib, and the FDA issued a black box warning on 1st of September last year after these results became available to them. And what was this warning? They said there is an increased risk of serious events such as heart attack, stroke, cancer, blood clots, and death with Xeljanz. Baricitinib and upadacitinib are also expected to have similar risk because of shared mechanism of action. This is the statement given by FDA. Clinicians must consider benefits and risks for individual patients prior to initiating or continuing therapy with these 3 drugs. This applies particularly to current or past smokers, those with cardiovascular risk, and those with history of cancer other than non-melanoma skin cancer. So at the end, it is mentioned use of JAK inhibitors is limited to inadequate responders to TNF inhibitors. Now, this is also something that we should note. Now, just a few words about others. Baricitinib also has similarly undergone several trials, but this is the one which I want to just focus here, that it says there is a head-to-head comparison between tofacitinib and baricitinib, and efficacy-wise, baricitinib is superior. Side effects-wise, they were not significant. This is just the gist of it. I'm not going to spend time on it. And then a few words about selective JAK1 inhibitors. Upadacitinib and filgotinib are 2 selective JAK1 inhibitors, and their JAK1 selectivity combines efficacy with better safety profile, because some of those bad side effects come from JAK2 inhibition or JAK3 inhibition. Select compare trial proved safety of upadacitinib at par with that of adalimumab. Serious infection, major adverse cardiovascular events, and venous thromboembolism, malignancy, they were balanced across the 2 groups. So there is a lot of hope on JAK1 selective inhibitors. Now, we come back to the basic question. Are JAK inhibitors a substitute for conventional synthetic DMARDs? So I have just tabulated a few parameters. If you compare conventional DMARDs with JAK inhibitors, the route of administration for the conventional ones is mostly oral but can be parenteral, while JAK inhibitors are all oral. The size of molecule is small in both. Mechanism of action of conventional ones are not very well defined, usually vague, while it is well defined target, case of JAK inhibitors. Monotherapy in either is efficacious, but JAK inhibitor is more efficacious than methotrexate, our best conventional DMARD. Direct analgesic effect, our conventional ones don't have. While JAK inhibitors have some kind of analgesic effect, which has been really sort of emphasized in the literature, that the pain control is better with JAK inhibitors. What mechanism operates here is not very clear, but this is an area of research. You may find more applications of JAK inhibitors in controlling pain, which otherwise is not responding to anything. Industrial production is relatively easy in both cases. When the proof is there, you know how many companies are making tofacitinib at present. Price of generic version, low and affordable in either case, but safety, our conventional ones are considered generally safe, while JAK inhibitors are real safety issues. Place of treatment in algorithm, first line, conventional case, while in JAK inhibitors, certainly not first line. Safety considerations, they must. So what is the answer? I think I've already answered it. They are not, certainly not substitutes for conventional synthetic DMARDs. So to conclude, JAK inhibitors are orally administered targeted synthetic DMARDs. The generic tofacitinib, which is available in India, is highly efficacious and affordable. Although comparable to biologics in efficacy, some serious adverse events have eclipsed the initial glitter of JAK inhibitors. Their position in RA treatment has slipped below TNF blockers. Obviously, they are not substitutes for conventional synthetic DMARDs. Selective JAK1 inhibitors have better safety profile, but these drugs will take a long time before becoming available and affordable for the third world countries. I will end it here so that there is some time for discussion, because I must have provoked a few issues.
Thank you, sir, for the wonderful talk. The house is open for discussion.
Dr. Ashok, I just want to ask two quick questions. During your presentation, you said that it also inhibits the osteoclast maturation.
Yes.
So can this have a collateral advantage in improving osteoporosis as an orthopedic surgeon, because osteoclastic inhibition will lead to increased bone mass? The second is that the previous speaker had said that tuberculosis incidence is within 9 months of onset of Mondis. So if somebody has taken for 2 years or so, does that mean the incidence of tuberculosis will be significantly reduced? These are the two questions.
Well, the first one, I don't think anybody can answer that, because the trial has to be done, has to actually see whether it has that much of benefit with in well, that possibly will be there. Possibly will be there. What I talked about was suppression of erosions.
So how long can we give, sir?
Wait. He asked two questions. The second one is still. Now, the second question was about tuberculosis. Now, let me tell you very openly. I also started using tofacitinib the way others were using. And I was probably not so impressed with the risk of tuberculosis. It has been really highlighted so much. I did not give any kind of prophylaxis. I didn't even check for MON2 test or quantiferon TB gold. And in my first 100 patients, only one developed tuberculosis. And that guy you could have predicted, because he was so lean and thin, 40 kg weight. And, he did not develop tuberculosis with anti-TNF, surprisingly, on which he failed. And then I, gave this, and he developed tuberculosis. Barring him, other 99 patients, simply no problem of tuberculosis. So what I'm saying is, anti-TNF, the risk of tuberculosis activation is 10% and above. While with tofacitinib, at 5 milligram BD dose, the risk is probably 1% or less. So keep that in mind. I've already done this trial of 100 patients. Actually, I've gone to more. 100 I just gave you, figure beginning. And continuing the same practice, I have not yet seen a second patient, 200 plus. Okay, so that's a practical experience, unpublished. Somebody else may stand up and I've seen 5 cases, I've seen 10 cases. Maybe they're right. But I am
For
not.
how long did The patient were on tofacitinib.
Oh, the drug came in December 20. From that time onwards, within 3 months, I had already given it to 100 patients. So now it is 22. More than 1 year, definitely. Average.
So just to answer his first question, so the conventional understanding is that the osteoclastic activity and the osteoblastic activity are coupled with each other. So when you inhibit the osteoclastic activity, the osteoblastic activity also gets inhibited. So they are not, uncoupled from each other. Teriparatide is a different drug. Teriparatide is a different drug. It increases the osteoblastic activity. But when you give a bisphosphonate, you suppress the osteoclastic and the osteoblastic. And that is why you end up with atypical femoral fractures.
I think we can close this session. Thank you so much, sir. Good luck.
Now I'll hand over the mic to one of my colleagues, Dr. Pallavi Vij, SR Rheumatology, for hosting the inauguration ceremony. Good morning, respected faculty, delegates, and welcome to Rheumatology Update 2022. Organized under the aegis of Delhi Rheumatology Association by the Department of Rheumatology, AIMS, New Delhi. We're truly honored to have such a galaxy of eminent rheumatologists, physicians, teachers, and students as a part of this glorious event and a much awaited event. And we extend a hearty welcome to all of you present in the auditorium here today. Light and brightness is a symbol of positivity, prosperity, and abundance. So to begin with, we would like to seek the blessings of the Almighty by lighting of the ceremonial lamp, for which I would like to request the following dignitaries to kindly join us on the dais. I would like to invite our chief guest, respected Dr. Randeep Guleria, sir, Director, AIMS New Delhi, to kindly come on the dais, sir. I now invite Dr. A.N. Malviya, sir, former HOD in Medicine and Chief of Clinical Immunology and Rheumatology Department at AIMS New Delhi. Currently, the head of the Department of Rheumatology, ISIC Super Speciality Hospital, New Delhi. Sir, can you please honor us with your presence on the stage? I request Dr. Rohini Handa, sir, to please ascend to the dais. He is a former professor and head of the Rheumatology Department at the All India Institute of Medical Sciences, New Delhi, currently associated with the Indraprastha Apollo Hospital, New Delhi, and is also the scientific chairman of the Rheumatology Update 2022. I further invite Dr. Sandeep Upadhyay, sir, the president, Delhi Rheumatology Association, and senior consultant rheumatology at Indraprastha Apollo Hospital, Delhi. Please come to the stage for the honors of lighting the lamp. I invite Dr. Hemant Sharma, sir, Secretary, Delhi Rheumatology Association and Head of Medicine Department and Rheumatology Wing at the NDMC Medical College and Hindu Rao Hospital, New Delhi, to please join us on the dais, sir. And I finally request Mr. S.L. Gera ji, our guest of honor, to please come to the dais for this inauguration ceremony. Can we please hand the faculty on the stage the lamp, the candle? Shubham Karoti Kalyanam, Arogyam Dhan Samprada, Shatru Buddhi Vinashaya, Deep Jyoti Namaste. Deep Jyoti Parabrahma, Deep Jyoti Janardana, Deep Hartu
Me Papam, Beef Jyoti. We thank all the dignitaries on the stage for doing the honors. Thank you. I would like to request Dr. Guleria sir, Dr. Handa sir, Dr. Upadhyay sir, and Dr. Uma Kumar ma'am, and Mr. S.L. Geraji to kindly stay back on the stage and take their seats on the dais, please. John Quincy Adams said, if your actions inspire others to dream more, learn more, and become more, you are a leader. I would like to attribute this proverb to all our dignitaries on the dais and would like to request them to give us this opportunity to please felicitate them on this auspicious. Dr. Momita ma'am, our research officer, Executive Director, AIMS, New Delhi, Dr. Randeep Guleria, the token of a gratitude. Round of applause, please. Dr. Sahej Roop Kaur, Senior Resident, Department of Rheumatology, to honor respected. Can we please applaud, sir? Next, I request Dr. Manikandan, SR Rheumatology, AIMS, New Delhi, to kindly welcome and felicitate Dr. Sandeep Upadhyay, sir, please. I would like to now call Dr. Israrul Haq, SR Rheumatology, AIMS, New Delhi, to kindly felicitate Dr. Uma Kumar ma'am, our Head of Department and Organizing Secretary for Rheumatology Update 2022. A doctor's world is not complete without his or her patient. We took this opportunity to do something unique, means of this meeting, and invited one of our oldest patients, taking care under us for nearly 34 years, to be a guest of honor. And he obliged us with accepting the invitation. Send a guest of honor with a momentum of our gratitude and appreciation and love. This conference was a brainchild of our head of department and the organizing secretary for Rheumatology Update 2022. Without her painstaking efforts, this conference would not have seen the light of the day. I kindly request Dr. Uma Kumar ma'am to please give a welcome note to our faculty and the delegate.
Thank you so much, all of you, and very big thank you. So you found time to come here on Sunday morning, and I would like to acknowledge my respect, regards, and gratitude to our Honorable Director, Professor Randeep Guleria, sir, and my teacher, my guru, Dr. Rohini Handa, sir, because of him I'm in rheumatology, and Dr. Sandeep Upadhyay, President, Delhi Rheumatology Association, Shri S.L. Geraji, who had been associated with AIMS for more than 3 decades. So you can imagine how precious he to us. And I would also like to thank all the audience once again for gracing this occasion. I'll not take much time. I'll just inform that we had this 1.5 day overwhelming response that we had to close down registrations for workshops. And today we are having this full day 9 to 5 meeting on various rheumatological. As you all know, rheumatology is a budding specialty. It's still in infancy, but the hope and positive thing is that it is being taken up by our junior colleagues, and the cutoff for rheumatology is going up day by day. So brightest of the brains, they are opting for rheumatology. And previous month, April was being celebrated as Rheumatological Disorders Awareness Month. So it's 1st May today, and this happens to be International Labour's Day. So happy International Labour's to all of you. And I would be fall short of words if I don't thank my sponsors who have made this event a success, and my students, my office staff, my lab staff, and everyone who I forget to name. And our director sir has to go for the, interviews are going on in the institute, so he has to leave. So I'll just keep it short. Thank you so much once again. Jai Hind.
Thank you, ma'am, for your pleasant and kind words. I now request Dr. Rohini Handa, sir, kindly bless this illustrious gathering with a few kind words.
Friends and colleagues, I think I would like to begin by volunteers of medical sciences for organizing this update. Rheumatic diseases are shrouded in and surrounded by myths and misconceptions, both amongst the minds of patients and doctors as well. Patients believe that their treatment would perhaps include always corticosteroids. Doctors have a tendency of therapeutic nihilism. It's no longer true, and updates such as this one dispel these myths. The content of this update has been curated with care, and the faculty is very experienced. I'm sure all who are attending this update will go enriched, and the ultimate aim is improving the quality of life of our patients with rheumatic diseases. Enjoy the rest of the day. Thank you very much.
Thank you, sir, for your appreciation, your motivation, and encouragement. I would now like to request our respected director, Dr. Randeep Guleria, sir, who has obliged us with his precious time to please bless us with his kind words.
Thank you.
Professor Manvir, Dr. Rohini Handa, Dr. Sandeep Upadhyay, Uma, faculty, been able to stay here for the entire inauguration because we have ongoing election interviews. When I joined as a faculty many decades ago, in many ways he selected me for this institute. So I still, it reminded me of my younger days when my hair was black and I was much younger as far as this institute was concerned. But I'd like to take this opportunity to really congratulate the Department of Rheumatology for holding Rheumatology Update 2020. It's nice to see a big crowd physically rather than and I think we have a huge interest in rheumatologists, physicians, pediatricians, rapidly branch as far as rheumatology is concerned. We all specialist and increase more awareness both in the general public and among practitioners. And we do still see patients who've been neglected, who haven't had proper treatment, and therefore have had significant deformity. I think this is something that we need to. Last few decades have been very fascinating. Changed dramatically, and so has rheumatology. I think our understanding of pathogenesis, diagnosis, and treatment in rheumatology has been really phenomenal. We moved from an era where we looked at symptomatic treatment and rehabilitation, now really offering something very aggressive as far as treatment of rheumatic and musculoskeletal. Now looking at biological DMRDs, I think there is a lot of change that has happened. Later part of the talk that Dr. Shokma ability of drug still is there. I think it's very important that we're able to understand how do we balance that out. There are new challenges also. We are seeing now patients with rheumatological disorders moving into an older age group with multiple comorbidities, hypertension, diabetes, coronary artery disease. Because of this, what is the drug-drug interaction? How do biologicals behave in these patients in terms of these disorders? There are some read an article on rheumatoid arthritis and its drugs and cardiovascular disease. I think there is going to be a lot of interest in how do we now these patients with comorbidities. Finally, I think it's been a challenging time for all of us last 2 years, and so has it been for rheumatologists to devise new ways of managing. The whole issue of the vaccine uptake in these patients. What is the risk of having severe disease as far as COVID is concerned? If you are on immunosuppressive therapy or you have a disease, it does alter your immune response. So I think these are new challenges. Do these people need more booster doses? They need a higher dose of the vaccine. These are still issues which need to be resolved. From all of this, I know that we would be conference workshops. Congratulations for that. And I'd like to congratulate and thank you very much.
Thank you so much for your time and your precious message. We'd like to take this occasion and request you to please greet and felicitate our guest of honor for tonight, for this meeting, Mr. Asig Algorithm. I now humbly request Mr. Asig Algorithm, our guest of honor for this occasion, to please share a few words with us on his long journey with his disease and his experience at AIM. Please welcome.
नमस्कार। इस प्रकार की इम्पोर्टेंस कॉन्फ्रेंस के लिए अक्सर किसी प्रमुख व्यक्ति को ऑपरेशन के लिए इनवाइट किया जाता है, परंतु प्रोफेसर डॉक्टर उमा कुमार जी ने इस कार्य के लिए एक पेशेंट को चुना, क्योंकि वो अपने पेशेंट को कहीं अधिक महत्वपूर्ण डॉक्टर उमा कुमार सारी टीम अपने पेशेंट्स की सुविधा और इलाज पर बहुत अधिक महत्व देते हैं। मैं अपने क्लिनिक में कई वर्षों से रहा हूँ और मुझे कहते हुए प्रसन्नता होती है और उनका प्रबंधन अतुलनीय। डॉक्टर्स की टीम एवं पेशेंट्स का रिकॉर्ड और उनको डॉक्टर पास भेजने का कार्य, ये सब बड़ा ही सुचारू रूप से किया जाता है। डॉक्टर उमा कुमार एवं उनके डॉक्टर्स की टीम का पेशेंट के प्रति कमिटमेंट प्रशंसनीय है। कहा जाता है कि दवाई बीमारी को ठीक करती है और बीमार को तो केवल डॉक्टर ही क्योर करता है। इसका उदाहरण है, जब मैं पहली बार अपने इलाज के लिए यहाँ आया तो डॉक्टर A.N. मालवीय ने मुझे कहा, निराश मत होइए, यू आर इन सेफ हैंड्स। उन शब्दों ने मेरी टूटती हुई उम्मीद को सहारा दिया और आज मैं आपको पूर्णतः स्वस्थ महसूस करता हूँ। और मैंने रखी है, यहाँ आकर पेशेंट्स के ठीक होने का सबसे बड़ा कारण यहाँ के डॉक्टर्स का विनम्रता और मुस्कुराकर पेशेंट्स के साथ व्यवहार है। डॉक्टर्स के प्रति कुछ शब्द डॉक्टर्स के महत्व को उजागर करते हैं। जब आंसू होते हैं तो आप कंधा होते हैं, जब दर्द होता है तो आप दवा होते हैं, और जब हादसा होता है तो आप उम्मीद होते हैं। थैंक यू वेरी मच।
मेरा जी को बहुत बहुत शुक्रिया अदा करूँगी उनके इन शब्दों के लिए, उनकी इंकरेजमेंट के लिए और अप्रिसिएशन के लिए हमारे डॉक्टरों और हमारे विभाग और हमारे हॉस्पिटल के लिए। I now request Dr. Sandeep Upadhyay, sir, Director, Delhi Rheumatology Association, to please come and please bless us with a few kind words, sir.
Good afternoon, everybody. The only three blessings that I can give you is one. The take-home message from this experience should be that the customer is always right and is the center of our universe. Patient is our customer, and if you've been listening to him very clearly, the loud and clear message is that you need to be affectionate and you need to be with the patient, empathetic with all his or her requirements. That's the most important number one message. Number two, for students, Professor Uma said, this is a burning subject, this is a burning specialty. So it's something that is not too hot to handle. I want you guys to really start reading. If you're not rheumatologists, you're physicians and you planning to go into more lucrative branches like cardiology, give rheumatology a chance as well, because there's so much happening here, and it's nearly as brilliant and academic as any other branch in the medical sphere. And finally, learn to respect your teachers. Be happy to learn something new every day. That's the number one and number two and number three message. Thank you very much.
Thank you, sir, for that message. With this, we now come to end of this remarkable inauguration ceremony. I now request the attendees to kindly stand in honor of our national anthem.
भारत भाग्य विधाता पंजाब सिंह गुजरात द्राविड़ उत्कल बंगा विंध्य हिमाचल उच्छल जलधि तरंग तव शुभ नाम तब शुभ आशीष मांगे गाहे तव जय गाथा भारत भाग्य विधाता जय है जय है जय है जय 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 जय
I thank all the dignitaries, faculty, for showing an overwhelming response to this meeting and extend our deepest gratitude for participating in this landmark event for our department. I thank the dignitaries on the stage for doing the honors of this inauguration ceremony. And I now hand over the stage back to Dr. Sayed Roop Kaur to take us forward in today's proceedings. Thank you so much, ladies and gentlemen.
So next 45 minutes, we'll be having a discussion on rituximab. For this session, may I request the chairperson, Dr. Saurabh Malviya, sir, to come on the dais. Dr. Saurabh Malviya is a consultant at Department of Rheumatology and Clinical Immunology in Medanta, Indore. He has over a decade of rich professional experience in this field, has published several papers in national as well as international journals, and is a member of various prestigious medical associations. I would also request Dr. Indrajit Agarwal, sir, to join sir on stage to chair the session. Dr. Indrajit Agarwal, a profound rheumatologist, is currently HOD Rheumatology and Senior Consultant Internal Medicine at Paras Hospital, Gurgaon. Now I would like to invite Dr. Sandeep Upadhyay, sir, to come on the dais for his upcoming talk, and may I request the respected chairpersons to kindly introduce him.
Good morning, all. Rituximab, as we all know, that it has been licensed for many indications, but it's quite interesting that it has not been licensed for lupus. But still, all of us here, we may have used this in this drug, in this condition. So we have Dr. Sandeep Upadhyay, President of the Rheumatology Association. He's a consultant at Interprasta, Delhi. He runs, and with his colleagues, very successful ENP program. So, without wasting any more time, I'd like to request Dr. Steve to give us this discussion on lupus, and thank you. Thank you, organizers, for the kind inclusion of my talk. So at the outset, I want to clarify that although rituximab is the official theme of the next two talks, I have digressed a bit, and I have included more of the lupus related medications which have come into the ambit of near FDA approval or near treatment in our clinics as the goal of my talk. And that's primarily because, something that reminded me of olden days. There used to be a time when Thumbs Up and some of the other Indian brands used to rule the roost. And then Pepsi Cola came in. And there was this time that there was a cricket tournament which was to be organized. And I think it was not Pepsi, but some other company that was the official sponsor. But then there was this tagline about the Pepsi that nothing official about it. And Remo Fernandez sort of got it right, and Pepsi Cola then took off very well. So although rituximab is the theme, I'll be digressing a little bit and talking more about, with the permission of the chairpersons, about what is new in the area of lupus and lupus development, what is new about pathophysiology. But that might also make me stumble, because even I'm likely to fumble and stumble, because I made the mistake of speaking with Dr. Malviya. Is he here or he left? The teacher of teachers. Okay, so the idea is never to speak to him on the evening or the eve before your talk, because it's likely that he'll come up with something that will stumble or make you fumble. So he told me about something that is, I'll have to take it out of my pocket and read it out to you. It's something like obutuzumab or something. So I was stumped, and I said, okay, I'll try to include it into my talk. because he is always well read on matters that are most recent, and he's gung ho about this. This is something that's going to work on CD20. It's a monoclonal that is even better than rituximab as regards lupus nephritis trial. So I've not been able to include that. And I was wondering what to do about it. Then I turned from teachers of teachers to the student of students. My student, Dr. Deepak, and I asked him, what is this all about and how does it act and all that. So if you're stuck and you're wondering what to do about things, this is what you should do. Go back to your student, he'll be able to teach you about something new. So with that as the introduction, let me get into the talk itself. We've seen several years of development for drugs in lupus, and till we had belimumab get approval, there were close to 50 years of nothing happening in the field of new treatments as regards lupus. Even rituximab seemed to be only a off-label indication for so many diseases and conditions of lupus. So it seemed as if, when I took up the talk, that the road travel thus far has had problems galore, and we've not really had much progress. And there seemed to be no solution in sight. But then I started to look ahead, and the future of lupus, there is bench to bedside data coming in that makes it very optimistic. Although it's equally daunting, the future is also very daunting. But there's something to look forward to. There is a bottleneck right there underneath the bridge, but there is a freeway right after that. I believe that in the next 5-7 years, there will be a shower of new antibodies, monoclonals, you name it, even some forms of vaccines that are being given a trial. So getting on to the real talk, there is the problem of lupus, which is a very heterogeneous disease. And even if we look at it from any angle, there is thrombocytopenia for one, there's lupus nephritis, there is cerebritis. And then to put them all together in one clinical trial and see A is better than B, very difficult. You have to look at standard therapies as part of the established treatment before you use a treatment that's experimental. So that has to be in the background. That interferes with the outcomes of treatment, and you're not able to define whether the new treatment was really effective or it was just the steroids or it was doing the trick. So therefore, targeted therapies have a tough time getting approval. We have more and more of steroid-related toxicities. We have more and more of infections. We're now aware that more than the disease itself, it's the malignancy and the CVD risk that kills the patient. And the dilemma is actually now finding effective solutions to solutions of effective treatment. We have to look for solutions to the problems that you create with these treatments. Now, if you use rituximab, you're likely to have infections. You use any other medication, mycophenolate, or cyclophosphamide. So it's now more to do with the dilemma of solutions to effective treatments. And therefore, there's been a shift of the bench to bedside paradigm from B cells and T cells and others to regulatory T cells, interferons, and some other cell-mediated therapies. Now, this actually is again, the same paradigm about how difficult it is for an average clinician to deal with lupus. And much of this comes from the fact that biomarkers, absolutely nil. We just have to rely on the few that we have, which includes anti-dsDNA, includes C3, C4, but all the others that are experimental, the ones that are with ICE3CB or interferon 1, or they're not really available for you in the clinic. So you can't really use that as a biomarker for activity. Then the treat to window target is very difficult to define. It's not something that you can see on the outside like a DAS28 score with tender and swollen joints. You can't really decide whether the drug that you're going to start is going to have side effects which are different from the lupus itself, or they're part of lupus disease itself. So you might give steroids, but the steroids might cause, say, for example, candidemia or some fungus or skin rash. And you can have a lupus-related subacute cutaneous rash, which looks like a fungal infection. So there are problems galore, comorbidities to deal with. There is the chance that you have a lady of 40, 50 who's on steroids for several years gets diabetes. gets, has this hangover of, I've read in the book that there is a malignancy associated with X drug. So more and more of these problems have been tackled now, and what was partly an innate immune problem started to look like an adaptive immune problem. But soon after it was realized that it's not just these two, but also some of the bridging cytokines, including the BAF, type 1 interferons, IL-12, 23, which are responsible for lupus pathology. And with that in mind, there's been plenty of work in this area. So it's not just the B cells that are being targeted, but T cells, dendritic cells, myeloid cells. And then there's several cytokines that have been targeted. Interferons, one of them, a success example. So what was accepted as norm earlier is now part of the clinic. What was not the norm earlier is now accepted as part of the clinic. As regards lupus nephritis, for example, in class 1 and 2, we know that we should not treat until it's really difficult for the patient. And there has been this development for electron microscopy to look for podocytopathy. Treat with steroids with or without cyclophosphamide. For class 6, the emphasis is now to go for renal replacement therapy and avoid immunosuppression at all costs. Class 3, class 4 nephritis earlier used to just rely on either cyclophosphamide, mycophenolate, and rituximab regimens. So despite the fact that it's not FDA approved, it's ULAR and ACR certified that it's part of the protocol of treatment, and we have had problems with the initial trials that were done with rituximab in lupus nephritis. And some of those can probably be tackled later. But now that it has been accepted by the scientific fraternity at large, there's not much point going back and trying to prove it in a clinical trial. It's part of the deal. But there are several caveats with rituximab use, and those have been addressed by the molecular structure or changes in the molecular structure that has been applied to the anti-CD20 molecule. And some of those include, higher propensity to attach, a higher ability to form complexes with the anti-CD20, with the CD20, and prevents its dispersion in the cytoplasm. And then there's some that allow dispersion in the cytoplasm. So there are lipid rafts which hold these CD20 molecules on it, and the CD20 molecules float around it. Rituximab tends to put them together in foursomes. So that's something that's beyond the scope of this lecture. But what I'm trying to say is that there is a role for development in this biotechnology sphere with regard to newer molecules that have a CD20-like mechanism of action. And they're extremely good, and they're doing well in phase 2, phase 3 trials. The subsequent slides will just cover briefly some of those molecules. So I'm not sure if you can see this, but this primarily is more or less like the overview of all immunology. So you have the innate immune cells on the one side, which is the myeloid cells, the dendritic cells, and the P and T cells on the other. What happens is that the dendritic cells are the one major link between the adaptive and the innate immune system. They're the ones who sort of carry forth the antigen from tissue into the lymph node or secondary lymphoid tissue and raise the alarm for antigen, which is part of the process. Now, dendritic cells and plasmacytic dendritic cells are also responsible for making a lot of interferons. And we know that lupus is now an interferon signature disease. So with that in mind, there has been a thrust or a move towards trying to capture or control plasmacytic dendritic cells and interferon-related antibodies, and indeed even BDCA2, which is part of the plasmacytic dendritic cell system, has been suppressed with an antibody. I'm not going to go into the details of what turned out of those trials, But suffice it to say that this is the length and breadth of, so you start with the immune cells that are absolutely in the innate sphere, say, for example, the myeloid cells, which secrete BAF and BLIS, which is part of the B cell immuno activation molecule. And some of these are absolutely new, and some of those that are on the left, on the B cell side, have been used, have just been tweaked a little bit. The ones that are CD20, CD19, for example. And then there is the plasma cell. So you look at the plasma cell and you give an anti-CD38. There's something called daratumumab. So what we'll do is very briefly look at some of those molecules. Rituximab we've discussed is good for RA and ANCA-associated vasculitis, but was a lupus failure, at least in trials, but is now accepted by the ACR EULAR and is used successfully in several of these lupus-related manifestations. Now the success story of belimumab. This is the first molecule after 50 years of absolutely zero development in the sphere of lupus. It's something that you can use for BAF and BLIS. It's an anti-cytokine, and these were the trials, BLIS 52, BLIS 72, and it was able to show benefit in mild to moderate lupus. Subsequently, the ones that are combo biologics or tandem biologic use. You use belimumab along with rituximab in some of these trials called BLISS, BELIEVE, BEAT Lupus. They're all very successful. Now the success story is voclosporin. Combination with mycophenolate mofetil, rapid taper of steroids was possible. This works through the mechanism of calcium inhibition. It's like cyclosporin and extremely effective, less toxic, and has also been approved by the authorities. It has found use in triple therapies, for example, a combination with mycophenolate, steroids, and voclosporin itself. Anifrolumab is one of the other success stories, also approved, and like we said, interferon is a very important cytokine for lupus generation. It's been approved for moderate to severe lupus. I won't go into details, but in 60 years, the only second molecule that has been approved for lupus, TULIP-1 and TULIP-2, it improves skin, restores blood counts, neutrophils, lymphocytes, and T-cell subsets. There are some other molecules that I'll just rapidly go over and tell you in a brief. CD40 ligand inhibition, dapirolizumab, pegylated dapirolizumab for patients who could use it during pregnancy, or bexilizumab for anti-CD19, or malizumab anti-IgE. So IgE affects basophil activation and can, through basophil activation, lead to reduced plasmacytic dendritic cells. So by and large, just a bird's eye view of what was new in lupus, not just rituximab. So I said this is nothing official about rituximab, nothing to take away from the rituximab. It's one of the most important molecules we use for not only lupus, but for several other indications. Mycophenolate and voclosporin as triple therapy. Mycophenolate plus tacrolimus, that's again a new way forward. Biological combinations, they're very much in the offing. And finally, even JAK inhibitors are finding a space. With that, I'll summarize and let you know that just the same way that we've had an explosion of molecules for psoriatic arthritis, for rheumatoid, we're going to have the next phase of renaissance in lupus. And that's something that Dr. Malviya has predicted, and he has wagered $1 billion bet that, was it obituberumab or something like that? Oh, okay. So it's always good to learn. Even if you're on the dais, you should always keep your eyes and ears open. So thank you very much for your attention, and I'll be open for questions. Thank you, Dr. Sandeep. Rituximab
as we all know, parts. Consequently, we have a lot of challenges when it comes to you in the clinic and how we should proceed with this current and in the future. But SME has many controversies, challenges. Then the treatment options are also not there much, apart from hydroxychloroquine, heparin, belimumab. Well, rituximab, we all use it as like, believing in God. Have you seen God? No. God exists. That is the asthma. So what we do in this situation, that what is the time when we like to use rituximab apart from lupus nephritis? Give us 2, 3, 4.
So one would be thrombocytopenia, that's maybe unresponsive to IVIG. A patient with lupus cerebritis, maybe a patient who has hemolytic anemia that's responded initially but needs steroids continuously for maintenance. And of course, lupus nephritis, like we discussed.
Well, I would use it in a patient who's got RA-like definitely as this. Probably, and then also use this, if you with me, that in those patients who are going to be thinking about marriage and childbirth and all, there is at least give this medication. There will be some amount of time that you can purchase, and the patient may not be on. That is another
Absolutely.
medication that I.
So if you notice, there was this development for a pegylated molecule which works like an antibody, and if it works well, you can even use it during pregnancy. So that's the kind of development that's happening in the sphere of
Since
biotechnology.
I see so many young faces, and I'm so excited that you are the future. Please don't shy away. Ask questions. Your time here. Dr. Vaini Handa. I think Deep enjoyed your talk. One of the things is that Retux fails also. I mean, one would imagine that the biologicals work for everyone, and when the chips are down, you still need to go back to good old cyclophosphamide. And there are some times when you need to combine both Retux with cyclophosphamide, and lupus comes in all shapes, sizes. And if you rebiopsy your patients with lupus nephritis refractory and you find they're not doing well, uh, I would be interested in knowing about the experience of other people combining cyclophosphamide with Retux. Because
I take that point very well, and I believe uh, there are n number of uh, occurrences that we have this patient in the ward who's done well first with a set of molecules, and we then see something uh, come through like either proteinuria or active sediment or rising creatinine. And then you biopsy again and you find crescents. And you say, then let's use cyclo. There are times when cyclo fails. There are times when you give Ritux. Ritux fails. So that's when the combination might be a good idea. And then, finding.
in my experience, our country for price, cost of therapy, cyclophosphide works. But then we all know that cyclophosphide will work in life-threatening. I think probably I would rather not take it once therapy, which after half month, 1 month. So I would definitely use cyclophosphide in those. And then thereafter, I would sort of pursue the time and money and all that exist. I will use protection. I don't know whether.
Can I?
Yeah.
Yeah.
It's a
Just because where it works best, no, you are using for cytopenia. What Rohini was asking, our experience has been that probably it works best in the Sjogren's syndrome, in the secondary Sjogren also. Now, in a very severe secondary Sjogren's syndrome also, it works beautifully. Primary Sjogren's, of course, it works very nicely.
I think I have a comment to make that you see, once you have a long time follow-up, the refractoriness of these diseases emerges. You may win the first round, but down the line, 5 years later, 6 years later, 8 years later, all the systemic vasculitis and lupus can tax your patients and the patient's patients, and you need to shuttle back and forth in the absence of biomarkers. Incidentally, anifrolumab, AstraZeneca is trying to get it in India, and for belimumab, unfortunately, the technical advisory committee felt that India does not need it. So that's why we don't have belimumab.
Just a few comments about rituximab. You know this drug, obinutuzumab, the trial has already come, and it is predicted that it will replace rituximab completely. The reason is that it really depletes B cells, not only in periphery, but also in the areas in the body where it is hiding and is not touched by rituximab. And it is predicted that this, in combination with other drugs, might be the real drug to treat lupus nephritis. By the way, one other thing must be noted, that when we talk about lupus kidney involvement, we are talking of two entirely separate areas of involvement. One is glomerulonephritis. Lupus is glomerulonephritis. But there is another entirely different area, that is podocytopathy, which occurs but rarely in lupus. And the treatment of podocytopathy has to be very different than the drugs that are effective in glomerulonephritis. And that's why the avacopan is going to be the drug for podocytopathic type of kidney disease, which is very uncommon.
Last question.
I mean, role of
And doctor as well. So you will get a chance. Please come first and then doctor.
Good afternoon, sir. I wanted to know what are the clear-cut indications of stopping steroids in lupus?
Well, that judgment would be best kept with the patient and the treating physician. And if the patient feels well, there's no fatigue, there's no swollen joints, no rash, the ESR is fine. That's when if the patient is in complete remission, there are no cytopenias, it stops steroids.
Then normally in clinical experience, how much time does it take from the time of diagnosis?
Dr. Sandeep.
I mean, we are talking about my experience and I mean what I feel. What I feel is that I mean it is best can be used in conditions like neurological lupus, in the sense that I mean it's transverse or Sneddon syndrome, or if NMO type of antibodies are there, it responds magically. And the other thing where it works is lupus with CAPS, the catastrophic antiphospholipid syndrome, which is not responding to IVIG or plasmapheresis. Rituximab works very well. So I mean the real indications are refractory nephritis, thrombocytopenias, hemolytic anemia, and neurological complication which is not responding to standard therapies.
But I don't allow my patients to go so bad that they go into such kind of complications.
They come in this
so I have very
situation.
little experience with that. I'm just kidding.
No. I mean, in your practice also, because I mean, we have a very limited practice.
We need to stop this
But
debate,
in your
Sandeep,
situation,
and,
we can come like that only.
Dr. Kapoor. So thank you. You just a lot of questions.
Thank you, Dr. Sandeep, sir, for such a thought-provoking session. I would like to invite Dr. P.D. Rath, sir, on stage for the upcoming discussion. And I may request the chairpersons to please introduce, sir.
Next topic is also very good on rituximab.
ANCA vasculitis, how, when, and why? For this, our Amitabh Bachchan of rheumatology, P.D. Rath, his name itself, personally Rath, he's always present. He's more scientific. Today you'll see more and more questions and suggestions from the audience side he has given. And Dr. Rath, he's currently director and head of department of rheumatology in Max Specialty Hospital. He has got many publications. He is in many guidelines, and also he is a very good orator. Over to you, sir.
Thank you, Dr. Saurav, and thank you, the organizers, Dr. Uma, for giving me this opportunity to be here today. I'm going to talk about rituximab and AAV. So today, when we talk of ANCA vasculitis, we no longer talk about microscopic polyangiitis or GPA. We talk about PR3 and MPO as two different diseases because we know now that they are two different, genetically different from each other. PR3 depends more on HLA-DPB1 and MPO depends more on HLA-DQ. So the diseases are now defined by the antibodies and not by the phenotype. What has revolutionized the treatment is this molecule which we were discussing, which is a chimeric molecule, rituximab. What we also know, the mechanism of action is very varied. So what it does is antibody-dependent cell-mediated cytotoxicity, complement-mediated cell-dependent cytotoxicity, antibody-dependent phagocytosis, and apoptosis. But for us immunologists, what is more important to understand is that immunologically it resets the body. So in ANCA-associated vasculitis, we have these defective T follicular helper cells which cause autoreactive B cells. And these defective T follicular helper cells are increased in patients of GPA. And even after treatment, these remain high. But when you treat with a B cell depletion therapy such as rituximab, you find that it significantly goes down. On the other hand, when we look at Tregs, which are important regulatory cells which reduce the inflammation, which are normally present in high number in normal individuals, when you see in patients of GPA, they are very low. And even when treated with conventional therapy, they remain low. But when we treat them with rituximab, they go back to normal levels as seen in individuals, healthy individuals. So rituximab resets the immune system in the body. So what it does is, it brings down the defective T follicular helper cells, sorry for the pointer, and it increases the T regulatory cells. So with that, I'll go to the rituximab induction therapy. There were two major articles published in the same year in NEJM 2010. This was the RAVE and the RITUX-VAST trial. Both these trials compared cyclophosphamide with rituximab with subtle differences. So the RAVE trial basically looked at 3 pulses of methylpred followed by prednisolone and rituximab infusions versus rituximab, placebo, and cyclophosphamide oral and followed by azathioprine. So this basically tested cyclo oral plus azathioprine with rituximab alone. And what they found was that rituximab alone was as effective as cyclophosphamide followed by azathioprine over a period of 15 months. What they also found was that almost 64% of patients were in remission at 6 months off pred on rituximab. What they also found was that in relapsing subsets, the remission was 67% as compared to cyclophosphamide and less chances of leukopenia on rituximab. The other trial, RITUX-VAST, and I will want you to just hold on to this concept. What they gave was one group received rituximab plus cyclophosphamide. So this is answering Dr. Handa's question. Rituximab plus cyclophosphamide. The other group received only cyclophosphamide and azathioprine. So this was actually a comparison of Ritux plus cyclo versus cyclo plus aza. And again, the time to remission, the BVAS was very similar across both the groups. The time to relapse was very similar across both the groups. And the safety was equal of Ritux plus cyclo versus cyclo plus aza. What subsequently also was shown by Johnstone and his colleagues that rituximab worked better in relapsers. So almost 66.7% patients achieved remission versus only 42% on cyclophosphamide. So clearly there were indications that this drug worked better in relapsers. And what they also found was that it was the PR3 ANCA associated vasculitis which was leading to more relapses, and Ritux worked much better for PR3 associated ANCA vasculitis as compared to cyclophosphamide. When we look at the effect on the ANCA serology, more patients in rituximab group became ANCA negative as compared to the cyclophosphamide group, 47% versus 24%. So what about the dosing of Ritux in ANCA-associated vasculitis? So one of the first multi-center surveys showed that 2 doses of 1 gram each was as effective as 4 doses of Ritux in refractory ANCA vasculitis. Subsequently, there was a systematic review and meta-analysis, and this showed, if you look at the size effect, I'm very sorry this pointer is not working, and I'm not comfortable with the pointer here. So if you see the effect size of 4 doses of Ritux versus 2 doses of Ritux, there was no difference in the effect size, thereby confirming that 2 doses of Ritux was as good as 4 doses of Ritux. So clearly, Ritux was established as the choice in induction therapy. What about rituximab as maintenance therapy? Now we know that the landmark trial Cyclozarim clearly showed that azathioprine was better than cyclophosphamide in terms of safety profile and as good as cyclophosphamide for maintenance of remission. So clearly azathioprine had taken its place as the treatment of choice in maintenance therapy. And that is where the main RITSAN trial came in when they started to look at rituximab versus azathioprine for maintenance. And what they did is they looked at the induction phase completed with cyclophosphamide, followed by 2 doses of Ritux, 500, 500 given 2 weeks apart, and then 500 every 6 monthly for 18 months. And what they found was that as compared to azathioprine, rituximab patients had lesser relapses, almost 5.2% relapses versus azathioprine, which had almost 30% relapses. We know about the main RITSAN 2, which showed that a fixed dosing was as good. You need not do a B cell counts, CD19 counts, and that was equally good. What the main RITSAN 3 did was it was trying to study whether giving rituximab for a more prolonged period, which is 36 months, was it better than giving it for 18 months. And what they found was that there was no difference between the two groups, and that giving it for 36 months did not give any extra advantage. So 18 months of Ritux was enough. Then came the study from the French group, and this was recently presented in the recent concluded vasculitis conference in Dublin, where they showed that an ultra-low dose rituximab was given for maintenance therapy in ANCA-associated vasculitis. This was 500 mg yearly versus the standard 500 mg every 6 monthly. And what they found was equal rates of remission with low dose, ultra-low dose rituximab. So in a resource-poor country like ours, this could be one of the regimes. What about rituximab in relapsing ANCA vasculitis? Now, there were early evidence to suggest that rituximab probably was superior to cyclophosphamide in ANCA vasculitis. And that is where the Ritazarim trial came in. And what this trial did is it took relapses at 1 month and 3 months, and then it started to compare. They gave 4 doses of rituximab and then rituximab 1000 milligram every 4 monthly, not 6 monthly, compared to azathioprine. And what they found again was that the Ritux group did much better, only 10.7% relapses versus 45% relapses in the azathioprine group, and 4 deaths in the AZA group versus no deaths in the Ritux. So clearly Ritux was the drug of choice for relapsing ANCA vasculitis. And now I come to what I feel is the most exciting part of my talk today is the combination therapy, which Professor Handa was just alluding to. And this is a very landmark study called the CycloVAS study. This was published by Stephen McDo and colleagues recently in Kidney International and followed by the Nephrology Dialysis and Transplant. And what they did is, taking cue from the Ritux-VAS study, all patients who had life-threatening manifestations, diffuse alveolar hemorrhage, severe kidney injury, creatinine more than 500 millimoles per liter, or requirement of renal replacement therapy within first 48 hours. What they did is they gave them 2 pulses of rituximab day 1, day 15, 6 pulses of cyclophosphamide according to the Euro-Lupus protocol, 500 every 2 weekly, 6 pulses, and very small steroid. Start with 60 and immediately after 1 week, 45, 30, similar to the Pexivas protocol, tapered down very rapidly by 20 weeks to 10 milligrams. And please see, not a single patient received IV methylpred. They were only on oral prednisolone. And what they found was fantastic. The GFR improved significantly at the end of 6 months. The anchor titers fell. The CRP fell. The ESKD-free survival was more than 75% in this group in all the patients. Of course, the group which had RRT at baseline did slightly worse than the patients who did not have RRT at baseline. But what is important is, irrespective of the baseline creatinine, more than 75% had a good kidney survival at 36 months. And it was only the RRT group which did not do well. The time to first infection, almost 75% were infection-free at 36 months. And when you look the current cohort and you compare it with the historical cohorts of ANCA vasculitis, it clearly was superior, far superior to the historical cohort. What also was very fascinating is what they found was what determines the prognosis is histopathology. So histopathology, clearly, if you have focal, they do the best. If you are mixed, they do slightly worse, crescentric, and the worst are sclerotic. So the renal histopathology will determine the prognosis in ANCA vasculitis. That is the most important message. Infections, well, if you look at grade 3 infections, 63% had no infections, 14% had 1, 23 had more than 2 infections. Buoyed by this, they came up with a long-term follow-up of combined this trial known as the cyclovas protocol in milder patients. Now they took patients who did not have severe renal disease. They had creatinine more than 500 millimoles per liter, who did not have creatinine more than 500 millimoles per liter, did not require dialysis at initial presentation, did not have alveolar hemorrhage or cerebral vasculitis. So milder patients. And they gave them the same protocol, and they looked at long-term outcomes at 5 years. Excellent outcome at 6 months, BVAS significantly decreased, dose of prednisolone significantly reduced, creatinine significantly improved, CRP levels decreased, ANCA titers decreased. 94% remission at 6 months, 95% renal survival at 5 years, with 0.124 patient per year infection at 5 years. So this was clearly or is clearly the future where you combine rituximab with cyclophosphamide with very low dose steroids and you taper down the steroids. And if you look at the ESKD-free survival and if you look at the ANCAs, significantly good responses with this regime. What is also very fascinating is when they compared the cyclovas patients with all the UVAS cohorts. You can name it Cyclops, Rituxvas, Ritazerem. You compare them with all the UVAS and you find relapses were definitely much significantly less in the cyclovas protocol. ESRD was significantly less. And more importantly, mortality was significantly lower with the cyclovas protocol. The other combination that is being tried is the CombiVas protocol, which combines rituximab with belimumab. This is an ongoing trial. The results are not yet published. 2 doses of rituximab and belimumab subcut every weekly for 52 weeks. What this trial is trying to look at, the primary outcome is time to PR3 ANCA negativity, and the secondary outcomes are changes from baseline in naive, transitional memory and plasmablast and plasma cell subsets, time to clinical remission, time to first relapse, and incidence of severe adverse events. And it will be very interesting to look at the result of this trial to look at whether a combination of belimumab and rituximab works better. So clearly, the combination therapy holds the future, and I'm sure there'll be a talk here in future about the rise and fall of steroids in ANCA vasculitis. And the steroids are going to fall and fall and fall till they disappear in ANCA vasculitis. And especially with the advent of avacopan, you will find that steroids will be buried in ANCA vasculitis. Side effects of rituximab, if you look at the RAVE and the Rituxvas studies, the side effects were not very different between rituximab and cyclophosphamide. What was very interesting was to see that the effect of rituximab on malignancy. So the standard incident ratios of malignancy in rituximab, specifically for non-melanoma skin cancer, is very high. What they found was that cyclophosphamide was associated with almost 4.6-fold higher risk of malignancy as compared to rituximab. And what was even more fascinating is that with every cumulative dose of cyclo, the risk of malignancy increases. But with every cumulative dose of Ritux, the incidence of malignancy decreases. So that's so fascinating. Hypogamma has always been a concern, but studies have shown that hypogamma across cyclo and AZA group versus Ritux group have not been very, very different. If you look at the IgG, IgM, and IgA, the change from baseline at 6 months and 18 months across both cyclo and Ritux group have been the same. And even in those who are hypogammaglobulinemic, the infection rates have been quite similar in patients of normal versus low IgG levels, and incidence of severe infections also have not differed. So on an average, hypogamma is not an indication to give IVIG, and routine IgG is not to be done in patients of Ritux unless your patient is developing infections. PML, of course, has been a concern, but as I showed you, with GPA, the risk of PML is low. Perhaps it's somewhat very peculiarly linked to lupus. Now I'll come to some lesser known side effects, and these are certain things which have taken the world by storm in the recent times. We use rituximab often for lung disease, but rituximab induces lung disease. So you can have an immediate reaction and you can have an acute interstitial pneumonitis or ILD. You can have a hypersensitive pneumonitis. But what is very, very fascinating today is the development of bronchiectasis with persistent use of Ritux and bronchitis and cryptogenic organizing pneumonia. So an acute reaction occurs within 15 days to 1 month, can be life-threatening and needs high dose of methylpred and oxygen, can be prevented with adequate steroids as pre-med. So give them 100 mg of methylpred as pre-med. Do not compensate on pre-meds. Rituximab-induced bronchiectasis is a fascinating condition recently described, especially in patients who are on regular use of Ritux. And the reason probably is a low-grade infection happening inside the bronchioles. There are also studies to show that Ritux can induce selective antibody deficiency, which means your IgG levels may be normal, but you don't have the capability to fight, say, Streptococcus pneumoniae. So selective antibody deficiencies can happen. So if your patients on Ritux developed selective a particular infection and your IgG is normal, remember it doesn't exclude immunodeficiency. And again, a very fascinating paper produced from the Mass General, again published in this recently concluded ANCA conference at Dublin, is bronchitis. So they found bronchitis, so chronic cough. So your patients of Ritux are going to have chronic cough, which is a bronchitis cough, which is seen in almost 17.5% of patients with less than 2 years and almost 24.7% of patients with more than 3 years of B cell depletion. Late onset neutropenia, again, a very, very fascinating aspect of Ritux, and we have seen 2 or 3 patients. And this can have immunological, it can be antibody mediated, it can be cell mediated because of T large granulocyte lymphocytes replacing. It could be transcriptional maturation arrest, or it could be due to hematopoiesis disturbance such as growth factor retentions, B lymphocyte depletions, and bone marrow fatigue. And finally, I will end with a very important thing for the pediatric rheumatologist is unmasking of primary immunodeficiency. This has been seen with rituximab of late, and as adult rheumatologists, because pediatric rheumatologists are anyway aware of it, but as adult rheumatologists, we must be aware in our patients, any patient who has a prolonged hypogamma lasting for more than 12 months must be ruled out for primary immunodeficiency, because remember, most of these PIDs can also have coexistent autoimmune disease. Most often they have autoimmune cytopenias, and that's where Ritux is given, and that can be the sole presentation of PID in these patients. These patients are often younger in age, and so these are the clear-cut, newer or rarer complications which we must keep in mind when we are treating these patients with Ritux. So with that, I would like to end my talk summarizing, and I think I've given a brief update of Ritux today in ANCA vasculitis. Thank you.
Sir, very good. Indeed, it's a privilege to chair your session. It's more scientific, very good presentation, sir. So, even I'm using Ritux as a maintenance therapy in causal studies now, with off steroids, almost 4 patients. So, what's your experience as a maintenance of rituximab?
Yeah, I think so. If you see the main Ritsan at least 18 months is clearly the indication for Ritux in maintenance. So when you have a relapsing disease, especially PR3 associated disease, I think Ritux does take precedence over cyclo where you can, and both for induction and for maintenance. And maintenance 18 months, as you have seen with Menritsan 3, is probably sufficient to give long-term remission. Prolonging it beyond 18 months may not be of benefit. That's what the Menritsan 3 tells us.
To help these youngsters,
So how do you choose rituximab as a maintenance and how do you follow?
So,
do you use ANCA level or do you use?
No, so Main-Ritsan, if you look at the Rituximab trial, it clearly showed that Ritux 2 doses of 500 every 2 week, or day 1, day 14, and then 500 6 monthly is good enough to maintain remission, and the remission has to be clinical. The problem with following ANCA is, in our country, ANCA is dubious. So when we are talking of pathogenic ANCA, so please remember that ANCAs are of various types. ANCA are not monoclonal, they are polyclonal. Some of the ANCA epitopes are specific for disease activity. Some ANCA epitopes are specific in remission. So unless we have an epitope-specific ANCA to know which ANCA is pathogenic, so when we have, say, a sandwich ELISA, we know we have a conformational three-dimensional epitope, and we preserve. So both of the pathogenic epitopes are three-dimensional. But when you put it on an ELISA plate, many times you lose it on a conventional ELISA. So many times what the ANCA that you're picking up may not be pathogenic. So do not treat patients on basis of ANCA. And Main-Ritsan 2 clearly showed that CD19 or ANCA-based treatment is not as good as a fixed dose interval treatment. So fixed dose, clinical remission, that should be the guideline.
Yeah. Hello, Dr. Prasann. Thank you for such a nice talk.
Hi, Sandeep.
Yeah, I just wanted to say that no discussion about rituximab can be complete without addressing the elephant in the room of current times, that is COVID. Because giving rituximab is planning a prospective treatment. We have to look into the past also, whether there is what type of vaccination the patient has received, what is the current immune status after the vaccination, how do you prepare the patient for a rituximab vis-a-vis vaccination,
Yes.
and then how do you prepare for any eventuality.
Yes.
So I just want you to highlight two or
Yeah,
three things. Is that does it make any difference what kind of vaccination the patient has received? Because we have 2 vaccines in our country, but in all likelihood we would have more vaccines. Secondly, what titers would you do before giving rituximab? If you want to give an additional dose of Covaxin or Covishield, how much would be the interval before giving another dose of rituximab? Patients who have already received an induction therapy, due for a maintenance therapy now? Should we delay our maintenance for a little? These are small points.
Yeah.
I would appreciate if you give a one-line answer to all
So
of them.
very, very
Thank you.
important question. So I'll also take you down to what is the latest in this field and then take you back to the conventional. So when we talk of rituximab in the times of COVID, there's always been this concern that with B cell depletion, antibodies are less. Will these patients be able to fight infection? And the whole COVID, we were really afraid of giving Ritux. The data now comes from the European Society of Immunodeficiency in patients who have primary common variable immunodeficiency. So CVID patients who developed COVID did not have problems. They had very robust T cell responses. And based on that, what they said is that giving a B cell depletion therapy may still be viable in patients, because if a CVID patients with COVID are able to survive with good T cell responses. So there are studies now to show that B cell are not the only arm, and you have good T cell responses, which is good enough to get a robust, protection against a vaccine. But the guidelines, the ACR guidelines have still said that the vaccines have to be given at least 1 month before the Ritux, and if you've given Ritux, at least 4 months after. So those are the guidelines. That's what we adhere to. But in a patient where you have to give the drug, you give the drug knowing very well that the T cell arm of immune response is robust, and patients who have CVID with COVID have shown robust T cell responses. So I think that is the scientific thing that guides us, but these are the guidelines which we need to follow. Thank you.
Excellent talk, Dr. Rai. Multiception is in combination already on. So this is something which. Secondly, that use a different brand, because now there are brands available.
Yeah. Yes.
And then after that, their brand.
Yeah. Yes. So again, there's a scientific and a practical answer to that. The scientific answer is no, because the different brands can have problems. And in Mexico, the deaths happened because of switching from the innovator to the generic, and that was the problem. But in our country, I think now there's enough experience. I did not have much experience, but one of my patients, when I talked to the R&R hospital, Dr. Karthik told me, well, we have used whatever we get, we use it. The next time we get another drug, we use another drug, and we have not had any problems. So quite buoyed by that. but still one has to be careful. I mean, as much as possible, try to stick to the same drug, same company, because they are different molecules. And we know that biosimilars or intended biosimilars are inherently different from each other. So try to stick to the same brand as much as possible, but some experience maybe from the others also that a switching of brand probably has not made any difference to most of these patients. That's what I've heard from my colleagues.
We can now stop.
Dr. Sujat.
That's next time.
Thank you so much, sir, for an interesting and stimulating discussion. So, as today's program is all about sharing knowledge and wisdom, so I would like to quote a Sanskrit shloka before moving on to the next session. न चौरहार्यं न च राजहार्यं न भ्रातृभाज्यं न च भास्कारे वयकृते वर्धते नित्यं विद्याधनं सर्वधनं प्रधानम, which means the wealth that cannot be stolen, neither abducted by state, nor can be divided amongst brothers, neither it is burdensome to carry. The wealth that increases by giving, that wealth is education and is supreme of all possessions. Moving on, rheumatology is an ever-changing super specialty with increasing understanding of pathophysiology of autoimmune diseases. We are able to find better ways to diagnose and manage at the earliest, resulting in newer management guidelines and recommendations almost every 2 to 3 years. In the upcoming session, we'll be discussing on the current management guidelines of the commonly seen diseases like RA, JIA, and SPA. To chair the session, may I please request Dr. Pulin Gupta, sir, to come on the dais. Dr. Pulin Gupta is Professor of Medicine and Consultant Rheumatology at Atal Bihari Vajpayee Institute of Medical Sciences, Dr. RML Hospital, New Delhi. He is a member of numerous institutional, university, and Government of India committees. He is also an adjunct professor of medicine at Loyola University, Chicago. He is a PG teacher, reviewer of many journals, has written many chapters in medicine updates and books, been awarded Oration Awards twice, and has more than 50 publications to his credit. Now I would like to invite the next chairperson, Dr. Anu Maheshwari ma'am, to come on stage and grace the stage with her presence. She's Associate Professor Pediatrics at Lady Hardinge Medical College and Kalavati Saran Children Hospital, New Delhi. She has over 30 publications in books, international and national journals, is a peer reviewer of various national and international journals. Her areas of interest are pediatric immunology and rheumatology. I would request Dr. Sandeep Grover, sir, the next chairperson, to come on the dais. Dr. Sandeep Grover is a well-known rheumatologist and merit whose area of expertise lies in prevention and treatment of rheumatology, immunology, and arthritis. And lastly, I would like to invite Dr. Ram Pratap Saini, sir, to chair the session. He's Professor and Consultant, Department of Medicine, in charge of Rheumatology Clinic at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. For the upcoming talk, I would request Dr. Rajiv Ranjan, sir, to come on the stage and begin the session. And I would request the esteemed chairpersons to kindly introduce him.
Good afternoon, everybody. So now we have 4 sessions regarding the guidelines, the recommendations for probably the most common CT in our clinical practice. Arthritis, HIA, and last but not least, psoriatic arthritis. In fact, I think that these are the 4 guidelines which the residents need to learn and know the most. One of these will definitely come in their final exam. And we have 4 prolific and fantastic speakers for all of these 4 guidelines. The first one is Dr. Rajiv Ranjan Kumar. He's a MD Internal Medicine from West Bengal. He is Associate from Rheumatology Department. He is DM Clinical Immunology and Rheumatology from. He has more than almost 30 international and national publications. He's a Young Scholar Award 2018. He has special interest in myositis and vasculitis, and currently working as a consultant rheumatologist at MedGram, which is the Arthritis and Rheumatology Clinic. Also a visiting consultant in CK Birla Pratiksha and Park Hospital, Gurugram. He's a faculty at ESIC Medical College and Hospital, Hyderabad. and occasionally he goes to the big Apollo hospital, Patna. Over to Dr. Raj.
Thank you, sir. Thank you so much. So my topic today is current management guidelines in the rheumatoid arthritis. So we all know that rheumatoid arthritis is a typical autoimmune disease which usually presents with symmetrical additive inflammatory polyarthritis. So if this inflammation is not checked, it can lead to irreversible damage to the multiple joints. And further, this inflammation can spill over to the multiple organ, causing multiple organ damage. So if you look at the different RA management guidelines worldwide, so we have more than 20 different management of guidelines worldwide, but we usually follow the ACR guideline, that is American College of Rheumatology, and EULAR 2019 guideline, which are the updated guideline. So as the evidence emerges, we have different recommendations based on the time to time. The recent one given by ACR is 2021 guideline, and by EULAR it is 2019 guidelines. So coming to ACR 2021 guidelines, it is based on the PICO questionnaires, systematic literature reviews, and grade approach. So ACR 2021 has given 44 recommendations. The 7 is strong, the 37 is conditional. The strong recommendation and conditional recommendation is based on the different parameters. One is the quality of evidences or quality of research. The second is the desirable and undesirable effect of particular recommendation, the side effect, and the different patient-related aspect also. And based on that, the panelist gives the strong and conditional recommendations. So ACR 2021 guideline is based on the disease activity of the patient. For those who are DMARD-naive patients, if the disease activity is low, then the hydroxychloroquine is conditionally recommended over sulfasalazine, while the sulfasalazine is conditionally recommended over methotrexate, while methotrexate over leflunomide. If the patient is taking conventional synthetic DMARDs, but not taking methotrexate or having moderate to high disease activity, then the methotrexate monotherapy is preferred over the combination of methotrexate with biological DMARDs or targeted synthetic DMARDs. If the patient is having moderate to high disease activity, then methotrexate monotherapy is strongly recommended over hydroxychloroquine, sulfasalazine, biological or targeted synthetic DMARDs monotherapy, or combination of methotrexate with non-TNFi biological DMARD or targeted synthetic DMARDs. If the patient is having moderate to high disease activity, the methotrexate monotherapy is conditionally recommended over leflunomide, dual or triple DMARDs, conventional synthetic DMARDs therapy, or combination of methotrexate with TNFi biologicals. Regarding the steroid treatment, the ACR recommends that patients with conventional synthetic DMARDs without short-term glucocorticoid, that is the less than 3 months of dose, is conditionally recommended over conventional synthetic DMARDs with short-term glucocorticoids. While the conventional synthetic DMARDs without long-term steroid is strongly recommended over conventional synthetic DMARD with long-term steroids. So regarding the treatment modification, treat to target approach is strongly recommended than the usual care of the patients if they are not taking the biological DMARD or targeted synthetic DMARD. If the patient is already have taken the biological DMARD or targeted synthetic DMARDs and not at target, then the treat to target is conditionally recommended. The target is best is remission. If not, then low disease activity is conditionally recommended over it. Regarding the treatment modification, these all are conditional recommendation. Addition of a biological DMARD or targeted synthetic DMARD is preferred over the triple therapy if the patient is not at target with maximum tolerated dose of the methotrexate. Switching of a biological DMARD or targeted synthetic DMARD to a different mechanism of action is preferred over than the switching from the same class if the patient is already taken that particular class of drug. Addition of or switching to conventional synthetic DMARD is preferred over the continuation of a steroid with conventional synthetic DMARD, even the patient is on target. This is the most important recommendation regarding the methotrexate administration. Oral methotrexate is preferred over the subcutaneous methotrexate. Initiation or titration of methotrexate to a 15 milligram weekly doses over the period of 4 to 6 is conditionally recommended over less than 15 milligram per week. If the patient is before labeling methotrexate intolerance, either try to split the dose over the 24-hour period, or you can give the subcutaneous methotrexate, or increase the folic acid or folinic acid before labeling it as a methotrexate intolerance or starting another DMARDs. If the patient is on oral methotrexate and not at target, then you can switch to subcutaneous methotrexate. Regarding the tapering of regarding the tapering of DMARDs, the ACR recommends that continuation of all DMARDs is preferred, but this is conditionally recommended over dose reduction if the patient wishes. If the dose reduction is conditionally recommended over the gradual discontinuation, while the abrupt discontinuation is not at all recommended. If the patient is on triple therapy or having sustained remission, the gradual discontinuation of sulfasalazine is recommended over tapering the hydroxychloroquine or methotrexate. If the patient is on methotrexate with biological DMARD or targeted synthetic DMARD, the first gradual tapering of methotrexate is recommended over the biological or targeted synthetic DMARDs tapering if the patient wishes and if the patient is on target. Now I will discuss about the special population with rheumatoid arthritis. If the patient is having subcutaneous nodules, methotrexate is conditionally recommended over the other conventional synthetic DMARD. And if the patient's developing more nodule, that is the progressive nodulosis on methotrexate, then you can switch to non-methotrexate DMARDs. Patients of pulmonary disease or interstitial lung disease, if the pulmonary disease or interstitial lung disease is stable or mild, then methotrexate is conditionally recommended over the other DMARDs. For the lymphoproliferative patients, rituximab is preferred over the other biological or targeted synthetic DMARDs. For the patients of heart failure, usually the TNF5 is not preferred, so the non-TNF5 biological DMARD or targeted synthetic DMARD is preferred over TNF5. If the patient is already on TNF5 and are having class 3 or class 4 heart failure symptoms, then switch to non-TNF5 biological DMARD or targeted synthetic DMARD. If the patient is having persistent hypogammaglobulinemia without any evidence of infection, then continuation of rituximab is conditionally recommended. If the patient is having serious infection in last 1 year, the serious infection is usually defined as if the patient requires IV antibiotics or hospitalization for particular infection, we call it serious infection. So in this particular patients, conventional synthetic DMARD is preferred over the biological DMARDs or targeted synthetic DMARDs. Try to reduce the steroid as minimum as possible or stop it if you can do it. Regarding the hepatitis or liver disease, for the patient hepatitis B, we have to see two things. One is anti-hepatitis B core antibodies. The second is hepatitis surface antigen. If hepatitis B core antibody is positive, regardless the hepatitis B surface antigen status, if you are planning for rituximab in this kind of patients, the prophylactic antiviral is strongly recommended before starting it. If the patient is having both positivities, like hepatitis B core antibody positive and surface antigen positivity, then you are planning for biological DMARD or targeted synthetic DMARD, then you have to give prophylactic antiviral therapy. These are strongly recommendations. If the patient is having only core antibody positive with hepatitis surface negative, and you are planning biological DMARD or targeted synthetic DMARDs, then only frequent monitoring is recommended. For hepatitis C patients, those who have already taken or received the antiviral treatment, the recommendation is same as the normal RA patients. And if the patient do not require or not receiving any antiviral therapy, then conventional synthetic DMARDs are preferred over the biological DMARDs or targeted synthetic DMARDs. For the patients of non-alcoholic fatty liver disease, methotrexate is conditionally recommended if the liver function tests are normal and no advanced fibrosis. For the patients of malignancy, like if they have already been treated or untreated skin cancer, melanoma or non-melanoma, conventional synthetic DMARDs are preferred over the targeted synthetic or biological DMARDs. If already they have taken treatment for solid malignancy, the treatment is as normal RA patients. For non-tubercular lung disease, try to reduce dose of steroid as minimum as possible, discontinue if possible. Conventional synthetic DMARDs are preferred over the biological DMARD or targeted synthetic DMARDs if the disease activity is moderate to high. If you have to give any particular biological agent, then abatacept is preferred over the biological DMARDs. This is all about the ACR 2021 guideline. Now the EULAR 2019 update of rheumatoid arthritis treatment. It has phase 3, 1, 2, 3 with 4, 5 overarching principles and 12 recommendations. The most important is conventional synthetic DMARD should be given as soon as the possible when the clinical diagnosis of RA is made. Treatment should be at target, and our target is sustained remission or low disease activity. Methotrexate should be the first line treatment. Active monitoring is required. If the patient is having active disease, then monitoring 1 to 3 months are advised. If no improvement at 3 months or target is not achieved by 6 months, then adjust the dose. This is the phase 1 treatment. First, the diagnosis of RA is made. The second, if look for contraindication of methotrexate. If there is no contraindication, then start methotrexate. If there is contraindication for methotrexate, either you have to give leflunomide or sulfasalazine along with the short-term steroids. Monitor your patient at 3 months or 6 months. At least 50% improvement at 3 months expected, or target at 6 months. If this is yes, then continue the treatment. If not, then you have to modify the treatment. Modification is based on the poor prognostic factor in phase 2. If the patient is having poor prognostic factors, then you have to add a biological DMARDs or JAK inhibitors. If poor prognostic factors are absent, then you can add or change to another conventional synthetic DMARD, that is leflunomide or sulfasalazine. The poor prognostic factors are moderate to high disease activity, even if the patients are on conventional synthetic DMARDs, high rheumatoid factor and anti-CCP, high inflammatory markers, high swollen joint count, if the patient is having early erosion or failure of 2 or more conventional synthetic DMARDs. Again, after this, you have to assess at 3 months or 6 months. If the target is achieved, continue the treatment. If not, then you have to modify the treatment. And in phase 3 is like the similar one. You have to change one biological DMARD to another or change to another mechanism of action and assess at 3 or 6 months. So now the recent thing is difficult to treat RA. What is difficult to treat RA? The EULAR recommends that according to the EULAR guideline, if you are giving the treatment and there is failure of 2 or more biological or targeted synthetic DMARDs after failing the conventional synthetic DMARDs, this is the first criteria. The second is there is sign or symptoms of active or progressive disease, which is defined as moderate disease activity, or sign or symptoms of active inflammation, inability to taper the steroid to less than 7.5 milligram per day, rapidly radiographic progression, or if the patient is having reduced quality of life. And the third is management of sign and symptom is perceived as problematic by the rheumatologist and the patient. These 3 criteria should be present to fulfill the difficult to treat RA guidelines. For difficult to treat, you have to really assess that the definition actually meets or not. The second thing that you have to assess the rheumatoid arthritis mimics. Sometimes the patient may have some different disease and you are treating, the patient are not responding. So misdiagnosis should be reassessed. The second thing is just assess the patient with some other illness like the check for inflammation, arthritis. If clinically not possible, you can also use ultrasound, or you can also check for the other like fibromyalgia-like conditions. And if another point to check is adherence. This is the most important factor in day-to-day or clinical practice. If patient is taking the drugs properly or not. If adherence is yes, then you can discuss the all treatment and optimize difficult to treat patients. So summary of the all guidelines are like conventional synthetic DMARDs should be given as soon as the possible. Monitor disease activity based on the inflammation or high disease activity. If it is high, then frequent. The target is remission or low disease activity. Methotrexate is the best initial therapy. Biological DMARD or targeted synthetic DMARD should be kept only for those patients who are having persistent active disease even after the conventional synthetic DMARD. Steroids or non-steroidal anti-inflammatory drugs should be given as minimum as possible. Thank you so much.
Thank you very much, Doctor. On time. Just summarize the changes in the present guideline, the previous.
The most important thing is like if the patient is taking like first is conventional synthetic DMARD. This is the primary treatment even in 2015 and 2021 guideline. The second is the steroid. In 2015, they have advised for the use of low-dose steroid. But in 2021, it is like ACR is usually conditionally recommended or try to advise that use of steroids should be as minimum as possible. Without a steroid treatment is preferred over than continuation of long-term steroids. The third thing is earlier recommendation is that you can give, it is preferred that targeted synthetic DMARD or biological DMARD, if inadequate response, you can switch to different mechanism of action rather than having same group of drug. This is the one thing that they have modified.
Recommend on the vaccination done before triple DMARD, Methotrexate or before biological?
Yes, sir. So vaccination recommendation has not been updated in the 2021. It is similar to the 2015 that for inactive vaccines can be given before the during the treatment of conventional synthetic DMARD or even on biological or targeted synthetic DMARD. Live vaccines should be properly, we have to monitor. And it should not be given if the patient in on treatment of biological DMARD or targeted synthetic.
Booster vaccine, no fever vaccine. One has been started on, right? Cannot give a yellow fever vaccine, which is absolutely necessary. Go to south. Do we have any questions from PGs? Any recommendation where to use rituximab or TNF inhibitor over and above? We know the target is 30 DMARDs.
Right.
Heart failure.
Sir, for rituximab, those patients who are having lymphoproliferative disease, this is the one biological DMARD which is preferred over the other biological DMARD. While the anti-TNF, the one thing that we have to monitor is heart failure. Patient having class 3 or class 4 symptoms, you should not give the anti-TNFs. You have to prefer other biological DMARDs over the anti-TNF.
I want to know one thing more. Told about dose of methotrexate, oral preferred over subcutaneous. The maximum dose is 25 milligram. If you go beyond 15 milligram, whether prefer subcutaneous or go ahead with
It's still, if the patient is tolerating well, no problem with the tolerating over the 15 milligram. So I don't think it's clearly mentioned in the guideline, but what I feel the same dose can be continued. If someone is having problem with tolerance, can be divided into 2 doses if it is not tolerating the high dose. Sir. Per kg. Not so
that statement that immediately as well as
right.
So they are very clear in stating the fact that the body mass index of Caucasians differs a lot from population like us. So 15, 20 million of those. Just a small query.
Right.
Dr. Malia Sandy.
Just a few points about the treatment. It was very nicely presented, and I'm very happy about it. There seems to be widespread misconception and misunderstanding about methotrexate. I'm not talking about rheumatologists. I'm talking about non-rheumatology colleagues. They think that this is probably related or it is the same drug which they use in the department there, which is called cancer. This drug has nothing to do with that, and it should not be even named in the same breath. And it never can cause cytotoxicity because the dose needed to suppress DHFR is so low for treating rheumatoid, and it only stimulates to produce adenosine as against to stopping this cell cycle and DNA, where you need 2 log order higher doses, which goes in grams. And if you read the literature, 13 grams of methotrexate have been given there, with 5 grams almost a routine, while we never hardly ever go above 25 milligram once a week. This is a very important point. Never equate for the non-rheumatologists here with that cancer drug. It has nothing to do with that. And I'm giving a talk in Iracon that methotrexate, LD and HD are two different drugs. And I have already written 3 major papers, which you must have read. Secondly, methotrexate, some, again, non-rheumatologists have this feeling, why methotrexate? There are so many good drugs, let us give that. But why? When the guidelines are clearly saying there is no drug till today which can work as well singly as well as the best of best targeted and biologicals, they don't work that well unless you combine it with methotrexate. And I'm emotionally connected with methotrexate because I used it for the first time in 1968 in autoimmune diseases. So anybody talking against methotrexate, I get very upset. And I'm again aiming again those who are non-rheumatologists because they have all kind of issues. And now I have 3 or 4, I can show it here, and Kapoor has more. The type of schedules they keep on giving in methotrexate. And the most wonderful was that I saw 3 days ago. 2.5 milligram on Monday, then 5 milligram Tuesday, Wednesday, and then on Saturday, 2.5 in the morning, 1.5 at night, or something like that. I've taken a photograph of that. Please don't do any such rubbish things. It's once a week drug. But remember that if you go above 15 and you want to give oral, split it into equal doses at 12-hour interval at night, and then next morning breakfast is the most ideal way to give it. And lastly, one small point. No, we can't give it because everyone has intolerance. They start vomiting. There is an anticipatory side effect. डॉक्टर मालविया का नाम सुनते ही उल्टी आने लगती है वो उनका क्लिनिक का शक्ल देख के हमको उल्टी आती है वो उसका रेफ्रिजरेटर में जो पानी रखते हैं हम पी नहीं सकते तो दिस इज एंटिसिपेटरी एंड इट इज ऑल ड्यू टू the adenosine receptors in the central nervous system. Now, why can't you just cover that adenosine receptor in CNS and read my papers?
Definitely.
Coffee and caffeine. And I can tell you, if you don't like to take coffee, 6 cups a day, I do. I mean, it prolongs life. You can give Sting. There's a new red, small little drink which children keep on taking. Or dark chocolate. Big pieces, 2 of them. And especially obese ladies, sorry. It's not sexist remark, but obese people also here. Obese men also here. They love to take dark chocolates, 2 big pieces. And after that, the adenosine receptors are covered by caffeine. And this problem, after about 3 weeks, it never recurs. Very peculiar. And I don't know the reason for that. And then they get stuck to methotrexate for life. And you just saw the man this morning who is on methotrexate now, 30 years, 40 years, nothing. Last but not the least, methotrexate never produces any lung disease except acute hypersensitivity pneumonitis, which is so rare that we don't see it. In fact, in interstitial lung disease, and you showed it beautifully, I'm so happy. Even American College of Rheumatology, which is so it will never recommend anything. It says, well, now you can give methotrexate even in ILD. Thank you.
So, rheumatology. I mean, I tell you, definitely, at IID also. The last question. Right.
Good afternoon, sir. So I wanted to know, just like there are KDOKI guidelines in CKD and ASLD guidelines in CLD for dietary recommendations, are there any dietary recommendations for rheumatoid arthritis also?
There is no such dietary recommendation in RA, but yes, usually what we, that obesity is one of the major risk factor for rheumatoid arthritis disease activity. So we usually recommend those things which increases the weight should be restricted. And many anti-inflammatory diet we have that some more fruits, vegetables, and some omega-3 fatty acids. The products which are having this anti-inflammatory can be taken in higher quantity, but there is no such recommendation that I know. Thank you so much. Thank you so much.
Thank you so much, sir, for such an elaborative discussion. Next, I would please request Dr. Sujata Sani, ma'am, for the upcoming discussion to come on the stage.
Welcome, ma'am. Dr. Sujata Sahani is a senior consultant in the field of pediatric and adolescent rheumatology. She limits herself to this area and leads a team of doctors at the Institute of Child Health in Sir Gangaram Hospital. Welcome, ma'am. Looking forward to your talk after adult RA. It will be interesting to hear a little bit about JIA.
That's fine. Thank you so much. Good afternoon, everybody. I'm standing between you and your lunch, so I'm going to make this really brief. I'd like to congratulate Uma for this wonderful conference and giving me an opportunity to talk to you today. So I'm going to talk about current management guidelines and recommendations in juvenile arthritis. Now, these are standard papers which are usually published by the American College of Rheumatology. They're available free text online, and you can go and look at them and look at what the recommendations are. What I'm going to do is to spend a little bit of time on the ethos as to why these guidelines have been developed, and I'll talk to you about the nuanced approach to the child who presents with arthritis. So juvenile arthritis, first of all, is an umbrella term, and it encompasses a very heterogeneous group of inflammatory arthritis. And amongst these groups, we have 7 classes, as you're all very well aware about. And these classes were put forward by the International League Against Rheumatism in the year 2001, thinking that these are clinically homogeneous conditions. And if you go back and look at the genetics of these patients, you will then probably get the answer as to why these clinical phenotypes are so homogeneous. However, it didn't work out that way. And when genetic studies were done, it was found that, in fact, these patients are very heterogeneous genetically. And this ethos that was developed for the classification system is not holding very well, such that the current classification system is under revision. And you will expect to see something very dramatically different in the next 6 months to a year. And then you will see that the classification of juvenile arthritis will be aligned to what's happening in the adult world. So let's pick up an example of a child with systemic arthritis. These children, if you have 100 children with systemic arthritis, they actually fall into 2 groups. The first group is an auto-inflammatory phenotype, where the child has very significant fever and rashes and organomegaly, and they calm down very dramatically with steroid, and then they do not develop very difficult arthritis. However, all of us who've been in this field for long enough know that we struggle with the second group of patients who have an autoimmune phenotype, and once the systemic features die down, they have very difficult to control arthritis. And honestly, it may be worse for the child to have the second phenotype of systemic arthritis than develop acute leukemia. We know that acute leukemia of good risk is 90% curable, and the child takes chemotherapy and is off medication and has a wonderful quality of life for decades. But if you are stuck with the second type of systemic arthritis, believe me, it can be very disabling physically for the child and mentally for the treating team. Extremely difficult. Let's pick up this other so-called homogeneous group of enthesitis-related arthritis. Again, these children are very heterogeneous. We have the child who presents with repeated acute uveitis, and that can sometimes blind the child. We have an occasional patient with isolated inflammatory back pain. We have the other child with recalcitrant enthesitis. And then we have a child who gets ankylosing tarsitis because you cannot control the inflammatory disease of the midfoot. Now, clearly, you can't have one treatment paradigm for a child with enthesitis-related arthritis. So what is this got to do with the recommendations? It's got to do with the recommendations that you have to personalize the treatment choice for every patient. And what does that depend upon? That depends upon, broadly speaking, what is my disease category. For instance, if I have systemic arthritis, then I'm not going to choose an anti-TNF therapy because I know that the drivers of disease are IL-1, IL-6, and IL-18, and I'm going to choose one of those cytokine blockers. What about the disease burden? If I have a child with oligoarthritis who's running around like a lunatic in the room and has one swollen knee joint, that child has to be treated very differently to a child who has got oligoarthritis with a fixed contracture of the knee, who's non-weight bearing and has got an aggressive uveitis. Then I've got to look at the prognostic features of the subcategory in front of me. So in a child with polyarthritis, if my patient is rheumatoid factor and or anti-CCP positive, we know that as a group, these patients are going to have an adverse prognosis. So my treatment choice is going to then be guided by the positivity of an anti-CCP in a patient. Let's look at something else that you must take into consideration, and that's the time to diagnosis. We know the concept of window of opportunity is critical for the good outcome of the children. So I tell my fellows whom I've been training for more than a decade that there are only two things that matter in every pediatric rheumatic disease. How quickly did that patient come to the correct team? The second thing is, how quickly did that patient attain remission as defined by objective criteria? Then believe me, it doesn't matter whether you attain remission with rituximab, hydroxychloroquine, paracetamol, whatever. You have to get that patient into remission quickly and see the child early. And therefore, when you have a late presentation, that is an adverse prognostic feature. So if I have a seropositive patient who's come to me 3 years after treatment, after diagnosis, and has currently been on some funny Ayurvedic concoction, I would treat that patient very differently to someone I see within 6 weeks. And these are the nuances that you have to pick up as you decide how to manage the patient. I have the bullet and I will use is very different to I have the bullet and I will use this bullet correctly for the particular enemy in front of me. And unfortunately, of course, we are going to look at comorbidities. So if my patient has inflammatory bowel disease in the context of HLA-B27 inflammatory back pain, I'm not going to use secukinumab for that child because I know that anti-IL-17 is not a good drug for an inflamed bowel. And again, if I have a child who's ANA positive and has uveitis, I know I will use a monoclonal antibody to TNF rather than to use a receptor fusion protein such as etanercept. So of course, and then something that we were never trained for is the affordability. So you ask your question then that the current recommendations, and I will show those to you, suggest that a patient with systemic arthritis should be treated with either anti-IL-1 or anti-IL-6 blockade up front. Now, am I ethical to tell a rickshaw puller's daughter that you should start on anti-IL-6 blockade? So what we forget as physicians sitting in institutes like All India Institute is, what about that man on the road? And were you trained that you have to treat the patient in the context that the patient is presenting himself to you, not in the Western context? And unfortunately, the ACR guidelines are only meant for 10% of the children who are born in the privileged part of the world, and not for 90% of the children that we have the very good fortune of trying to help. And therefore, your pharmacological intervention has to keep all these features in mind, has to be early and appropriate. We must have access to a multidisciplinary team, and we must intervene early in these patients. And broadly speaking, the models of care in pediatrics are step up. That is to say, you begin standard and step up to biologic. Occasionally, when you have high risk, high burden, poor prognosis, you may want to step down. That is to say, if I have a patient who has a complicated uveitis and has got a vision of 660, is 4 years of age, and has got uveitis ANA positive with just one swollen knee, then I'm going to use a monoclonal antibody. Why? Not for the joint, for the eye, because I know that if the child is under 7 and doesn't see well, and that patient's occipital cortex is not going to perform, and that child will be subjected to amblyopia, which is lifetime blindness. So we have to be able to understand the exceptions where you're going to use step-down therapy. All children must be objectively assessed, and you can use any objective assessment that you're comfortable with. In our unit, we are very comfortable with the Wallace criteria. We don't use what is called the JDAS, which is Juvenile Arthritis Disease Assessment Score. I find it a bit peculiar that it's a standard of care assessment tool where you stop at a joint count of 10, right? So if you have a joint count of 10 or more, you just get X number of points. But if I have a child who comes to me with 20 joints, and after 8 weeks, that child has now got 11 joints, well, the JDAS is not going to move, but my patient is 50% better. So probably in the Western world, you see children who present to you very early, and they don't have this horrific disease that we tend to see all the time. So JDAS, to my mind, is not a very great outcome tool if you have a child with very high disease burden. So that is again nuanced as to what you want to do. And then the Western population really emphasizes upon the protocol of shared decision making. So you can't, sitting in the United States, tell a mom that, okay, start off on anakinra, 10 milligrams sub-Q every day for the next 5 years. She's going to ask you, what's anakinra? What's the data? Where does it come from? And you have to legally protect yourself. So shared decision making. And I think because of the shared decision making, the ACR recommendations that I'll present to you for juvenile idiopathic arthritis are at best vague. They are vague. They don't talk about the dose of methotrexate. They don't talk about the route of methotrexate. They don't talk about the time interval you have to wait for the methotrexate to be effective. A lot of these are data driven. They are to legally protect the societies. And I think it's also because of a shared decision making. When you have the parents sitting in the room as physicians talk about guidelines, so they are at best vague. And I don't think that anybody can be confident enough to treat a patient after reading these guidelines. What are these recommendations based upon? The recommendations are based upon evidence. And we have double-blind randomized controlled trials, that is type 1 evidence for many of the biologics which are used. And all the trials in pediatrics have used one protocol. So all the children are given the trial drug in an open-labeled fashion. After X amount of weeks, the responders are then shifted to a double-blind trial. And the double-blind trial, 2:1 ratio, you give the trial molecule versus placebo. After X amount of weeks, you unblind the trial. And then all the responders are given the drug in an open-label fashion. So when you're giving in a blinded fashion, the trial molecule versus the placebo, you're looking at the time to flare. And the second very interesting thing is that when you look back at all the trials, whether it is adalimumab, infliximab, etanercept, golimumab, all the patients that have been recruited are the ones who have a polyarticular course, not a polyarticular onset, a polyarticular course in which will be included enthesitis related, psoriatic, the extended oligo, the seropositive and the seronegative. So it's a disparate group of children who have been given the drug. However, this classification paradigm has not been followed. And then if you look at the ACR 70 response, which is a very robust response, you see that whether the drug is sub-Q or IV, there are some differences, but most of the molecules are giving more than a 60% ACR 70 response, which is very robust. And when you look at the trial data and look at all the biologics which have been used, you see that the percentage of patients who flare on placebo, which are the bars in yellow, is roughly twice as much as the patients who flare on the originator molecule. So again, very robust data that is showing us the evidence for these recommendations which are now going to follow. If we keep it really simple, you look at this paper which has been published in Nature Reviews by Professor Alberto Martini from Italy, and it's a wonderful paper that talks about the paradigms of management. Essentially, when you have a child with less than 4 joints that we call oligo, you can start with an NSAID monotherapy, but very quickly. Now that very quickly depends upon how impatient you are. Between 2 to 6 weeks, you should step up to an intra-articular steroid. If the patient is not responsive, how much time do you need to wait? Not mentioned, but it's prudent to wait for at least 4 months. You could then go ahead and use methotrexate. And if the patient is still flaring in a further 3 to 4 months, you could go ahead and add an anti-TNF therapy. So that's broadly for the oligo patient. For the poly patient, you should start with methotrexate. 3 to 4 months, your patient is not responding, add an anti-TNF therapy. If you look at the data from the British Society of Pediatric and Adolescent Rheumatology, the BSPAR, the most commonly used molecule is adalimumab, followed by etanercept, followed by anti-IL-6 blockade on the sub-Q route. And I think the reason to use adalimumab much more than etanercept is the fact that in the Western world, 60% of the children you see are oligoarthritis, and those children, 70% are ANA positive, and that's the group that is going to get the uveitis. So if you want to use an anti-TNF therapy, again, it's nuanced and they don't talk about it. But if you read between the lines, you use a monoclonal antibody in an ANA positive oligo patient, even if that child does not have uveitis, because we know that etanercept is known to trigger uveitis flares in children who've never had uveitis prior to being given the etanercept, right? So that's the polyarticular cause. Methotrexate, not working. Anti-TNF, not working. The data suggests better to switch to a different class rather than a different molecule and a subtype of the anti-TNF therapy. When you have systemic arthritis, the current data, and I'll show that to you, suggests anti-IL-1 or anti-IL-6 upfront, which is clearly not possible in our country. And all these children, you should follow the treat to target strategy. So your objective assessment should bring you down to a 0 physician score, a 0 patient score, a normal acute phase response, no febrile features, no active uveitis, and no active joint. And that's a time point that you cannot achieve for a child who presents with late disease, where you may want to go to what we call minimal disease activity. And again, that's got different cutoffs depending upon what kind of outcome measure you want to use. And for these children, you have to personalize the choice by doing a regular assessment of the disease activity, by changing the therapy at regular goals to achieve the target, by sharing the decision making with the parent, by making sure that you've abrogated inflammation, and most important, avoidance of long-term steroids. So remission in juvenile arthritis is remission without steroids. We cannot use 1 milligram per kg ad nauseum in a patient who has systemic arthritis and think that, we've done it because the child has 0 disease activity. So it has to be remission without steroids. And for the first time, the treat to target strategy has suggested that we should have a 50% achievement of the disease activity, reduction within 3 months, and remission within 6 months. And when you talk about disease activity, you have to look at all the domains of disease that that particular patient has. And once you achieve the target, then you monitor the patient carefully. There are several outcome measures. We won't go into those details. And with that background, you now have just published hot off the press. You have the guidelines for oligoarthritis. The boxes in deep green are those options which have got a strong recommendation, and the light green ones have the conditional recommendation that depends upon the level of evidence. So oligoarthritis, treat with intra-articular steroids. Not doing well, step up to Methotrexate. Not doing well, go ahead and step up to an anti-TNF therapy. But there's no consensus for duration of NSAIDs. Sub-Q Methotrexate is preferred. There's no discussion on the dose. And of course, you must avoid oral steroids. And these pictures just show you that how you treat the child in panel 3 will be very different to how you treat the child in panel 1. There's a separate recommendation for the temporomandibular joint. Interestingly, this is one joint that you should not inject willy-nilly. Only inject if the patient is symptomatic. Why TMJ? Because TMJ growth is occurring in children. And if in case this joint is involved in juvenile arthritis, you can get tremendous deformities of the face, and you want to avoid that. So you have 2 children showing you jaw asymmetry and a child showing you micrognathia. So if the child has got TMJ involvement, please step up to Methotrexate quickly. If the child is yet not doing well, step up to anti-TNF. Only if the child has got significant symptoms, then you should inject the child. And that's because you can damage the disc which is present within of the TMJ. So it's one joint which is an exception that you shouldn't be very gung-ho in injecting. The systemic arthritis child, like I said, whether or not the patient presents with macrophage activation, the upfront therapy is anti-IL-1 or anti-IL-6, and I think this is not possible. Methotrexate goes right down, and it is used after anti-IL-1 or anti-IL-6 only if the child has got persistent joint disease. And very interesting, a moderately sick child with macrophage activation syndrome can be treated only with anti-IL-1 or anti-IL-6. I have strong exceptions to this recommendation. If you see a child on 1st May who's moderately ill and you give an anti-IL-6 blockade, how do you know he's not going to be severely sick on 2nd May? So we don't have the courage to use upfront biologics, especially with the absence of anakinra. If you give anti-IL-6 blockade to a child whose blood culture turns positive after 48 hours, you're done because the drug is in and is there for 15 days. I don't think these choices can be directly translated to our population at all. So those recommendations of 2022, and then you have the older recommendations for polyarticular GI, and this is exactly what I showed you with Professor Martini's paper. We then have recommendations for sacroiliitis. This very much follow the ASAS recommendations. Therefore, sacroiliac disease, you use NSAID. If the child is not doing well, you go ahead and use anti-TNF therapy. This recommendation does suggest that you can use sulfasalazine for SI joint disease after NSAID if the patient has a contraindication to anti-TNF therapy. So that is mentioned. There's a detail on how to manage enthesitis, which is again NSAID, and if refractory, go ahead and use anti-TNF. So like I said, there are many ambiguities which have been left unaddressed. What's the timeline to step up or step down? What's the route and dose of methotrexate? You must individualize the approach. So for instance, if I have a child who has marked improvement with some disease, I might want to wait some. But if I have a child who has very aggressive disease with not much change, I may want to step up sooner. So because clinical care is nuanced, timelines have not been mentioned at all in these recommendations. And there's no discussion of what you do if you come from a resource constrained background. And these publications have just come about last month, so just a few weeks ago. And subsequent to that, we have 2 more licensing for GI. One is the use of tofacitinib for polyarticular GI, which is licensed by US FDA and the European Agency for methotrexate and anti-TNF failure, not as a substitute for methotrexate and not prior to anti-TNF therapy. We also have the new licensing for secukinumab for enthesitis-related arthritis for children over 4 and for psoriatic arthritis for children over 2. So to conclude, I work in a wonderful institute. I've been here for more than 2 decades. But we look after children who come from rural backgrounds. We look after children who have lots of roadside vendors who try to offer care. We have a lot of societal pressure for alternative care. We have very poor health insurance coverage. We don't have a healthcare coverage for the 1.33 billion, which I'm told as this meeting is going on, has gone up to 1.34 billion. And the public expenditure from the government is abysmal. If you look at the data, we spend $16 per capita on health in India, and Switzerland spends $6,944 per head. We have one of the richest people in the world, and then we have the kid who scavenges to survive. So to my mind, I think the biggest difficulty we face is not following the GI recommendations from the American College, but how do we address the issue of inequity and poverty that we as clinicians face every day? And for the children who come to us, those little girl children, they have no advocates. They can be taken to homeopathy, to Ayurvedic. They can be given no treatment. They can get osteoporotic fractures. They can become blind. We have no social service. We have no child advocate. And one fine day, we get nasty reviews in Google where people say that we went and met Dr. XYZ. I'm finishing. Last line. We went and met Dr. XYZ. And, my child is today blind and XYZ should never be gone to. So that are the problems that we grapple with, not the ACR recommendations. Thank you.
Thank you, ma'am, for the wonderful talk, and I completely agree with you that the poverty and the inequality in our country, but I think things are getting better. And ma'am, I would like to share something like we had a patient with systemic onset JIA, came with severe refractory mass. We treated him with methylprednisolone pulse and cyclosporin, but she did not respond. But we were able to procure anakinra for her, and anakinra is a wonderful drug, and we have given that child anakinra for 3 months now. And initially, as we tried to taper the pulse after 5 days, the patient continued to have fever, and we were waiting for anakinra. So another modality which I have used in 2-3 patients and they respond very well is the tapering of the pulses. Like you give 30 for 3 days or 5 days, and then you can go on to maybe 20 for 3 days, then go on to 15 for 3 days, then 10 for 3 days, then 5 for 3 days. I think they published from PGI Chandigarh a small correspondence to that effect, and that patient does very well. So, ma'am, I think we have to keep on being innovative, and I think you did a wonderful job with the talk. Thank you so
Thank you. My remit was ACR. My remit was recommendations. Of course, we do know how to innovate and use the steroids,
Yes, ma'am.
but can you see that it's not mentioned in the ACR recommendations
Absolutely,
upfront?
ma'am. That's it. I think Malviya sir has a
Yeah, I know we are short of time, but if you want to learn diction, voice modulation, and how to express yourself in a language, which I think is first language for her, we all learned how to speak this language. Sujata, you are great.
Thank you, sir.
But I would like to just mention one thing. for those again who are non-rheumatologists, a child with one swollen knee is not TB. A child who has two swollen knees, one earlier and now, is not rheumatic fever. They are all what you were talking. And I think people should understand that and stop this nonsense of a single joint TB, TB, TB. Why TB? They haven't learned about GIA?
Thank you, sir.
Sad part is that most of them undergo arthrotomy in the private sector, and it's sad when they come to the clinic with, ठीक हो सकता है बच्चा आप उसको operate कर देते हैं. It's very very sad. Biopsy.
Hey, Dr. Anu, I have to take exception to that comment you made about private sector. I can show you a lot of goons in the public sector, so I'm sorry, I take exception to that comment. Thank you.
I didn't mean it like that. I meant the orthopedicians in whatever sector.
Thank you.
Thank you so much, ma'am, for an informative and interesting discussion. I would like to invite our next speaker. It's my pleasure to call upon Dr. V. Chaturvedi, sir, for the next discussion. And I would request the chairpersons to introduce him.
I can't have enough words to pioneer and trailblazer committee. Was one of the earliest alumni from his place now, my senior. He has been a visiting professor at Kennedy Institute of London. He has been ex-president of Indian Rheumatology Association and Delhi Rheumatology. He has been forced to establish the department at Artery Hospital. Now, flourishing department. So presently, sir is working at Sir Ram Hospital as a senior. He has been a pioneer as one of the earliest persons to be able to use biologics in our country and has tremendous experience the way to this. Sir, over to you.
Thanks for the kind introduction. Respected Chairperson, ladies and gentlemen, at the outset, I must thank Dr. Uma. After a long time we are meeting, we are so excited about it. Excellent. As introduced, I was working earlier in this hospital. Youngsters may not be knowing Army Hospital. Now I'm working in another equally good hospital. And my brief is to talk about this. Look, surprisingly, whether early disease or late disease, recommendations for ankylosing spondylitis are same. So that's very important. So don't have much issues, whether it's an early disease or a late disease. You can call it radiographic or non-radiographic or early disease or a bamboo spine. The recommendations are same. So that's very interesting if the recommendations are same. And also for the ankylosing spondylitis in females. So the recommendations are all same for all. The four broad categories of approved treatment. Very simple. You have inflammation. You have inflammation, so you have an anti-inflammatory drug. And we know physicians and orthopedic surgeons, everybody knows about the NSAIDs, how to use them, which one is good, which one. So first drug remains the anti-inflammatory drug. And of course, the physiotherapy or physical exercises. And other drugs which we are using for last 20 years, anti-TNF drugs and IL-17 inhibitors which have been added. The guidelines, don't try to read about all those societies, Spartan and this. Basically, ACR and ULR, these two leaders, they employ people and then they join together and then they may make guidelines. And we have been reading, especially students, that 2016, the ACR guidelines came, and 2019, it was supported by the Spartan group, and now the ULR guidelines came in 2010, and now in 2017. Mostly they are similar, if you really ask me, what we are practicing. And there are a few differences which are there, which have been discussed by earlier speaker, how these guidelines are made. If youngsters also sometime, if seniors are sitting, they must know how these guidelines are made. These guidelines are made based on evidences, recommendations, Some people call it guidelines. Somebody says the recommendations. They don't call rules. No, basically, these are all guidelines only. And every time methodology change, sometime you raise about 70% people say, okay, this should be used, TNF we are using. So that is how it is. So great methodology is used. The most important slide is this, which Dr. Sujata was also talking about. Applications of these recommendations must be individualized. These are not Bible or Quran or something that has to be. So these are the recommendation must be individualized, requires careful assessment. You just don't read and start practicing. So careful assessment, sound clinical judgment. Now, what is a sound clinical judgment? It comes from training, it comes from experience and patient preferences. Look, I'm a poor person. I can't afford anti-TNF. So definitely I'll choose other drugs. So patient preferences are also very important. You must remember. Now, non-pharmacological, a lot of people ask what should be done in ankylosing spondylitis. So we all know that yes, there are evidences that physical therapy and regular exercises is as important as pharmacotherapy. There are moderate evidences, there are low evidences. The low evidences is probably that it improves pain, stiffness, and spinal mobility. But there is a moderate evidence that it improves physical function, no doubt about it. We know that it improves physical function and disease activity. And there are some evidences are there with that it improves the ASDAS, BASMI, and reduce serum calprotectin level also. Now, if you, I don't know that you should read it, but you must remember, suppose you have ankylosing spondylitis and I tell you to do exercise, you will not do it. But if you're supervised, so that's why it has come, supervised group physical therapy. If you're 10 people sitting there and do a thing, so there is if you do it, this is better. That is what the recommendation is. When we came in, I was doing my DM from SGPGI, a lot of stress was there on the swimming pool and the aquatic. So the recommendation is land-based physical therapy interventions over aquatic therapy, because aquatic therapy is probably difficult to organize. Patient will keep searching for a swimming pool. So you must remember that land-based physical therapy has been advised. And of course, the screening for osteopenia and osteoporosis should be done. NSAIDs. Now that's very important, close to everybody, whether it's a rheumatologist or orthopedic surgeon. Patient asks, should I take daily? Should I take continuous? So continuous NSAIDs over on demand. A lot of people may object that people will not take, especially Indians. So that's why the first slide, individual. If I'm a South Indian taking a lot of chilies, or if I'm in Punjab taking a lot of chilies, so you have to modify. As a good clinician, it's not that you have just written take NSAIDs every day for whole life for 2 years, 3 years, 4 years. So recommendations are there, no doubt about it, that if you take a continuous NSAIDs, they are better. They stop probably there are papers, which I don't want to read those papers, that yes, it definitely improves the structural damage. So it stops the structural damage, but on demand, over on demand. So people ask, Doctor, मैं बार-बार कभी भी ले सकता हूँ? So we say, if you can take continuously, it is better. Then we explain it. And 50% achieve control with NSAIDs alone. This is the first drug of choice. This should be initial treatment. And if you are a good clinician, you ask, believe me, if you ask, Doctor, when I take this, though I don't take it daily, but if I take this, it improves symptoms. It improves peripheral arthritis. It improves uveitis. It improves enthesitis. So everything it improves, no doubt about it. There's no preferred NSAID. Which one? Which one to take? Nobody knows. The patient asks, Dr. Malviya ने तो ये दिया था, अब मुझे सूट नहीं कर रहा. मैंने कहा तुम दूसरा ले लो. So basically, it is just patient preference called cafeteria choice. So a lot of people ask, what should? So it's a cafeteria choice. Patient will say, okay, doctor, मुझे ये पसंद है. Try. If one is not working, another one, and try for 2 to 4 weeks if it works. Don't give it up that it is not responding. Then after NSAIDs came the anti-TNF. This man in 2002, 20 years back, not now, 20 years back, Lancet paper, double blind, yes, anti-TNF works in ankylosing spondylitis. When nobody believed it, British didn't believe it. He was a German. The people who discovered anti-TNF, who made anti-TNF, they didn't believe it will work. The story of ankylosing spondylitis, youngsters, you must remember, it was like osteoarthritis, that nothing will work. I have seen it. I have seen it. Dr. Malviya has seen it. Our generation, Dr. Malviya is much senior, that we thought nothing will work probably. So then it came anti-TNF. It was in 2002. And I always show this. Why I show? Because I have worked. In 2002 to 2004, I had Jurgen Brown tried on 27 patients. I had about more than 100 patients in Army hospital because I had a drug for rheumatoid arthritis. I had patient also. Army is full of the male patients, so more ankylosing spondylitis. And we presented also. This was our first patient in 2002. That time only infliximab came. And we presented also in APLAR that yes, they are effective. And if you use judiciously without loading dose, no tuberculosis. Then these are the recommendations. Now, this is the recommendation of ACR that anti-TNF works. So since probably I've seen this doesn't work, anti-TNF, whether you use 1, 2, 3, don't remember, you all know as a student, yeah, this works. So basically A, B, C, D, E, whatever anti-TNF you use, it will work. And it will work about 40 to 50 years. So if you take a ACR 40 response, almost roughly about 50% patient will respond. 50% patient may not respond. Some works better, like we know it, if you see this, the golimumab response is roughly about 54%, better than others. But it responds whether you see for axial disease or a peripheral disease or enthesitis, dactylitis, uveitis, IB, everything it responds. Yes, if somebody has a uveitis, somebody has a IBD, we know this, we use the monoclonal antibody, so we use etanercept. So whether it is in the clinical trial in ankylosing spondylitis, you see this is ankylosing spondylitis. Okay. So use the TNF inhibitors, it works. Then sorry. So use the NSAID, then it works. I think it's disturbing whatever is happening. I really don't know. So the TNF is the first line of therapy. It is basically recommended over IL-17. No preferred TNF. When to use biologics, these are the EULAR rheumatologists. The diagnosis should be done by a rheumatologist. And with the active disease like elevated CRP or positive MRI, and failure of standard treatment, at least 2 NSAIDs over 2 weeks. Patients with predominantly peripheral arthritis, Shefali is here, that yes, sulfasalazine also works, but as per recommendation, it works in peripheral arthritis and high disease activity when S-DAS and BICE-DI is high and positive rheumatologist opinion. And when the TNF failure, and what is a, I think this, is it audible? Okay. So, when the TNF, what is a TNF failure? It is basically if the TNF fails. How it fails? Suppose you are giving infliximab, and it is working, and after say I think it's not working. If first TNF is working, then you can use another TNF. But if you use TNF, it doesn't work. So in primary failure, you change to IL-17. If a secondary failure, then you choose to another anti-TNF. That is how this slide says. The IL-17 inhibitors is when anti-TNF fails or anti-TNF are contraindicated. So what are the contraindications for? These are the contraindications. Since we are all using anti-TNF, this slide is very important. You must read this slide that yes, there are contraindications to anti-TNF. Probably in a busy clinic, so basically either a congestive cardiac failure, demyelinating diseases, previously untreated tuberculosis, recurrent chest infection, septic arthritis, last batsman. So if the IL-17, this is the tofacitinib, it works. It is like वो एक फिल्मी गाना है ना कि मैं भूल रहा हूँ अभी because of this, that everybody is prescribing tofacitinib. If you really ask me, even the recommendation, it works on axial disease, peripheral disease, enthesitis, dactylitis, uveitis, skin, except if you are, since morning we are discussing the JAK inhibitors, you must remember the first question you should ask about when you're using JAK inhibitors, IBD. IBD is very common, and we are missing IBD. So contraindicated in IBD, that's very, very important. So this is the last drug which you use. So basically, it's a active AS despite treatment with NSAIDs, and when the anti-TNF, either they are contraindicated or they fail, then you can use the tofacitinib. Stable disease, I think I have 1 minute, so I'll try to finish. If your disease is stable, there are guidelines for ULAR and ACR. The ACR says, as Sujata was mentioning, tell me, if some patient asks me, can I take it whole life? The ACR says, you can't reduce it. You can't taper it. You can't change to biosimilar. It's probably there are some, definitely a commercial bias. While the ULAR says, if 6 months the disease is stable, if patient is comfortable, if patients are is asymptomatic or acceptable level, then you can reduce the dose. So dose reduction and tapering is very, very important, and we must learn this crowd how to taper the dose, and we must follow the ULAR guidelines rather than ACR guidelines. Steroid basically is no role. Systemic steroid has no role. Yes, locally you can inject, and T2 target strategy is no more. So ACR has made it comfortable that you need not to make the T2 target approach. If you are a clinician and if you feel the disease is stable, asymptomatic, then you can see it is a T2 target. Every time you are measuring, all this is not required. Comorbid condition, iritis, you must include ophthalmologist. IBD, as I said, you should remember that you should not JAK inhibitors. So the last slide is this. I'll just come to the last slide. The first line therapy is physical therapy and NSAIDs. Then you can use TNF inhibitors. If the TNF inhibitors fails, then you can use IL-17. You can change between TNF inhibitors if there is secondary failure, and tofacitinib in active disease despite NSAIDs. No role for systemic steroid. There's nothing like T2 target strategy. As a good clinician, you are the one. You decide what is an active disease, and comorbidity management should be multi-team approach. You must involve the eyes ophthalmologist, and role of surgical management is important. That you must remember this slide. There's no role for spinal osteotomy or spinal manipulation. So that's very important. A lot of people come, a lot of people are there. If you have this kind of testing, there's no role for spinal manipulation or spinal osteotomy. Thank you, ladies and gentlemen. Thanks.
Thank you, sir. Thank you. We are just a minute of time. Organizers have requested for no questions after this.
Okay, thanks.
Absolutely. Thank you. But it was a wonderful talk. Thank you, sir.
Thank you so much, sir. Now, may I please invite our last speaker of the session on the dais, Dr. D.S. Bhakuni, sir. If I may request our distinguished chairpersons to introduce him.
Afternoon. At the outset, I'm thankful to the organizing committee for giving me the opportunity to hear this important session. It's my honor to invite Dr. D.S. Bhakuni, sir. And sir he's a consultant rheumatologist at Manipal Hospital, Dwarka. He has more than 40 years of experience. And he has a special interest in inflammatory arthritis and osteoporosis. And without wasting much time, I request sir to start the proceeding. The topic is on psoriatic arthritis. What are the current recommendations? Over to sir, please.
Thank you, the chairperson, and thank you, Dr. Professor Uma, for inviting me. My lecture is very simple. It's not for the 2 benches or 2 rows who are sitting in front. They can go to sleep. But I could see some of the back benches, they were sleeping. It's such a simple lecture. It is meant for all of you. No strings attached with this lecture. absolutely simple. And am I audible? Those who are sleeping, they can wake up. Now, the topic for today's talk is current management guidelines and recommendation in psoriatic arthritis. Now, let's see, why should we know about psoriatic arthritis? Because we hardly see the patient of psoriatic arthritis in our day-to-day practice. But it's important because 30% of the patient of psoriasis, they develop psoriatic arthritis. That's important. And 20% of these, out of these psoriatic arthritic patients, they have permanent joint deformities and loss of function. And psoriatic arthritis occurs usually after 5 to 12 years. However, it may accompany the skin lesions. But when does the problem occur? The problem occurs when it comes before the skin lesions. So how do you diagnose? How do you suspect? The few features are the involvement of, the occurrence of dactylitis, that is uniform swelling of one of the digits, either toes or either fingers. So if you have dactylitis and the patient has come to you, after ruling out sickle cell disease, tuberculosis, sarcoidosis, and bacterial infections, please suspect that the patient may be having psoriatic arthritis. And next is DIP joint involvement. All of us know that very few diseases has involvement of, they have involvement of DIP like osteoarthritis, reactive arthritis, all those things. But suspect psoriatic arthritis in these conditions. Now, the remission is also possible like in rheumatoid arthritis. That's why we must treat these patients as early as possible. And 60% of the patients of psoriatic arthritis, if they are on biologics, they go into remission. But what happens? The moment they go into remission, we tend to taper the disease or stop the disease, or the patient may himself or herself stop the disease. But remember that the disease comes back with a vengeance. So we should be very, very careful while treating and tapering or stopping the treatment. Now, what should be our strategy? The typical strategy is treat to a target strategy. It was supported by International Treat to Task Force, ULAR and GRAPPA. And why this treat to target approach? Because it has shown that there are significant benefits in disease outcome, the quality of physical function of the patient, and the quality of life. The overall quality of life improves. And all these things are possible because we have the newer insight into the pathogenesis of this disease. Now, this TICOPA trial, just forget about that. The good points what we have taken from TICOPA trial is that if the patient is treated, the aim should be having that the patient should have minimal disease activity. And how do we know that? The few of the points should be less than 1. And what are those points? Less than 1 tender joint, swollen joint, PASI score, and enthesitis point. And few of the points are like patient VAS score or visual analog score should be less than 15, global disease activity of the patient should be less than 20, and HAQ score should be less than 0.5. This should be our target when we start the treatment of the patient. But what is the irony? The problem is that only 56% of the healthcare professionals, they stick to this kind of treatment, this kind of strategy. And what was the target basically? To have achieved the minimal disease activity. But disadvantages are also there, because if we go for this tight control or the treatment of the this disorder, there's an increased adverse effects because we are using much more medicine and much more powerful medicines, increased visit to the hospital, and increased expenses. And the most important thing is that therapy should be individualized. Discuss with the patient, sit with the patient, tell him that this will be the expenditure and this will be the outcome, this will be the adverse effects. Or do you prefer oral medication or do you prefer injectable medications? You have to give time initially to the patient. And that is what I've written, that patient education and doctor's role is enormous in our country, where we have less resources. In abroad, foreign countries, they have the insurance, but our patients, they do not get the insurance except those patients who have, they are panel patients. So we have to sit with the patient, make them aware, chart a plan of treatment that suits the patient. The cost effectiveness, just a comparison. In our country, it takes around 30 to 40,000 rupees if you are using biologics also, like tofacitinib or baricitinib, not the injectable biologics, per year. Look at the cost involved outside. Without biologicals in US, it's around $5,000 per year. With biologics, 4 times more, 20,000. I'm not audible. Who all are sleeping? Raise your hands. No one is sleeping. Okay. In UK, with biologics, again, 20,000 pounds. So the enormity of the expenditure matters. But luckily in our country, we can do away with that. Of course, if the patient is of middle class or if he has some kind of help. And that has been made possible because of the reduced doses of JAK kinase inhibitors as well as other biologics. Biomarkers, not very important. The treatment. Two categories of patients we can have with mild psoriatic arthritis where there is an involvement of 4 or less than 4 joints, no radiological evidence of any damage, and minimal functional impairment. Beyond that, everything is either moderate or severe. And what are those poor prognostic markers where we can, talk to the patient that, look, the outcome may not be that rosy as you have been told. So what are those things? The increased number of inflamed joints, increased CRP level or ESR, failure of previous medications, presence of joint damage, and loss of function and poor quality of life. You must raise the red flag. Look, I am trying, but the outcome may not be as good as I expect. So EULAR recommendations. Now I'll be coming to the recommendations, EULAR and ACR recommendations, that's all. Again, the target is to get the remission or low dose activity. They have recommended that for the musculoskeletal activity, just give symptoms, just give NSAIDs, which I'll tell about later on why shouldn't we stick to that. For local enthesitis or arthritis, they have recommended local steroids, where all of us give, and avoid systemic steroids. But I will not agree with this because if you avoid systemic steroid and if you can give them in low doses, the patient will bless you. I haven't seen any aggravation of skin lesions for last 20 or 22 years. I was speaking to Professor Malviya sir. He has also not seen. But I was participating with the dermatologist friends. They were very chary that they said, we do not give any steroids, thinking that skin lesions may be aggravated, which I have not found. Pharmacological therapy, few terms like OSM, oral small molecules, all of us, we know that methotrexate, sulfasalazine, leflunomide, and anti-TNF inhibitors. My lecture is basically a repetitive lecture. All those 3 speakers who have spoken to you, that will help me. But repetition is a good thing so that something will stick to you and the carry home message will be good. Now, EULAR recommendation, it says that patient with polyarthritis, start with conventional synthetic DMARDs, methotrexate. And we do with that. And patients with mono or oligoarthritis with poor prognostic markers, start with methotrexate again. Patient with peripheral arthritis with inadequate response within 3 months, consider biologics. But what we consider here? JAK inhibitors. Because of what reason? Cost factor. And if with relevant skin involvement, the recommendations say that you must consider IL-17 inhibitors or IL-12 or 23 inhibitors. Peripheral arthritis with inadequate response to any synthetic DMARDs and at least one biological DMARDs, then they have recommended JAK inhibitors. And if mild disease with inadequate response to the conventional synthetic DMARDs and in whom neither you can give biological DMARDs or JAK inhibitors, then you must consider PDE4 inhibitors, which is usually used for the mild disease. Patient with enthesitis with inadequate response to NSAIDs and local steroids, please consider biologics. And patient with axial disease predominance, all of us, we know that we have to use TNF inhibitors, otherwise we do not get any good response with oral molecules. If axial disease with relevant skin disease, the ideal drug will be IL-17 inhibitor, like secukinumab and other things. Patient failing to respond to biological demands is basically jugglery. If one drug does not act, switch over to different biologics. That is what it says. Or patient with sustained remission. Sustained remission means the patient is absolutely all right, or those factors which I told you with the minimal disease activity for 6 months, the cautious tapering. Please have it cautious tapering. That is what they have recommended. Now, ACR guidelines are also similar, almost similar. They were based on systemic literature review and expert opinion. 6%, only the interesting thing that whatever they recommended, 6% recommendations were strong, 94% were conditional. And it also highlighted, sorry? 5 minutes. I am seeing, half of the time I am seeing there only. Anyway, as I told you earlier, they also said that individual is important for the treatment. Sit with the patient and discuss all those things, but about the finances, about the ease or mode of this thing, which I've already spoken. If they have recommended that in active psoriatic arthritis, you have to give TNF inhibitors over the small molecule, oral small molecule like methotrexate. They have said don't start with methotrexate. But again, they have recommended that if the choice is given IL-17 inhibitors or OSM, start with OSM or tablet methotrexate in simple language. Methotrexate is recommended over NSAIDs. Remember in ULR they said for musculoskeletal system use only NSAIDs. But here ACR says no, you use methotrexate or other oral small molecules. And IL-17 inhibitor recommended if possible over IL-12 or IL-23 inhibitors. And if psoriatic arthritis, despite your methotrexate and leflunomide, it does not improve, switch over to TNF inhibitors or switch over to JAK inhibitors. Other considerations. If the patient prefers oral medications, best is oral small molecules like methotrexate, leflunomide, or tofacitinib. If the patient has inflammatory bowel disease, consider IL-12 or 23 inhibitor or tofacitinib, which will be better cost-wise also. If the patient prefers less frequent dosing, consider IL-23 or 12 inhibitor. If the patient has serious infections, avoid all these inhibitors, consider abatacept. If the patient has recurrent fungal infection, consider tofacitinib or JAK inhibitors. If the patient has diabetes, start OSM rather than methotrexate or IL-12, 23 inhibitors. I don't know the reason why have they written. Professor Malviya sir may reply later on. In diabetes, why not methotrexate? I don't know. If with uveitis, of course, methotrexate we can start. Non-pharmacological therapy is as good as the patient asks you, doctor, मैं acupuncture के लिए जाऊं or physiotherapy. Don't say no because he is asking for some certificate from you. Will this be beneficial or not? It will be better than not to have those things. You recommend. The patient has faith on you. He will, improve also with those things. And of course, cessation of smoking and reduce obesity. GRAPPA recommendation, I'm not going to this thing. So take home message. I think I'm going to finish within time. Start methotrexate or any conventional synthetic DMARD at the earliest. Do not wait for the NSAIDs only to act. Local steroids for enthesitis and arthritis must give. Avoid systemic steroids, that is the recommendation say, but in practice, if you don't treat the patient or you don't take away the pain of the patient will run away to some other rheumatologist or any other specialist. Give low dose steroids. What I give, 15 milligram once in a day for 15 days, then 10 milligram for 10 days, then 5 milligram for 1 or 2 weeks. The patient is happy. Never ever I've seen any aggravation of skin lesions. Affordable JAK inhibitors can be started instead of biologics due to cost factor. Watch for the adverse effects. Ask for 4 weekly or 8 weekly, all those tests we are aware of. For axial disease, biological DMARDs, TNF inhibitor or IL-17 inhibitors are preferred. Tapering with caution, as I told you that the disease may come back with a vengeance. So we have to taper very, very gradually. Thanks for listening and viewing my these things. That is what I got.
Thanks so much, sir, for an excellent talk and finishing well in time. I think all speakers have done an excellent job. Please give them a big hand of applause to all four speakers.
Thank you. Thank you very much.
Due to shortage of time, sir, we are not taking any questions.
That's why
Thank
I've
you so
written.
much, sir.
Answers are not guaranteed. That is what I've written.
Thank you so much.
Thank you. You can use it.
Thank you so much, sir, for an elaborative discussion. I'll invite all the respected faculty members and all the delegates for lunch. And our panel session would start exactly 30 minutes after. Please be back at 2:35.
हेलो 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 चेक टेस्ट हेलो ठीक है
Good afternoon, all. We are going to start post-lunch session. I request all delegates to auditorium. Senior resident, Rheumatology, Ames, Delhi. Welcome you all. Post-lunch session of today's program. I have an important announcement to make before next session. Certificate of participation will be given to all registrants and it will be available after 4 p.m. Difference of opinion leads to inquiry, and inquiry leads to. With this spirit, proceed to our first panel discussion. Topic for first panel discussion is pregnancy and lactation in rheumatic disease. We'll try to focus on common autoimmune disorders like rheumatoid arthritis, antiphospholipid syndrome, SLE, and scleroderma. For this, I would like to invite our esteemed panelists to the stage. Our first panelist for the session is Dr. Sanjeev Kapoor sir. I request Dr. Sanjeev sir to kindly come on. Dr. Sanjeev is Senior Consultant Rheumatologist in Indian Spinal Center, Vasant Kunj. Next, I invite on stage Dr. Hemant Sharma sir. Dr. Hemant is HOD of Medicine at NDM Medical College, Turao Hospital, Delhi. He is actively involved in DNB teaching for last 50 years and is an examiner of DNB. Also, joint editor of journal Current Trends in Diagnosis. Next, I invite Dr. Ghanshyam Pangte sir as a panelist. Currently, Dr. Ghanshyam is Professor of Medicine, LHMC, Delhi, and in charge of has been editor of reputed API textbook 9 to. Our next panelist for the session is Dr. Kali Khanna. I invite her on. She is additional professor internal medicine at Chandigarh. She has received many national and international awards, including Young Scientist International Fellowship by Indian and Japanese College of Rheumatology International. Next, I would like to introduce Dr. Atul Kapoor as the moderator for this. Dr. Atul Kakkar, Professor of Medicine and Vice Chairman, Department of Sir Ganga Ram Hospital. He is President-elect of Delhi Rheumatological Association. Sir has received many prestigious awards, Jan Oration Award for Best Physician. Sir, kindly come. Like to
so much, and we'll this very clear. So we have. Let me start with Dr. Shif. The topics. One is rheumatic disease, current, very recent women's health in. Dr. Shifali, can with that, do you think that like what happens to activity?
People who have seronegative rheumatoid arthritis, they fare well in comparison to the seropositive or the anti-CCP positive patients. But there is no data as to the titer is high in rheumatoid factor or anti-CCP that has any correlation with the bad pregnancy outcomes. That data is still.
So that's very clear that the majority of the patients, they have remission. But Dr. Ghanshyam, what happens during postpartum period and during
yes, sir, I think that is also important. Like Dr. third of the patient has a because of immune tolerance during this pregnancy. But there have been studies and which suggest that postpartum period there may be flare of rheumatoid arthritis. So we should be very cautious in these rheumatoid arthritis patients. There has been a series of patients from Norway where they have found that if patients are there like postpartum up to 24 months, almost 2 years, chances of flare of rheumatoid or new rheumatoid diagnosis is increased in those periods. So we should be observing these patients postpartum and patients who are already on disease modifying drugs for rheumatoid arthritis. So we can give some safer drug like sulfasalazine and all, add on or with or without steroid if there is a flare. And just opposite to that, like rheumatoid, we have 2/3 of the patient has better prognosis with the pregnancy, while SLE is opposite to that. So there is more, 2/3 of the patient has exacerbation during pregnancy, but rheumatoid has better prognosis. And postpartum, there is exacerbation.
what about lactation? Is it that period a little different for patients with rheumatoid or it's the...
Yes, sir, but lactation also, there is increased chances of exacerbation because with lactation, there is increased hormone prolactin synthesis, which is a pro-inflammatory state. So this hormone also causes increased flares of rheumatoid. So postpartum period with lactation chances are more. So there are some advocacy that if someone has a major flare, breastfeeding should be taken care of. But still for fetus and all and newborn, breastfeeding should be continued. But flare is there postpartum as well as lactation.
Dr. Heri, just tell us about, like, we know that during the pregnancy, the patients are well controlled, but can we anticipate that and we can improve the outcome in the postpartum period, or how can we improve the outcome for these kind of patients?
I think the best way to improve outcome is to plan for conception till the disease becomes inactive. We should minimize the drug therapy before the plan for conception, which is just safe pregnancy lactation. And we should have a multidisciplinary approach when we manage. Because if the patient are in active state, they become pregnant, we find that there are more chances of having hypertension, ET, premature deliveries, more for gestation age babies, and they have more chances of having severe section. All these things can be prevented if they plan for conception till the disease is under control.
So that is quite clear. Dr. Kapoor, can you just tell us how to treat active rheumatoid with various DMARDs and biological agents which are available now?
As Dr. Himmat has said that we should plan that. I mean, it is recommended that around 6 months remission should be there before we plan the pregnancy. But nowadays, I mean, because the fecundity is low and infertility rate is increasing, so we say that, I mean, whenever I see a patient who is in age group who requires pregnancy, we want to put the patients within 3 months in remission. For that, what I do is we put the patient on the methotrexate, hydroxychloroquine, and corticosteroids for 3 months. If patient is not in the orbit, and increase the dose every 2 months. And if patient is not medical remission, I usually prefer now the tofatimab to be added on the combination therapy because of the various reasons which I can tell. But I mean, I want that within 6 months, patient should be in deep remission and we can able to stop steroids. Once that happens, I shift the patient onto the sulfasalazine for 2 months. If patient remains in remission after methotrexate and tofatimab has been stopped, then we start planning for the pregnancy and patient conceived. Once patient is conceived, as everybody is saying that, I mean, patient goes into remission. So usually for 2 months or 3 months, I do not give sulfasalazine. I give hydroxychloroquine and corticosteroid and intra-arterial injection in between, because although, I mean, we have a safer drugs which are available to us, but still, I feel that, I mean, organization is going on and there is a lot of apprehension minds of patient as well as gynecologists also. So usually I do not give for 3 months. And after that if patient says that we have a armamentarium of drugs which are available to us, which we give. For example, I mean, sulfasalazine is very good drug which is, can safely be given to them. Corticosteroid or intra-articular steroids can be given to these patients. And even if the patient does not comes into remission with consultation with the patient, we can use tacrolimus also in this kind of patient because that is safe in pregnancy. And if patient is still not in remission or is just flaring up, then we have choice of giving TNF-alpha blockers to deep second trimester. And before the third trimester, it can be given. Although satralizumab is not available in India, but I mean, theoretically speaking, it can be given throughout the pregnancy also. The other option which I give to these patients is before going for the pregnancy, time that is up to 6 months or 1 year, patient does not require any medicine. So if patient is seropositive, have high disease activity, not controlled by and requiring methotrexate and as well as corticosteroid, I give them rituximab upfront, and so patient goes into deep remission and they can taken care for the pregnancy. So these are the strategies which I employ for treatment of in pregnancy.
So can you tell us which drugs are big no for pregnancy if the patient is taking that in rheumatoid?
Yeah, I mean we divide these drugs into 4 categories, and moderate and severe fetal risk medicines are there. For example, methotrexate.
So how early after delivery can you reinstitute the methotrexate in case the patient was requiring that? Okay. I think the message is very clear that the disease activity does improve during pregnancy, but in the postpartum period, there is a relapse, and there are certain drugs which are not to be used, which have been mentioned very clearly, and how to treat also has been mentioned very clearly. Now, let's go to the other disease, which is lupus, and let's find out what is the effect of lupus on pregnancy and vice versa. For that, let me invite Dr. Shefali. Can you tell us the effect of lupus on pregnancy and vice versa?
And because of the inflammation, the hypothalamic pituitary ovarian axis is disturbed. So they have a lot of patients cannot conceive in these. First of all, when to plan pregnancy in these in patients of lupus. So they first of all they should be in remission, and generally if any patient has nephritis, that is a bad prognostic sign. And the patient should be on hydroxychloroquine, and that should not have been stopped. So, and there is a big no to there is a big no to 4 or 5 conditions where lupus patients should not get pregnant. One is that if they have a creatinine of more than 2.8, and if the proteinuria is more than 0.5 grams, and if the cardiac involvement is there, or if there is severe pulmonary arterial hypertension, or there is considerable restrictive lung disease. So those lupus patients should not get pregnant. So what maternal complications do we have in patients of lupus? We have, of course, the lupus flare, hypertension, and eclampsia, preeclampsia. All kind of complications can occur during a lupus pregnancy. But in one progress trial which was done, which showed that patients of lupus who were getting pregnant had a bad outcome up till 43% in 1965 to 1966, versus now that lupus pregnancy adverse outcomes are only 17%. So that is the silver lining in the cloud, because now we probably pick up this condition earlier. We are more aware of increasing immunosuppression and dealing with these complications. So as far as the complications for the fetus are there, we have all kinds, again, small birth weight babies, LUGR, abortions, and of course with patients who are Rho and La positive, we always are scared of encountering the neonatal lupus syndrome. So besides this, we have new disease activity indices which are tailor-made for pregnancy, like you have the SLEDAI, we have the SLEPDAI, which is only for the pregnancy. So lupus activity index for pregnancy. So there are different indices which look into disease activity of lupus during pregnancy. And what is more important is that once these patients they come to you, it is very difficult for us to establish the diagnosis of a lupus flare, because there are certain physiological changes that take place in the lupus pregnancy, like the complements. The complements normally decrease in lupus, whereas in pregnancy they increase. So one level, one reading will not tell you or will not differentiate, so serial readings are required. And practically it is not easy to differentiate flare from the eclampsia. So they are the practical problems that we keep on encountering.
So you mentioned very briefly about the autoantibodies which should be done. So let me call now Dr. Hemant. Can you suggest a workup for these patients, a preconceptual workup for patients with lupus?
Conceptual assessment is important to assess the risk of pregnancy as well as fetus. And that take into consideration various factors. What is the activity of the disease before they are planned for conception? What is the organ involved in this? And what is the severity of organ involved? If the organ involvement is very severe, in fact, it's a contraindication for pregnancy. Then we can have various autoantibodies to analyze it, like anti-Rho, anti-La, anti-phospholipid antibodies. Again, the age of the mother is important, because more the age, worse is the prognosis. If there is a past history of bad obstetric outcome, this is again a bad prognostic marker of pregnancy outcome. Similarly, if there is any history of use of any cytotoxic drug before pregnancy, taking all these factors into consideration, pregnancy is divided into 3 profiles, like low risk profile or moderate risk profile or high risk profile, depending on which monitoring can be, frequency of monitoring can be decided and therapy can be decided.
So let me now come to how do we treat patients who got arthritis or cutaneous manifestations during pregnancy in patients with lupus. So Dr. Shefali, can you just throw some light on that? How to treat arthritis and cutaneous manifestations in lupus patients?
We generally give hydroxychloroquine in these patients and steroids. And the only other drug which we can give is sulfasalazine. So we generally don't give anything else.
So is hydroxychloroquine safe, and is the safe, dose is there?
Yes, absolutely. We continue the same dose which the patient is generally having, but the only thing which we have is steroids, which we can increase. So that is the only thing which we give for musculoskeletal involvement, nothing else.
Okay, Dr. Ghanshyam, does it change the management if the patient has lupus nephritis, like, the drug profile, and how would you manage such patients of lupus nephritis in pregnancy?
Yes, lupus nephritis like kidney involvement and brain involvement. These are the major organ involvement and that can be fatal to these lupus patients. And Dr. Shefali already told that monitoring these patients are difficult in pregnancy state. Like proteinuria and all, these are common in third trimester. A lot of protein secretions also changes, ESR, CRP monitoring. But still, we should do the monitoring first to manage this patient. So ideally recommended is around 8 to 12 weeks, we should have an ultrasound of these patients to see the fetal well-being. And we should have a monthly, and this management should be a multidisciplinary approach. So there should be involvement of a experienced obstetrician, there should be involvement of a rheumatologist and a nephrologist who do look lupus nephritis patient. And maybe a later part, a neonatologist will be a good thing to look after because some patient who has anti-Ro and La positivity, they can develop a complete heart block. So these patients may need a regular echocardiogram during later part of the pregnancy, almost 2 to 4 weekly, to see that if there is a complete heart block and they may need a pacemaker. So regarding monitoring, every monthly we should have a urine protein checking, followed by we should also do routine examination, and every 3 monthly we should do complement levels, we should do urea creatinine, and creatinine maybe every monthly we should do. And regarding fear of disease per se, like we have already talked, it may be a lupus
or a nephritis flare or a kidney flare, or it may be a non-kidney flare. So non-kidney flare like mucocutaneous or a musculoskeletal involvement is there. That can be taken care by hydroxychloroquine and maybe a steroid. Ideally in early phase, it should be less than 20 milligram per 20 milligram per day should be used because high dose of steroid may also lead to cleft palate and other deformities. While lupus nephritis, if developed in pregnancy, especially sometimes these patient may have a flare of RPGN or rapidly progressive glomerulonephritis. So that may need a kidney biopsy, which can be done in maybe a second trimester. First and third we should avoid. And if there is a lupus nephritis, RPGN, we should take a decision that how to treat that. Also is a difficult decision. But sometimes taking care of cyclophosphamide is a cytotoxic drug, but still seeing patient condition, we may have to use cyclophosphamide also, second trimester. Otherwise, routine care will be giving a hydroxychloroquine and steroid on a lower dose side. And these pregnancies should be elective pregnancies. Patients should be explained and they should be in remission, ideally 3 months, at least 3 months of remission, because a lot of patient may be on ACE inhibitors and all. So these antihypertensives also has to be stopped at least 3 months back. So ACE inhibitors will be a contraindication for pregnancy. So if we have a multidisciplinary approach, we can take better care of and better outcome of pregnancy.
That's very important, multidisciplinary approach where it improves the outcome. So, Dr. Kapoor, is there any, like you have a personal information about whether B cell therapy can be used in pregnancy in patients with lupus nephritis?
Can be given, regimen can be given. Emergency is there, and we should give because of the fact that it has got the immunoglobulin G1 is there, so it does not cross the plasma. So it should be given, like even in arthritis also, although the studies are not there, and they say the monograph says that at 1 year duration should be there before planning for the pregnancy, but in large number of parents have been found that it is very, very safe and can be given, and it should be given in those, as Pandey is discussing that, lupus nephritis, which is not unable to say cyclosporine or tacrolimus, which can be given in pregnancy and high low dose of steroid and still complements a low DSD that should be given. These can have such a
Yeah, so what is said, basically the literature says that it should be avoided, but since it's a larger molecule, although there is, the drug profile can be found in the placenta, but normally there is no effect actually. So let's come to the next question now. And we were discussing with Dr. Pali during the lunchtime about the contraception, which is an issue which basically we don't discuss with our patients, especially with lupus. And I believe it's a major issue. And Dr. Pali, can you just throw some light on that? Yeah.
Anybody who is pleased not get pregnant, we are answer. Actively they are planning. We all know that there are different barriers. Trend. There is no data available. The IODs will test whether these patients get motivated. So there is no data. These testing there's harmful consequences. Where the progesterone only is that's the best
Okay.
for this get actively involved with their gynecology. Because there are other issues in the lupus. They're APA positive. MMF has a drug interaction with the spine film.
It's,
All that thing.
So, Dr. Kapoor, you want to add something?
What is complicated in the way that when the patient has going for cyclophosphamide or some these kind of territories where the ovum quality or ovum use. So there is a good amount of data which is coming up that we should give DHA to patients so that the follicles goes into the effusion stage. More importantly, people are advocating is that for the they go for preservation of the eggs also. That whenever they go into remission, they can use that. So these things are coming up in the literature, and in India probably we are not looking this aspect very well.
So we all are aware that the antiphospholipid may complicate pregnancy, and so Dr. Kapoor, can you tell us about what are the practical tips which we should be doing to take care of this?
And they're doing and very good. Then there are four types of patients comes to me for APLA with the APLA. That is one are asymptomatic. They have APLA positive because gynecologist asked them to do. So those cases they are asymptomatic. It is patient wanting to become pregnant. My advice is that if it is really positive and 2 times it is positive and IgG level high, that will be. So if the two anticoagulants are high, then I prefer that. Although there is no recommendation like that, but I'm facing. The second group of patients are those who have atrial or arterial or venous thrombosis there, and they become pregnant or any pregnancy loss. So in these conditions, whenever they become pregnant, we recommend that they should be on therapeutic as well as aspirin should be given to them. And we give hexaprine 40 milligrams twice a day per kg body weight. So given to them, we can the delta vaccine also. We preserve fundapresent. We do not use it often, but sometimes we have to use it when patient has heparin-induced cytopenia of fundapresent, and we continue this kind of result 36 weeks, and 24 hours before we stop heparin, and 7 days before we stop aspirin. So that patient goes for severe whatever. So the alternative or system patient put back on the artery. For those who have arterial venous, the other is in the background where you see losses there or morbidity is there. There are two kinds of patients. Those who have fetal loss, in those cases, collected pregnant. I prefer in these. Also, it is although it is not recommended in the guidelines, but I mean I prefer it and I have a reason. After that, pregnancy we continue for 6 weeks postpartum also. Very important that I have lost few patients like that
During the postpartum.
Just after delivery and patients. Third group of patients are those who have PET or eclampsia related, or they have IVGR. These patients also we give aspirin in pregnancy along with hydroxychloroquine. If there is bad upstream is there, we may give low molecular weight heparin. There are that, and cesarean section is taken. If 6, and so that some. Although for the vaginal delivery, you can. So this is the broad guideline.
Yeah, so those are the things which we should follow. So thrombocytopenia is a very common finding, especially in pregnancy, and there could be multiple reasons, and one of them could be due to antiphospholipids also, and it is usually sometimes difficult. So Dr. Ghanshyam, can you tell us how to treat severe thrombocytopenia during APS?
Yes, sir. I think literature suggests 25 to 30% of the APLA syndrome may have a thrombocytopenia. And late trimester, like after 20 weeks and all, HELP syndrome and all, they also come into picture, and they also comes with thrombocytopenia. So if like SLE with APLA syndrome is there, complement level, CRP level may help us in diagnosing that it is active SLE and active APLA syndrome. Thrombocytopenia will be an issue, although thrombocytopenia is common, but usually it's not very severe. Most of the time it's around 50 to 80,000, 90,000 is the platelet count, and they usually don't bleed. So it's more of a thrombotic disease, APLA syndrome, and the bleeding is less likely, but still because platelets are less, you have to do some procedure like epidural anesthesia and all delivery time. So you need to improve the platelets. So recommendation is steroid. So we can use low dose steroid, and if it is severe thrombocytopenia, like less than 20,000, or someone has active bleeding, so there even methylprednisolone pulse can be given. Or in very severe cases, IVIG can also be tried as a rescue procedure. But it's common, and these will be the, depending on how severe it is, we can give it. And although APLA syndrome as a steroid is not a drug of choice, only in thrombocytopenia and maybe a catastrophic APLA syndrome may require steroid. Otherwise, like Dr. Sanjeev already said, aspirin and low molecular weight heparin or unfractionated heparin will be a good choice.
I think that was a very fruitful, discussion, and there are many issues which we have left because of paucity of time, but we can discuss over tea or something. Thank you so much.
I'm extremely thankful to our esteemed panelists and moderator for this wonderful panel discussion. We will proceed to our next session. For that, I would like to invite chairpersons on stage. First, I invite Dr. Aradhana Singh ma'am as chairperson. Dr. Aradhana is professor and founder head, Department of Rheumatology and Clinical Immunology, SMS Medical College, Jaipur. She has received many prestigious national awards, including Excellence Awards for Academics and S.N. Parikh Memorial Oration Award. She has many publications in various reputed national and international journals. Next, I invite Naval Mendiratta sir on dais. He is Senior Consultant Rheumatologist, Fortis Memorial Research Institute, Gurgaon. Dr. Naval. Next, I invite Dr. Arvind Kumar sir on stage. Dr. Arvind is editor of book Post-COVID Clinical Issues and Management, which has been published recently. He has more than 100 publications in various indexed national and international journals. He has received many prestigious awards, including Atal Swasth Bhushan Samman 2019. Next, I invite on stage Dr. Surbhi Vyas Madam to deliberate on the topic imaging modality in common rheumatic diseases. I request esteemed chairpersons to kindly introduce the speaker for this talk.
So, welcome Dr. Sulbi. She is the additional professor of radio in Department of Radio Diagnosis at AIIMS New Delhi. And I would like to just introduce by saying one or two sentences that we here in AIIMS for our all diagnosis related issues for in rheumatology, we always go to Dr. Sulbi Vyas. So I from many departments. Over to you, ma'am.
Thank you so much, Dr. Arvind, for the kind introduction. And I thank all the organizers also for giving me this opportunity, especially Dr. Uma ma'am. So the topic that I have been given stays true to my specialty, that is imaging modalities to be used in rheumatology, how, when, and what. So this talk is going to be a brief outline on what imaging modalities we have in our armamentarium and how we can pick and choose among them to ensure the best clinical outcome. So whenever the question of imaging comes, there are a few questions that our rheumatology colleagues ask from us. So the important question is whether actually there is an inflammatory process going on. If it is going on, what are the sites and extent of involvement in the body? If the pattern of involvement can give a hint towards a specific diagnosis, and when the patient is on treatment, whether there is a response to treatment which can add on to the clinical parameters, and if there is any complication. So based on these questions that are asked, there are this list of indications that we see commonly whenever we have a requisition for an imaging, that is to establish and confirm the diagnosis, monitoring disease activity, response to treatment, and identifying complications. In addition to these indications, there is a very important indication that is for outcome assessment of new treatments and research, which we are fortunate to be a part of an institute where research is given so much importance that we have to take into consideration this indication also. So coming to the first modality is radiography. So radiography, even when we are talking about a musculoskeletal involvement or a chest involvement in patients of rheumatology, it remains the most common modality that we come across. The low cost and easy availability helps definitely, but it shows a limited usefulness in evaluation of specific types of ILDs. Let us look at examples by looking at these radiographs. The first radiograph at the top shows areas of reticulations as well as some ground glass like haze. In addition, there is cardiomegaly and filling up of the pulmonary bay. So it would suggest that there is an interstitial process going on, whereas the radiograph at the bottom, in addition to these findings, show an area of consolidation with a suggestion of breakdown in the left suprahilar location. Let us look at what the CTs of these patients revealed. So these are the CTs at the corresponding similar timings. The first one showed without doubt the possibility of a fibrosing interstitial lung disease by demonstrating subpleural reticulations, cysts, bronchiolectasis, as well as some larger confluent cysts in both the lungs. It also shows the predilection of disease for the subpleural and posterior dependent locations. Whereas when we look at the second radiograph for which the CT was done. It reveals peribronchial areas of consolidation with centrilobular nodules with a relatively larger area of consolidation. So this was because of a presence of tuberculosis in a patient of SLE. So that is how radiography kind of builds on which CT would help us in obtaining a specific diagnosis. When we are looking at musculoskeletal indications, the problem arises that we are trying to take a single dimension image of a 3D structure. So because of superimposition of structures as well as poor sensitivity in evaluation of subtle changes or early changes of disease, radiography has definitive limitations. In addition, the first and the foremost changes, that is synovial thickening, synovial effusion, as well as bone marrow edema, these changes cannot be seen on radiographs, and thus it stays as a limitation. In early disease, an radiograph can look absolutely normal, or there can be just a suggestion of periarticular osteopenia, which can further progress to a relative diffuse osteopenia. More extensive disease is easier to see on radiograph by means of the typical findings in inflammatory arthritis, be it rheumatoid arthritis or psoriatic arthritis, so on and so forth, and presence of deformities and typical joint destruction changes can also help us in evaluation of bone loss. Similar to the peripheral joints, the central joints, that is the axial skeletal evaluation, is also kind of limited by means of radiography because the changes lag by many years when compared to the modality of choice, that is MRI. Still, it is helpful in quantifying bony abnormalities. The second modality that we have is ultrasonography. Ultrasonography is more like an office practice modality, and its availability widespread in both teaching as well as non-teaching institute and as an OPD procedure helps in obtaining a immediate diagnosis. There are difficulties and limitations for ultrasound also. There is a definitive learning curve for musculoskeletal ultrasonography. It requires experience, it requires time, and the major limitation is that not all areas of the body are amenable and accessible to an ultrasound evaluation. For example, the median and lateral aspects of the metacarpophalangeal joints or the axial skeletals, these are definitely not evaluated as easily as the peripheral skeleton. However, it still remains good for evaluation and aspirations of joint effusions, ultrasound-guided injections, and evaluation of tenosynovitis and complications like ganglia. So let us look at a few examples. A normal synovium is seen as a thin hypoechoic layer of soft tissue around the bones and the joints. It measures less than 2 millimeters. However, in presence of inflammatory arthritis, this soft tissue appears to be more thickened, which, if we put a color box, may show presence of internal as well as periarticular vascularity in presence of active disease. In addition to the synovium of the joint, tenosynovial thickening is also very well appreciated on ultrasonography as a hypoechoic line around the tendons. These are the flexor tendons, which are showing hypoechoic tenosynovial inflammation. In addition, presence of synovial fluid and synovial effusion also helps us in identifying the abnormalities. Moreover, presence of erosions, which are seen as bony irregularities in the outline of the bony contour, seen on two planes, are suggestive of erosions. There are definitive extra-articular uses of ultrasound. The primary among them are vascular, in the form of Doppler evaluations of accelerated atherosclerosis in these patients. Newer modalities like elastography and contrast-enhanced ultrasound have also given a clue to various possibilities like degenerative disease of the tendons, tendon ruptures, fibrosing tendinitis, and adhesive capsulitis. Another important extra-articular use of ultrasound is in lung ultrasound evaluation. Now, this is a relatively newer use of ultrasonography, where predetermined sites, so there are 10 sites described in the lung ultrasound score. So 10 predetermined sites on both the sides are evaluated in supine as well as sitting position, and the number of B lines are evaluated. In addition, the irregularity of the pleural surface and the shredding of pleura are also evaluated, based on which a score of lung ultrasound is obtained. Now, it has been shown by various literature that this lung ultrasound score shows a very good correlation with clinical parameters and as well as the HRCT modified Warwick scores. These are few examples of the work that was done in our department, where we can see this irregular pleural line as well as these comet-shaped B lines. These number of B lines are then calculated for the entire to obtain a global score. The next modality is CT. Now, CT is like the workhorse modality, not just for evaluation of musculoskeletal abnormalities, but also for chest evaluation. It is definitely superior to plain radiographs because it has a higher contrast resolution and it has 3D imaging capabilities. Moreover, newer techniques like dual energy CT, microfocal CT, low dose and ultra low dose CT have definite implications in current times. They are the modality of choice in evaluations of fractures, subluxations, along with evaluation based on MRI. Let us look at a few examples of dual energy CT, how it helps in evaluation of gout. So these are the plain images. This is a non-contrast dual energy image of the SI joint, which shows presence of these erosions with a hyperdense material due to tophaceous gout. These are the color-coded images which we obtained from the dual energy data set, which helps in quantifying the disease extent. Another application of dual energy CT has been recently published, and it has shown that even in inflammatory arthritis in small joints like PIPs and DIPs, use of dual energy CT with contrast, iodinated contrast, can give us images which help in evaluation of synovial thickening as well as bone marrow edema, as given in this image. The next modality as part of CT is the contrast CT evaluation. Now, contrast CT evaluation is done in definitive niche indications like in presence of infections or if there are vascular abnormalities which are suspected. The common findings that we see in vasculitis are vessel wall narrowing, wall thickening, presence of delayed phase enhancement. The only thing is that there is a significant overlap among findings of various vasculitis. Still, the kind of involvement, morphology, and the presence of aneurysms or absence of aneurysms and other associated features like parenchymal involvement, renal involvement, they can help in getting to a correct diagnosis. Another advantage of CT is that the various recon kind of images that we get would be easy to understand the abnormality, as can be seen here in a case of renal artery stenosis in a Takayasu disease. So these are other recons, these are coronal recons, which can serve as a framework for further evaluation by vascular intervention, where this focal narrowing of the renal artery has been opened up and stented to obtain an optimum result. A definitive indication is the CT chest in ILD and infections. The protocol differs because of the kind of patient presentation. For evaluation of ILD, it is the IPF protocol that is recommended, that is non-contrast HR, that is high resolution scan with an MA of that is 100 to 240. The FOV is to include only lungs, and the recommended kind of scan is a full inspiratory scan. An expiratory scan is added as and when required to show presence of areas of air trapping which show exaggeration on the expiratory scan. A prone scan can be done to show areas of subtle involvement and to differentiate dependent densities from early ILD, like in this case. This looked like early ILD changes, but on prone scan, it disappeared completely to show that these are actually dependent age-related densities and not true changes of early ILD. Reduced dose CTs, they have a definitive indication in follow-up of ILD. However, they are not recommended as the primary first line investigation when the first scan is done for extent and pattern evaluation. Let us look at few more examples. These are two images to show the typical patterns of UIP and NSIP in axial lung window images. These are examples of complications wherein we can see multiple enlarged necrotic lymph nodes in a patient of tuberculosis. This is another example of pulmonary parenchymal tuberculosis where we can see multiple central lobular areas with areas of consolidation. Now comes the MRI. MRI, because of its superior soft tissue contrast and no ionizing radiation, plays a very important role, and it forms the modality of choice in specific conditions, like in musculoskeletal conditions where bone marrow edema and involvement of the synovium in the form of either synovitis or effusion, it forms the modality of choice. However, it has long imaging times, expensive and limited availability. Let us look at a few examples. This is the same radiograph that we saw earlier, a case of early disease, absolutely normal, not even osteopenia. But when we look at the MR images, we can see definitive areas of marrow edema, not only in the along the metacarpophalangeal joints, but also along the various wrist bones. In addition, we can see the synovial proliferation around the metacarpophalangeal joints. These are the sequences. I will not go into the details. Suffice it to say that contrast-enhanced images are considered to be the gold standard, but the recent literature suggests that the information provided by the fat-saturated T2-weighted images is as good as contrast-enhanced images. But whenever we are thinking in terms of infections, then yes, contrast-enhanced MRI is the modality of choice. These are a few other examples where we can see erosions on T1 weighted images. This is the T2 stir image, which shows this very beautiful abnormality in the form of synovial hypertrophy along the tenosynovium. And this is an area of enhancement due to the presence of inflammatory pannus in a case of rheumatoid arthritis. In the axial skeleton also, MRI helps in evaluation and differentiation between fibrosed chronic changes of sacroiliitis with presence of sclerosis, or to differentiate between active synovitis, which can be seen as areas of bone marrow edema, as well as synovial effusion, as can be seen on these cases. Another very important role of MRI is in distinguishing between inflammatory versus infection, presence of definitive collections, marrow edema, as well as soft tissue involvement of the surrounding musculature are definitive signs that this is actually an infection and not an inflammatory pathology. So which MRI is to be done well? In JRAs, a whole body MR can be done to look for total joint count. However, the absolute evaluation of small joints cannot be done on whole body MR. So that is not indicated. In early diseases, a contrast-enhanced MRI, it shows a higher sensitivity for subtle changes. Assessment of destructive bone changes can also be seen on T1 weighted MR images. MR can also demonstrate neural compromise as well as complications in the form of atlantoaxial involvement in inflammatory arthritis. And it forms an additional modality with CT. This is a new indication for MRI, which is the lung MRI. This is part of the work that was done in our center, where various MR sequences were compared with the modified Warwick scores as obtained on HRCT, and we found that non-radiation modality like MRI in patients who have an ILD, who have an established diagnosis of pattern of ILD, they show a very similar Warwick scores and very similar findings in terms of honeycombing as well as ground glass opacities on various MR sequences. So these are examples from a 42-year-old lady who has systemic sclerosis, where the CT demonstrates ground glass opacities and microcysts, and similar changes can be seen in MRI as well. Yeah, this is the last two slides, sorry. This is MR angiography representative slides. I would just like to say that there are two kinds of MR angiography, non-contrast as well as contrast. What we need to remember is non-contrast MRI can include almost the entire body But when we are looking for contrast MRI, it is essential that because the FOV is limited, so the entire torso and limbs are not evaluated. So what we have to do is split the examination and make it a small parts of series with multiple injections of contrast to obtain a larger area of interest. So if we are interested in evaluating the entire thorax and abdomen, a non-contrast MRI is what we would be recommending. I would skip over the nuclear medicine slide. The only advantage is that it gives an overall picture of the abnormality. The take-home message is that we need to understand what we are looking for. If it is early disease, if it is bone marrow edema, or if it is differentiation, then a particular modality has to be weighed against the other so as to achieve the maximum benefit for the patient. Thank you so much for a patient. Any questions?
Compact and informative deliberation. I'll please open for
Thank you so much. So actually that is what formed the basis of various MR studies. Cellular NSIP on HRCT presents as more ground glass predominant disease, but it has been seen on histopathological analysis that even early fibrosis appears very similar. So early fibrosis can also present as ground glass opacity on an HRCT. And this formed the basis of MR studies where it has been shown that delayed post-contrast enhancement is what differentiates between the two, because fibrosis by its very nature leads to a delayed enhancement, whereas an active inflammatory component would lead to an early phase enhancement. So the post-contrast MRI chest that is obtained, it is done in phases. So there is an immediate early post-contrast phase followed by a 4-minute and 10-minute post-contrast images. So it has been seen that the 10-minute post-contrast images are the ones which are correlative with the fibrosing NSI, fibrotic component of the disease.
We are running short of time, so we'll not take any further questions. So can I ask the co-chairperson to invite the next speaker?
Thank you so much.
I'm extremely thankful to Surbi ma'am for this informative talk. Now I invite Dr. Lalit Duggal sir on stage to deliberate on glucocorticoid-induced osteoporosis, prevention and management. I request respected chairpersons to kindly introduce Dr. Lalit sir.
Dr. Lalit. Know about him. He's the chairman of the Rheumatology and Clinical Neurology. And this is the previous presentation where he was ex-president Delhi Rheumatology. He is like founder president of Delhi Rheumatology and Immunology. He's got more than 60 publications in the national and international journals, and special interest in spondyloarthropathy, biological and correlated. His major achievements include he established Department of Rheumatology at LGRH in 2010, and he started DNB program in rheumatology in 2014. He is a WHO consultant in immunology.
Thank you, Chairperson. And at the outset, I would like to thank Dr. Uma for giving me a topic which initially I thought was pretty straightforward. However, as we would see, it turned out to be pretty complex, along with a lot of abundant knowledge gaps, as we would see here. And the problem is that there are very few trials which are coming now or guidelines. Perhaps by the end of the year, we'll be seeing more of them. And I would now actually give a simplified kind of an overview of this particular topic, and I hope to keep everybody awake up there. We all know that glucocorticoids are the most prescribed drugs with the most potent immunosuppressive and anti-inflammatory properties. And they are the most common cause of secondary as well as iatrogenic osteoporosis. I think we know what osteoporosis is defined by the WHO classification of a BMD of less than minus 2.5 compared to a normal mean. The prevalence of use worldwide has been shown in some studies to be 0.5 to 0.9%, coming up to 2%. And a lot of these patients are on long-term treatment. That means more than 3 months at least, with associated problems such as fractures, which are clinical or maybe diagnosed on radiography. And out of these, less than 15% are actually on anti-resorptive or anti-osteoporotic treatment. So you can see the wide gap between what is understood and what is being treated. So it is, like I said, it is less understood, underdiagnosed, and undertreated. The need of the hour is awareness and education of the caregivers. Let's start with this story, which will continue all along the talk, of a 40-year-old premenopausal lady who was diagnosed with a moderately severe lupus with no comorbidities, on hydroxychloroquine, along with tapering steroid dosages from 20 to 2.5. This was the expected dose later on. Now, the questions are, do we start anti-osteoporosis treatment in this lady? Any additional tests that are needed, for example, DEXA or the FRAX score? Let's briefly run through the pathophysiology of this particular condition. They are known to induce imbalance in bone modeling, osteoblasts, osteocytes, and osteoclasts. They actually cause what is known as apoptosis of osteoblasts and osteocytes, leading to thinning of the bone, and that leads to an increased fracture risk, which I'm showing here is independent of the BMD. That is important because it's important from the treatment point of view, where you can start treatment at a much higher BMD than otherwise in primary osteoporosis. And secondly, because of this, you might need additional tools such as FRAX, which we're going to talk about. The bone loss is maximum in the first few months of treatment and then plateaus off annually. And as we all know, its greatest effects are on the trabecular bone, that is vertebral and the vertebral and the femoral neck. The problems are that, a huge lot of patients are on it, and it has been seen that the vertebral fracture risk is almost 3 times those compared to those who are not on any treatment, and about twice the hip fracture risk. Longitudinal studies, large number of longitudinal studies have shown that a dose of 7.5 milligram or more per day is associated with increased vertebral and fracture and hip fracture to the tune of twice compared to a 2.5 milligram dose. It's not the daily dose, but importantly, the cumulative dose also is very important. More than a 1 gram dose is also associated with increase in vertebral and hip fracture. When you combine the two, the chances of fracture multiply. Other mechanisms include induced muscle atrophy through the protein synthesis and hypocalcemia through the GI and renal absorption, as we all know. This particular topic is a little controversial. I'm not going to talk about it, disease specific. Now, let us just recapitulate what are the modalities that we use for screening. We all know about the DEXA scan, which gives an idea of the bone mass at both the lumbar bone at the trabecular as well as the cortical bone. The T-score and the Z-score are used depending on the age of the patient, the cutoff being around 40 years. Hip and lumbar spine are used for assessment of fracture risk and monitoring treatment. The peripheral DEXA is not an established arm, at least as far as GIOP is concerned. Next, we come to FRAX, which is a computer-based algorithm which is used to predict a 10-year osteoporotic fracture in patients who are 40 years or older. It can include both BMD and without BMD. If the GCs are in a fairly decent dose of 7.5, you need to have a multiplication factor. Important thing is if the T-score is between -1 to 2.5, then the FRAX score perhaps might help in deciding the treatment. The problems are it uses only the hip BMD and can be used only for untreated patients. Now, this is the BMD and the FRAX that is shown in our hospital, where we combine the two. This picture clearly illustrates, and it makes it very simple for us to start or to not to give treatment. This is an online score which can be used very easily when you combine FRAX with BMD. There are certain charts where you can use FRAX without BMD in men and women, where you use what are known as the clinical risk factors that we will discuss. Other modalities such as single energy X-ray absorptiometry, quantitative CT, biochemical markers have less predictive capacity and are not the routine modalities being used for following up or for screening. Trabecular bone score and high resolution peripheral quantitative CT scan could be the new tools for the future. This is how we assess fracture risk, again, based on the ACR 2017 guidelines, based on prior osteoporotic fractures, presence and the BMD scores, as well as the FRAC scores, and along with that, the dose of steroids that is being used in patients who are less than 40 years of age. Now, how do we assess the fracture risk initially? An adult patient, as soon as possible, certainly within 6 months, you should do what is known as a clinical fracture risk assessment. That includes use of glucocorticoids, presence of any frailty, fractures, or falls, systemic conditions such as patients on thyroid or parathyroid disorders, malnutrition, low body weight, and smoking, alcohol. Last but not the least, a good clinical examination to elicit tenderness over the spine. So, if an adult of less than 40 years with history of osteoporotic fractures and other risk factors, BMD should be done as early as possible. Adults more than 40 years, a FRAX and a BMD should be done when you're starting patient on steroids. Now let's come to our patient. On the first visit, no anti-osteoporosis treatment was required and no DEXA scan was required as the patient had a below fracture risk threshold. Reassessment at 12 months includes, again, the clinical risk, fracture risk assessment. Patients who are less than 40 years of age with moderate or high risk of osteoporotic fracture risk, dose of more than 30 milligram per day, patient who's more than 30 years of age, or a cumulative dose of more than 5 gram would need a BMD 2 to 3 years, if not earlier. Those who've never been treated and are more than 40 years of age would need a FRAX and a BMD. Those on osteoporotic treatment would again, or with moderate to high risk osteoporotic risk factors would probably need a BMD every 2 to 3 years, as also those who've completed the osteoporotic treatment. Now, our patient, what happened to her at 6 weeks? She had a massive worsening with malar rash, fever, chest pain, a high SLEDAI, was put on mycophenolate along with prednisolone with 40 milligram per day. A DEXA scan was done which showed osteopenia. The question now is, do we start anti-osteoporosis treatment in her? Now, let us look at this chart, which is so beautifully shown from Hirschberg, which I've taken from there, which shows the three lineages that I was talking about. As far as the osteoblasts and osteocytes are concerned, the most important thing is increasing apoptosis with steroids. And as far as the osteoclast is concerned, the most important thing is increasing the rank L ligand expression. So the first drug that we're going to talk about, first group, are the bisphosphonates, which inhibits osteoclast, and that's why they call it anti-resorptive agents. In mice model, they've also been shown to promote osteoblasts and osteocytes. The second are the parathyroid derivatives, that is the teriparatide and the newer one called abaloparatide, which increases the osteoblast survival, thereby increasing the strength of the trabecular and the cortical bone. And it acts perhaps through the WNT pathway also. Then is the drug which is now being increasingly used called denosumab, which decreases the expression of rank ligand. By that we mean that rank ligand is important in the maturation of the primordial stem cell into the osteoclast, and that's where the inhibition of denosumab occurs. Then we're talking about calcitonin, not much used excepting for probably analgesic effects on the spine, got osteoclastic effects. We have raloxifene, which is an SCRM, which is again not very commonly used, but promotes osteoblastic activity and inhibits osteoclast. And finally, the new drug, which is now being approved, called as romosozumab, a tongue twister, which is actually an anti-sclerosting drug, which helps to increase the WNT pathway, leading to increase in the osteoblastic pathway. So these are the current treatments which I've just talked about. Oral bisphosphonates reduce fracture risk at both the vertebral and non-vertebral level. IV bisphosphonates, zoledronic acid is found to be superior to risedronate in BMD benefits, but not in fracture. Teriparatide and denosumab have been found to be effective in reducing the fracture risk both at the vertebral and the hip level, and they increase the BMD. Teriparatide is definitely found to be superior to bisphosphonate. And raloxifene, I was saying, can be used in selective cases of postmenopausal women where other therapies cannot be used. The new treatment we just talked about, the abaloparatide and romosozumab, these drugs have been found to be superior to teriparatide in clinical trials. However, their use in GIOP has not yet been established, approved for postmenopausal osteoporosis. Now, the important question is, where would I prevent or treat, and with what? Lot of gray areas, no guidelines telling us clearly, excepting perhaps the ACR. We started with our Indian Journal of Rheumatology guidelines in 2011, but we've got no further updates after that. So, but uniformity across guidelines are patients needing more than 3 months of steroids, prior fragility fractures, irrespective of age, sex, and GC dose, should be started on anti-osteoporotic treatment and with a BMD measurement every 3 to 6 months. First line, oral bisphosphonates. Second line, IV bisphosphonates or teriparatide and denosumab. Teriparatide and denosumab can be used upfront in patients who got very high risk chances of fracturing. And these drugs, as per the recent studies and reviews, are probably going to be the standard of care in the future when we have the RCTs coming in. Other characteristics are important, such as menopausal status, renal dysfunction, costs, and most important, the patient preferences to a daily subcut injection versus maybe a 6-monthly one. So the patient who needs more than 2.5 milligram per day for 3 months should be on calcium and vitamin D supplements along with, along with lifestyle modifications. Those at low risk need no further treatment. Those at moderately high risk, women of childbearing potential should be given oral bisphosphonates, and maybe second line could be teriparatide, not the others. And those who are not of childbearing potential or men more than 50 years, oral bisphosphonates followed by any of these that I've shown. So our patient should be started on anti-resorptive treatment because the daily dose, as we calculate, would be more than 7.5 with an estimated cumulative dose of more than 1 gram, used longer than 3 months and a low BMD, not osteoporotic. And the choice of this agent in her would be an oral bisphosphonate. The final question is it possible to stop treatment? At 1 year, a patient was asymptomatic. At 15 months, she was off prednisolone. Can we stop treatment in her, and when can we stop? Preclinical evidence has shown that there is some degree of reversibility due to the recovery of osteoblasts on discontinuation of the steroids. It is also dependent on long-term impact of steroids on osteoblasts and osteoclasts. Daily and cumulative dose that I've been repeatedly stressing are important because they will determine the treatment of anti-osteoporosis treatment for on GC discontinuation. The higher the dosages, the longer the time would you take to stop the anti-osteoporotic treatment. Studies have not seen age, sex, and other fracture risks. So this is a certain thing which has to be seen for the future. So based on expert opinion and in vitro studies, if a cumulative exposure is more than 1 gram, you can afford to stop treatment after 3 to 6 months. More than a gram or approaching 5 grams up to 18 months, or when the fracture risk is low as determined by the BMD. Primary osteoporosis, you have to continue as per the guidelines of primary osteoporosis treatment. Therefore, in our patient, we could stop at 6 months because she was a younger premenopausal lady, had no other risk factors, though she had a cumulative dose of probably needing more than 1 gram. So what are the future goals? We need more tools for patients at risk because even now, both the BMD and the FRAC score do not give a comprehensive picture. We need advances as far as specific potent drugs for cost-constrained countries such as ours is concerned. We need additional studies to look at the geographical differences, ethnicity, and also certain subgroup of patients who have got variable bone density, such as those with low body mass, recent fragility fractures, looking at effect in children, which I have not discussed at all because there's very little literature on it. And most of the children who are not osteoporotic would probably be given only calcium and vitamin D. And importantly, look at fetal safety because as I've shown, most of these drugs cannot be given when the patient is planning pregnancy. Another thing is that some patients would need bone-sparing effects by reducing inflammation. By that, I mean that there's excessive inflammation and the dose of steroids given to these patients would perhaps reduce inflammation more than causing damage to the bone. And there are certain steroids such as deflazacort and maybe liposomal prednisolone, which are said to be less injurious to the bone. And finally, we need more clarity on when to stop treatment based on the dose-related, persistent, reduced density in these patients after discontinuing glucocorticoids. And perhaps the newer guidelines coming by the end of the year would answer some of these questions. Thank you very much for your attention.
Take one question.
So you're talking about two things. Number one, you're talking about a combination therapy. Well, there have been studies to show that there will be no superiority when you combine, say, a bisphosphonate maybe with a teriparatide versus teriparatide alone. However, another important question which you could have asked was combining denosumab with teriparatide, which a lot of the orthopedic surgeons are doing. There are no studies in GIOP, but there are some guidelines for primary osteoporosis, so I can't comment on that. The second part was sequential. Well, there has been a very interesting study to suggest that if you're using denosumab over a period of 4 years versus when you're using teriparatide initially followed by denosumab over the next 2 years, the results on at least the neck of the femur are much better than combining denosumab after the patient has failed bisphosphonates. It makes logical sense because the anti-resorptive effect has already been full when you're adding drugs such as denosumab, and that's why combining maybe a sequential maybe teriparatide followed by denosumab would be better than either giving bisphosphonate followed by denosumab.
Thank you.
I am extremely thankful to our chairpersons and speaker for this enlightening session. We'll proceed to our next panel discussion, which is on the topic interstitial lung diseases associated with connective tissue disorders and interstitial pneumonia with autoimmune features. For this, I would like to invite panelists on the dais. First, I invite on stage Dr. Priyanka, Associate Professor, Department of Radiodiagnosis, AIIMS, New Delhi. Next, I invite Dr. Anand Mohan sir. Dr. Anand is currently HOD of Pulmonary Critical Care and Sleep Medicine, AIIMS, New Delhi. He has received many honors and awards, including prestigious UK Commonwealth Fellowship 2008-9 in Chest Medicine at NHS Trust, UK. He has numerous international and national research publications and book chapters. Next, I invite Dr. Sunil Attari sir. Dr. Sunil is Senior Consultant Physician and Rheumatologist, Hindu Rao Hospital and NDMC Medical College, Delhi. Sir has served as President of Delhi Rheumatology Association and has multiple publications in reputed national and international journals. Next, I invite Dr. Abhishek Kumar sir. Dr. Abhishek has done his DNB Rheumatology from Army Hospital, New Delhi, and is currently working as consultant in the same hospital. He has many publications in national journals and is also author of many book chapters. His most notable publication is on stem cell transplant in systemic sclerosis in India. Now I invite Dr. Vimlesh Dhar Pandey sir as a moderator for this panel discussion.
At outset, I'm thankful to Dr. Uma for asking me to be the moderator. I have a sore throat. I'm also thankful to Professor Malviya for feeding a lot of questions that I'm going to put up to the panelist by the number of articles he sends early in the morning. So it was the last week's questions that he had sent. One most important thing is that I'm thankful to Dr. Tejas Suri. Dr. Anant Mohan had an emergency call from Hyderabad and he had to move to Hyderabad. And he was very sorry, but he said, let me ask Tejas. And Dr. Tejas chipped in at 6:30 p.m. Warm welcome to Dr. Tejas Suri. It is not easy to come as a last person towards this meeting. To the audience, I would be posting 3 questions, and that would be, the panelists or yourself can take up these questions at the end of this deliberation. Dr. Uma Kumar has clearly asked to finish this topic in 30 minutes. So this is the first case, a 52-year-old female who presents to a pulmonologist with dry cough, decreased exercise tolerance. She has 30 years of smoking history. She notes some joints which are painful in the knees and the fingers, and which are 4 in number. Her PFTs are there. Her HRCT shows UIP pattern. Her CRP is 4 milligram per liter, and CCP is positive. So what do you consider? These are the options. We'll be taking up these questions later on. There's another question. Which of the following should be communicated to a patient with RA and a newly diagnosed ILD? These are the options. We'll take up these options. For a female who's Black, recently diagnosed systemic sclerosis with digital ulcers, positive anti-polymerase 1 antibody, which of the following should be performed to screen systemic sclerosis associated ILD? And this is the question. These are all relevant because this is what we see in a day-to-day practice. May I start with Dr. Sunil Attri? How common is ILD in rheumatic musculoskeletal diseases?
That's 25% undifferentiated. Also known as undifferentiated ILD.
There's another question that I always feel. Is RA-ILD a rheumatologist fault? You have been treating a patient of RA, and over the period of time, he develops ILD. Do you feel that you are at fault?
There is evidence of 10% of the patients. 30% of diagnosed uninvolvement, subclinical morbidity. And regarding CTD, ILD, has been seen that and initially they are communicating to the and most of the time when they visit the rheumatologist or that time 2 years have that time they are most of the patients are on antibiotics, inhaled steroid or prednisone and patients are even on oxygen. This picture is further back is concerned. People saying that there again published that there is a delay of almost 4 years picking up these. And normally this is the condition they are not aware of. Other patients treated by the government that know that this is they are chronic diseases and at times the patient probably the delay is there. That is why come to us already they are having.
So what do you suggest, how we can prevent it or how we can pick up early ILD? Should we just focus in rheumatoid arthritis joint or we should focus beyond joints while we are managing the patients?
And the functional assessment, how is that then antibody test. Functional assessment as such is done with mechanics with the pattern of life. Normal in these two. And then lung volume, total lung capacity. And further, gas exchange in the form of DLCO, you have to look in that part also. And various exercise tests, evaluation, 6-minute walk test, you have to see. And then the patient, even the gold standard is cardiopulmonary exercise testing. So if we come on to the clinical assessment in these patients, the most important thing is the cardinal features in these patients in history is they are having progressive breathlessness along with persistent non-productive cough, and along with other features of malaise and weakness. So these two important things we have to keep in mind. At times they are, and this persists for pretty a long time, and maybe some acute presentation when there is associated infections are there. And these patients, the chances of, they are having very less chances of hemoptysis. Then coming on to the general physical examination, as we all rheumatologists are aware of various subtle signs which we are supposed to pick, and it should be percolate among all the physicians that we should look for all those signs in the form of mechanic hands, patient xerostomia, then patient have deformities of rheumatoid, arthritis, scleritis, Raynaud's phenomena, then puffy fingers, then erythema nodosum, then patient may have facial nerve palsy along with the classical scale lesion of the sarcoid. So you have to look for all these subtle signs so that you can pick up the patient of CTD and then you can pick up for ILD at the earlier. Then on, as far as examination is concerned, clubbing is again, it's not a very common feature in CTD associated ILD. Of course, if the patient is having idiopathic pulmonary fibrosis, then 30% of the patient, they can have clubbing. Then on examination of the chest, classically they are having bigesal Velcro veils. It could be that it may be variable from person to person, but if you do with electronic stethoscope and when you look at the on the laptop, that it's again very irregular wave formations, and then those can be picked up from the back. And so the important thing is that if you pick all these things in the early stage, in the form that if you are doing the history properly, taking the history, and if you are doing the assessment in the form of pulmonary function test, and if you are having 6-minute walk test and HRCT, you can pick the disease much earlier. So what I want to convey is every CTD patient, once we are come across that, you should try to find out interstitial lung disease when they are coming to you in the first time.
Thank you.
Annual screening is required for at least every 12 months. And if there is any problem in these settings, then it should be repeated every 6 months.
Very clear in your message. Being a good physician is what is required to pick them early. Dr. Abhishek, controversies again. ILD may be the first manifestation of CTD. How strongly you believe? Some experts believe that the ILD may be the only manifestation of CTD. How strongly you believe? And other than systemic sclerosis, none of the connective tissue disease or RA has ILD as a classification schemes or diagnostic schemes. So what is the problem there? If CTDs are so common and very important in terms of mortality and morbidity, why are we not putting that as a classification or a diagnostic criteria?
First of all, sir, first question is that ILD may be the first manifestation that sir has already told that around 20% of the patient they will have ILD as the first manifestation. And if we go through the literature and you see those articles from the respiratory journals, when they have evaluated ILD and they look for the cause of the ILD, around 15 to 20% of the patients, they have later on turned out to be any connective tissue disease. And the next question that some experts believe ILD is the only manifestation, that is again quite a controversial thing, because here we have to differentiate between using a classification criteria and a diagnostic criteria. So any patient who have an ILD, and I presume by this question that this patient has another serological marker of CTD, but not any other clinical manifestation. So if you go by this patient does not fulfill even the criteria for an undifferentiated connective tissue disease. Patient may fulfill that criteria for other entities which has been slowly evolving, like IPAP, CTD ILD, or maybe UCTD ILD. But for the purpose of diagnosis, possibly yes, you can do that, but not for the purpose of classification. And next is like CTD current classification schemes other than systemic sclerosis. If we see the prevalence of CTD, ILD in CTDs, apart in RA that is around 30 to 40%, And if you see in systemic, SLE, it is around 2 to 30%, and after SSC, the most common disease which will be having ILD is inflammatory myositis, curtains. But still the prevalence is not as high as systemic sclerosis. And we just see the classification criteria which has been recently been given by EULAR and ACR for inflammatory myositis. Even when they form this collaboration of multi-speciality collaboration, and we were surprised to know that there is not a pulmonologist in that collaboration. And the reason being that that myositis per se and all those clinical features of dermatomyositis and myositis being demonstrated by other means, maybe a biopsy or this, those are sufficient enough to give a diagnosis. That ILD per se does not give you additional advantage in increasing the sensitivity or specificity of the criteria.
Thank you, Dr. Abhishek. And that's why we have pulmonologists with us. The ULAR may not have, and we have also a radiologist with us. So, Dr. Tejas, very basic. If you get those CTs, so what are the ILD patterns in musculoskeletal disease that you come across? Does they make any, viewpoints regarding clinical management? And how often should you do HRCT? Baseline after 1 year or 3 years to repeat, PFTs, echo, 6-minute walk test, the pitfalls and advantages. When do you do BAL? When do you do ultrasound? And the previous speaker was speaking about the ultrasound of lung. So is it a good modality? When Dr. Priyanka can also highlight the usefulness. And the important question, when do you want to do histopathology? Because we do not do histopathology. We don't come to you asking for a biopsy. And that must be something which must be irritating you, why we do not ask, and what we should do that we should improve. And any biomarkers you specifically look, that will give a clue to anticipate. Multiple questions, you can take one by one.
Okay, thank you so much for these questions, and let's take them one by one. So coming to the first question, the common patterns of ILD in the connective tissue diseases. So we know that there are several different patterns of ILD which are initially defined histologically, but now there are radiological correlates. So we have histopath and radiology correlation, and based on that we have certain patterns of ILD which are different, which are initially defined as idiopathic interstitial pneumonias, but similar patterns are seen. Some of them are seen commonly in connective tissue diseases. So the most common patterns which we come across in our practice, as Dr. Priyanka ma'am can also elucidate, are the NSIP patterns, which is non-specific interstitial pneumonia. We also have usual interstitial pneumonia pattern, UIP. We have organizing pneumonia pattern, and we also have LIP pattern. So these are 3 or 4 common patterns which we see in connective tissue diseases, and in fact the different connective tissue diseases may have different types of histopathological appearances which are more common in that particular CTD. For instance, I would say that overall NSIP may be the most common pattern in connective tissue diseases, and particularly in systemic sclerosis. Again, NSIP OP overlap may also be encountered in any of the connective tissue diseases, but commonly in myositis. And then we have RAILD, in which we can have UIP and NSIP, both are equally common. And then one unique pattern in Sjogren's syndrome which we get is LIP. So these are the common patterns. And as far as do we want histopathology to diagnose these patterns, so I'll just skip the second question because the third question is related to what I was talking to. So basically, when you have a defined CTD in a patient, we know the CTD is diagnosed, the criteria are fulfilled, then we usually do not need a histopathology for the diagnosis of ILD. However, as had been mentioned, that can lung involvement be the only manifestation of CTD? So this is a $1 million question, but then we don't have an answer for that, but we are trying to find an answer for that. So we have a new, not new now, but in 2015 we had a new criteria called IFAB, which is interstitial pneumonia with autoimmune features.
in that particular situation, often we do end up doing histopathology because here we don't have a defined CTD and we have many differential diagnoses. In fact, histopathology may give us a clue that it may be connective tissue disease.
I would agree with Tejas. One point I want to highlight here is that histopathology may not be required in this particular subset of patients of CTD because radiologically there are several studies, and the recent most study was by Chung et al. In our radiology journal, where they have shown the correlation between the radiological features and with histopathology in idiopathic ILDs at least, which correlated up to 90%. So most of the histopathological correlates are visible non-invisibly on radiology. So maybe that's why the histopathology is very rarely done in this subset of patients. Also, as we interpret the CTs upfront, when we see a pattern, say UIP, it is, and even in the radiological steps of interpreting that as UIP, the first step is to rule out a CTD, and then only we tend to reach again looking at the clinical features, whether it's smoker or not, and all those things, to label it ultimately into an idiopathic form. So that's why a pattern, once we get, there are several features also on CT. I would enumerate 3 main features on CT, which have shown a very high predictive value for those features being associated more likely with the CTD ILDs. And those features are presence of exuberant honeycombing. So by exuberant honeycombing, we mean that the involvement of the honeycombing in the lower lobes is seen, which is involving more than 70% of that area of fibrosis. So that is called as exuberant honeycombing, and this particular feature has shown to be very highly sensitive and specific for a CTD associated ILD of a UIP versus any idiopathic or smoking related ILDs. Second feature is the presence of involvement of the upper lobes only in the anterior corner sign. So that is called as the anterior upper lobe sign, where we get the involvement of this honeycombing and fibrosis in the upper lobes only in the anterior segments, anterior subpleural regions. So that is one more feature. And the third feature is called as straight edge sign. So by straight edge sign, that is, we mean that the involvement of the ILD suddenly stops at the lateral edge in the lateral parts of the lung parenchyma, the lateral segments of the lower lobes and the middle lobes, lateral segments. Those are less likely affected by this fibrosis process. So these 3 features have shown very high sensitivity, specificity and positive likelihood ratios of up to 3.2 to 4 in those studies to predict that this ILD form, these features would represent more of a CTD associated ILD over an idiopathic ILD. So radiology, as this is also shown, these all features correlate very highly with the ILD being secondary to a CTD rather than an idiopathic form. And regarding the patterns, once again, this has highlighted, but I would say that in RA, UIP patterns are more also UIP versus NSIP in RA has shown us again it has prognostic implications, right? So even if RA patient has a UIP, it has bad prognosis as compared to if he has an NSIP pattern. And whereas systemic sclerosis more oftenly shows us the NSIP pattern, and in myopathies, IIMs, we get more of NSIP OP overlap type of patterns more frequently.
It brings to another question. So we have a joint count for rheumatoid. So when you see CT, you also have the activity index versus a chronicity index that we usually see in, say, lupus nephritis, kidney biopsy. So can you give us an information about?
We have several scoring systems. By scoring systems, we mean there is a severity score is given and an extent score is given. So in the like the standard Boric score, which is used in measurement in the CTD ILDs. So by severity score, we measure the abnormalities, extent of that abnormalities in the given segment of the lung. And we enumerate how many number of segments are affected by that particular abnormality. So that abnormalities are that we take into consideration are ground glass opacities, fibrosis. By fibrosis, we measure the presence of subpleural thickening, we measure the reticulation, presence of traction bronchiectasis, those features are evaluated individually in those segments and a combined scores are given. That's how severity assessments are done. This is a visual, this is a semi-quantitative, like an operator-based subjective assessment of the extent and severity. We do have softwares available now. There are two major software. This is Caliper software, which is a deep learning based software, which machine learning based software basically, which is applied on the scan, and it automatically highlights the regions and calculates the extent and amount of fibrosis upfront and gives us a numerical value of the extent of involvement. These softwares are also available. These are all three third-party softwares which have to be incorporated in our PAC system for evaluation, a quantitative evaluation, a computer-aided methods basically. The other softwares are also named like in bio softwares and all, which are all on the obviously at the investigational stage. One of them is just the Caliper, which is come up for the commercial use.
Thank you, Dr. Priyanka. So we move forward. So this is for the audience, IPAF-like presentation, and autoantibody present HRCT shows ILD, but there's some amount of nail fold capillary changes, puffy hands, but not skin thickening. And this is how they may progress over a period of time where you can see a lot of changes. And this is what Dr. Priyanka was highlighting, that the disease may develop over a period of time. So the question is, when do you use antifibrotics, especially we are very good in immunosuppressants, rheumatologists, but we are not as good as using antifibrotics. Dr. Tejas, your viewpoints. When do you want to use antifibrotics?
ILD or IPAP in general is treated with glucocorticoid as the first line, glucocorticoid or immunosuppressant agent as the first line treatment. Because when we want to treat these patients, our first aim is to have an improvement in their condition. So these drugs at times may help in stabilizing and at times may even improve the condition of the patient and reverse the pathology in some instances. Like organizing pneumonia may improve with immunosuppressant. So coming to antifibrotic, why antifibrotic? Antifibrotic as a drug cannot improve the efficacy, whereas immunosuppression can. Now, we must understand that when we talk about the pathophysiology of connective tissue disease ILD, there is inflammation which is going on, but then there is also aberrant healing with fibrosis. And this fibrosis may be irreversible, is actually usually irreversible. So, this is where the antifibrotics come into the picture. So, we have had the advent of these drugs over the last 10 years, initially in IPF. We know that these drugs are pleiotropic, that is, they have multiple mechanisms of action and they prevent development of fibrosis by acting against platelet-derived growth factor, vascular endothelial growth factor, etc., fibroblast growth factor. So basically, these drugs are not as first line in CTD-ILD unless the patient is already in extensive fibrosis. Rather, these drugs are to be added in a condition known as progressive fibrosing ILD, where the disease is gone into a situation where the fibrosis is a dominant picture, or there is more than, say, a certain degree of fibrosis in the HRCT, where so either they can be used alone or they can be used in combination with immunosuppression in such cases.
Thank you. To our rheumatologist, do you do environmental antigen, as a trigger for worsening CTD-ILD? And to Dr. Tejas also, your viewpoints. If a patient is a known case of, say, systemic sclerosis ILD, when would you do these tests? And so we can start with Dr. Abhishek.
Actually, sir, there are studies that where you see that all those areas where air pollution is high.
I mean, autoimmune disorders are found to be more prevalent in the cleaner areas. But exactly pinpointing certain things, we don't know what are the things in environment. And other things in environment which cause ILD are certain things like drugs and all those things which we can control. Okay, so we have to we can have a control or some advices for the patients only on those things which we are conclusively we can say that this is the thing which is going to either precipitate or either it is going to worsen. But as we know that even in the pathogenesis of rheumatoid arthritis, there is smoking and these things are playing an important role. So here again, there is one more environmental factor which has been implicated. So whatever, known things are there. We do screen for that, but other things are still in that at research level, so nothing much we do about that.
Thank you.
Yes. So I also agree that we do not routinely do these tests when we have a definite diagnosis of CTD-ILD. However, in cases of IPAP where we suspect that hypersensitivity pneumonitis may be a comorbidity, we may want to go for a ABN or other antigen pattern.
So this is the last question to the panel. We will be having a quick views about when do you treat and when do you do not treat when you see a patient of CTD-ILD. So what things you look upon these in the HRCT that makes you compels you to treat or not treat.
Symptoms. The patient is having serious symptoms and 6-minute walk test is showing fall in oxygen saturation, and then FVC fall is more than 10% and DLC fall is more than 15%. Significant fall is there, and the patient is deteriorating, and there is more natural technical changes. They are more than 20%, and they are falling in moderate to severe category. Those are the patients you have to plan for the treatment in this situation.
Dr. Abhishek, your viewpoints?
I would say that there are a lot of a few randomized controlled trials only in systemic sclerosis, not in other diseases. But there are no definitive guidelines. There are for treatment decisions, but into a clinical ILD and subclinical ILD, depending upon the HRCT report. If the patient has a subclinical ILD, it's defined as having maybe less than 10% of the lung milk involved and normal FVC and VLCOs. And then you have to look for other features which are predispose patient to develop ILD. Like in systemic sclerosis, it can be SCL70 antibodies or diffuse cutaneous disease or rapidly progressive systemic disease. Then possibly even in these patients, even if the patient has no symptoms, we can choose to treat. And in the other subset, when the patient has clinical ILD, then we should definitely treat all these patients. And so I think we should treat all patients of CTD-ILD. When I say we should treat all patients of CTD-ILD, I mean we need to do certain basic things like smoking cessation. We want to give them vaccinations, prevent infections, etc. But then if we talk about specifically about drugs, so as we have two broad categories, glucocorticoid immunosuppressants as well as antifibrotics. So the role of glucocorticoid immunosuppressant may be there where we feel based on clinical profile, young patient, female patient, rapidly progressive dyspnea or progressive symptoms with documented decline in FEV1 or DLCO or CT picture suggestive of inflammatory ILD with GGO predominant ILD. These are some of the markers which may guide us. So we may not treat all patients who come with very mild disease. Similarly, if a patient comes straight away with extensive fibrosis, we again may not want to treat with glucocorticoid. If suppose extensive UIP pattern, we may straight away treat with antifibrotics in that case. So we have to have a nuanced approach of about whom to treat and how to treat.
Dr. Priyanka, your wisdom. How do you guide us?
I was going to ask this question. If I detect a very early form of an ILD in a CTD patient in terms of presence of ground glass opacities in the lower zones, will it be treated or not? And extent is like less than 10%.
So I just want to say that most of the trials, like the SSC ILD trial, they have in fact treated very early ILD. However, if the FVC, BLCO is all normal, we can observe these patients for a while because some patterns like OP may go into spontaneous remission also. One more thing, where
Patterns in the follow-up CTs do show progression in terms of formation of reticulocytes, even though the ground glass goes back, then we are left with actually the fibrosis element in lot of patients.
Whenever we decide not to treat the patient, it is very important that patient should be under careful follow-up. So finally, we have to decide the adverse effect of the treatment versus the likely benefit. So if we don't treat, we should monitor them at 3 months with repeat PFT and plus minus imaging if required.
One more thing I would like to add here that even if the patient has a subclinical involvement, less than 10% of ground glassing involved in CT scan, if there is a high risk factor like an anti-MDF5 antibodies, in those patients they are likely to have more prevalence of rapidly progressive ILD. Then you go aggressive and treat those patients.
Thank you, Dr. Abhishek, because that's why I wanted to differentiate that not ILD, not all the ILDs are the same. Some ILDs have words, some ILDs can go on, as a slow process. Thank you, panelists, for giving your excellent viewpoints. Thank you once again.
Thank you, sir. Moving ahead, I would like to invite chairpersons for next session. First, I invite Dr. Rajiv Gupta, sir, on stage. Sir is currently head of the Rheumatology and Clinical Immunology in Medanta Hospital, Gurgaon. He was among the international reviewers of Kelly's textbook of Rheumatology, 7th edition, and member of International Advisory Board of 20th edition of Davidson textbook of medicine. Next, Rajiv. Next, I invite Dr. Anu Davar ma'am on stage. She is consultant rheumatologist in Gitanjali Medical College and Hospital, Udaipur. She has done her DM rheumatology from Jipmar, Puducherry. Ma'am, please come on stage. Next, I invite Dr. Shalu Gagneja ma'am. Presently, she is head and senior consultant, Department of Rheumatology at Primus Super Speciality Hospital, Chanakyapur, New Delhi. She has numerous national and international journal publications to her credit. Now I invite on stage Dr. S. Karthik sir to deliberate on the topic IgG4 related disease. Dr. Karthik. I request respected chairpersons to introduce Dr. Karthik sir.
So Dr. Karthik is currently working at Army Hospital Research and Reference, and he's a consultant rheumatologist there. In addition to having served in the National Indian Mission and in areas such as Northeast India and Afghanistan, his special areas of interest include musculoskeletal ultrasound and nail fall capillaroscopy, and he's done really good work in this particular specialty. So thank you, sir. And the topic which he's discussing today is, of course, IgG4 disease. A difficult disease to diagnose and treat. So we hope at the end we'll have some clearance as to how to manage this disorder. Thank you, sir.
Thank you. At the onset, I would like to thank Professor Uma Kumar and the organizing committee for considering me for this talk on IgG4 related disease. So over the next 15 minutes, I will be talking in the following heads. This will how the talk will proceed. And it's the disease of the 21st century. The first report of IgG4 related disease came in NEJM in 2001 from a Japanese group which had a few patients with sclerosing pancreatitis, or also known as autoimmune pancreatitis type 1, who were found to have raised IgG4 levels. So over a period of in the next decade, it came to be known that a lot of other organ involvements are also there, which have got high serum IgG4 levels. And a lot of eponymous diseases like Mikulicz, cutaneous tumor, and renal thyroiditis, which were discovered in the previous century, were actually, in fact, IgG4 related disease. And very soon, in a very short period of time, they could actually define what is IgG4 related disease and what is the characteristic features of them. So basically, you need to have one tumefactive mass associated with raised serum levels of IgG4 and tissue infiltration of IgG4 plasma cells. And there is a characteristic histopathology about which I'll be discussing it in detail as we proceed. So a typical patient of IgG4 related disease would be a middle-aged to elderly male And we also would have common organs which are involved. These are the lacrimal glands, the major salivary glands, pancreas, and retroperitoneum. Of course, a lot of other organs have also been described, and these are the typical organs which are involved. And there is a male preponderance for these diseases, except for head and neck involvement, where there's a female preponderance, or almost an equal ratio between the males and females. And we have the Indian study by Dr. Duggal from Gangaram, who had actually almost an equal male to female ratio, and the average age was around 40 in their cohort of about 70 patients. So what are the dysfunctions leading on to the involvement of these structures? So in head and neck region, we got meningeal involvement, and we got the varied neurological complications. Depending on the site of involvement, you can have multiple cranial palsies from basilar meningitis. You can have the pituitary involvement with pituitary dysfunction, both anterior and posterior pituitary with endocrine deficiencies. We can have orbit and cavernous sinus involvement with, again, involvement of extraocular muscles and inhibition of extraocular movements, and also multiple cranial palsies, and proptopsis and orbital pseudotumor. We can have the characteristic involvement of lacrimal gland and the salivary glands leading on to the Zika symptoms, which are quite prominent in these patients. And you can have sinus and nose involvement with quite a destructive process, which can resemble GPA, or granulomatosis with polyangiitis, or even malignancy. Then you can have thyroid gland, which can grow to enormous proportions and cause pressure symptoms in renal thyroiditis. So in chest and abdomen, you can have constrictive pericarditis, fibrotic pleura. You can have stenosing mediastinitis with all the major vessels and airways compromised because of the involvement, because of extensive fibrosis due to IgG4 related disease. And of course, pancreas is a prototype organ which has been described before, and you can have both exocrine deficiencies leading on to weight loss and malnutrition, and you can have endocrine pancreatic failure leading on to diabetes. And you can have chronic hepatobiliary failure also. So renal involvement is also well known. You can have a tubulointerstitial nephritis type of picture, or you can have a membranous glomerular nephropathy. And you can have retroperitoneal involvement leading on to hydronephrosis, and which can lead to renal failure due to obstructive uropathy. And you can have a mesenteric fibrosis. Again, it's a more of stenosing kind, which has got a chronic abdominal pain. And you can have the aorta and the large vessels involved in more of a peri-aortitis type of fashion, and you can lead to aneurysms and inflammatory abdominal and thoracic aneurysms. So before we come to how to diagnose, I would slightly dwell upon IgG4, what is unique about this particular immunoglobulin. So as we all know, immunoglobulins, immunoglobulin G is the most commonest immunoglobulin, and it's found in grams, about 6 to 16 grams per liter. And IgG4 is the least common of all the immunoglobulins. We got about points. It's got a wide variation in the general population of 0.01 to 1.4 milligram per milliliter. But in an individual person, generally the concentration remains static. So there are few characteristics of IgG4 where in the CH domain, there is a less stimulus of the Fc gamma receptor and the complement activation. It doesn't have a classical inflammatory function compared to other immunoglobulins. And as with all immunoglobulins, it is released from plasma cells. One of the characteristics of IgG4 is it can have intra-chain and interchain disulfide bonds between the inside the heavy chain and also between the heavy chains. And it can also bind with constant region or FC region, rather crystallizable region of both heavy chains. And it can bind with other IgG4 antibodies. And there is something called FAB arm exchange, where you got the antigen binding arm So you can have a divalent IgG4 molecule which is reacting to two different antigens. The basic problem with this FAB exchange is that it's not able to form immune complexes. So there is no downward escalation of the inflammatory cascade or the common effects of immunoglobulins which we see. So what is the trigger of IgG4 is exactly not known. One is you can have an autoimmune process which is going on. So a lot of targets have been found like carbonic anhydrase, annexin, laminin and all. And they lead to autoantigen presentation and activates the immune system. You can have a molecular mimicry which is going on. Carbonic anhydrase of H. pylori has shown to have similarity with our carbonic anhydrase, and this can trigger the autoimmune process. And infectious agents can trigger the innate immunity, leading on to the activation of T cell dependent B cell activation, leading on to IgG4 excess. So by and large, it has been known as a Th2 type of reaction involvement, T helper cells 2, and they got the prototype cytokines of IL-5, 4, and 13, which trigger the formation of IgE from B cells and also IgG4 production from B cells. And T regulatory cells, especially follicular T regulatory cells, can also produce interleukin 10, and they can lead on to IgG4 production. So finally, what happens is with all this cascade, you will have accumulation of all the plasma cells and some amount of eosinophils, leading on to the tumefactic enlargement of the affected organs or sites. And later on, you can have fibrosis and organ damage and dysfunction. So there are two ways the T cells help the B cell activation in IgG4 related disease. One is you got a T follicular helper cells, predominantly in the lymph nodes and germinal centers, where they secrete IL-4 and probably IL-10 also, and they stimulate the B cell to form IgG4 positive plasmablasts and possibly IgE plasmablasts also. So there is a class switch which is happening. And this proliferation of T follicular helper cells and B cell expansion leads to lymphadenopathy in IgG4 related disease. And you can have the raised tissue and serum IgG4 and even IgE levels. And you got long living plasma cells which continue to secrete IgG4 and they might be refractory to treatment with rituximab. So another T cell which has to be found to be more contributory to the pathogenesis is activated CD4 T cells, which are of the cytotoxic variety, and they activate the B cell, and they also form with the B cell help, they also get activated, and they form with the help of interleukin 1 beta, TGF beta, and interferon. They increase the fibroblast proliferation. And this leads to the fibrotic component of the IgG4 related disease. And of course, the damage which is there. So both the infiltrate is there and the characteristic fibrotic pattern is because of this. So the characteristic pathologic findings are the dense lymphoplasmacytic infiltrate and the obliterative phlebitis, which takes place in IgG4 related disease. And the characteristic fibrotic pattern is the storiform fibrosis or a whorl-like pattern, which is seen in IgG4 related disease. All three might not be present. You might have 1, 2, or 3 depending on the organ involvement. So characteristic imaging features are you can have a paravertebral soft tissue shadows or soft tissue encasing large vessels like aorta. And we have got a classification criteria for IgG4 related disease where we got an entry criteria which specify the characteristic organ. And the most important thing is the exclusion criteria where we should know when it is not IgG4 related disease. And later on we go to the inclusion criteria. It's a complicated weighted criteria. I'm not discussing the details. One more important thing is how important is this measurement of serum IgG4 in these patients. Up to 40% of people can have normal IgG4. Its level increases proportionate to the number of organs which are involved. And there's always the tissue serum paradox. You can have a disproportionate increase in the tissue IgG4 levels, and serum does not show that much of increase. In case of high IgG4 levels, it can, especially with multi-organ involvement, it can be used as a biomarker. And the fall in IgG4 corresponds to the regression in the disease. And you can have false positives in various other conditions like ANCA-associated vasculitis, bronchiectasis, and chronic inflammations, even chronic fungal infections. And so we cannot use IgG4 to rule in disease or rule out the disease. And we should have the other features of histopathology and the clinical and radiological features. The important thing is when it is not IgG4, when there is fever, there is no objective response to glucocorticoids clinically. And generally, there are no cytopenias or characteristic autoantibodies in IgG4 related disease like ANCA or dsDNA, anti-Smith are generally not there. And if you got a radiological suspicious of malignancy or a rapid radiological progression, it's a very insidiously progressive disease. So we should think that it's not IgG4 related disease. Massive splenomegaly, again, is not a characteristic of the same. Histology, when you got a predominantly neutrophilic infiltration, any suspicion of malignancy, presence of granulomas, necrotizing vasculitis, prominent necrosis, then we should think again before labeling the patient as having IgG4, even if the serum IgG4 levels are very high. Yeah. I'll just there is a simpler diagnostic criteria which has got clinical radiological features. Serological diagnosis raised IgG4, and we need to have increased proportion of IgG4 plasma cells compared to the IgG4 positive cells, at least more than 40%. So there are various phenotypes. Broadly, we got two major phenotypes, that is the proliferative subtype and fibrotic subtype. Proliferative is generally seen in glandular and epithelial tissues, and fibrotic is generally seen in the retroperitoneum and extra organ involvements. And that is generally has less tissue as well as serum IgG4 level raise. That is more refractory to treatment compared to the proliferative subtype. So management is watchful waiting is not a common possibility in IgG4 because a lot of damage has already occurred by the time the patient reaches you. Unlike in sarcoidosis, we can have watchful waiting in some people. Early initiation of treatment, glucocorticoids generally at 0.6 milligram per kilogram per day for 4 weeks, and taper later on at 5 milligram per week is commonly followed. And if there is no response in those 4 weeks, then we should rethink our diagnosis. And there is a risk for relapse if you got very high IgG, depending on basic serological, demographical, glucocorticoid dosage used, involved organs, number of organ involvement, peripheral blood cells. I just skip this. And in refractory cases, that is people who initially respond to glucocorticoids, but later on they recur again, there is a role for rituximab and possibly other DMARDs, though they have not been found to be as successful as prednisolone. And a lot of supportive care is required for obstructive symptoms which are there, or a mass effect which is there because of IgG4 related disease. So there's a future of IgG4 management. Probably it will be a targeted therapy which can target either the cell with the cell markers, basically naive B cells, plasma cells, and all, or the cytokines secreted by the cells like IL-6 inhibitors in tocilizumab or IL-1 beta. And the future lies in probably a targeted therapy with different therapies for different phenotypes. So with that, to conclude, it's a tumefactive disease with increased serum and tissue IgG4 levels. It's got a very insidious course, doesn't progress rapidly, but a lot of damage has already occurred by the time patient reaches you. You should recognize the phenotype of the patient, and they're all steroid responsive. Thank you.
Thank you, sir. Presentation. As we are short of time, we'll not take up questions. We'll go to the next. Thank you, sir.
Thank you, sir. Now I invite on stage Dr. Colonel Vinay Kumar Singhal, sir, to deliberate on the topic interpretation of common immunological investigations in rheumatology. I request esteemed chairpersons to introduce Dr. Vinay.
Senior consultant. He has a vast experience in rheumatology.
Sorry for that. Down कहाँ से? Yes.
Sir is going to talk on integrated common investigation. Lab investigations play a very important role in any patient with autoimmune disease. Right interpretation is important. Bent over or under diagnosis. Over to sir.
Good afternoon, everybody. It has been a long day, and I can see fatigue on the faces of many of you. And this topic was supposed to be with Dr. Rajiva, but something conspired between Dr. Rajiva and Dr. Uma, and it came to me. So I try to finish it in time. I think it is an important topic because none of the immunological tests are without false positive and false negative. If we don't interpret them correctly, then we may believe that a person with false positive test actually has a disease and we may treat it wrongly. Similarly, if we have the test is false negative, we may wrongly exclude the disease. So this I'll be discussing following antibodies, rheumatoid factor, anti-CCP, ANA, ENA, complement levels, antiphospholipid antibodies, ANCA, and if time permits, ESR and CRP. Now, rheumatoid factor and anti-CCP can be taken together. Their sensitivity is almost equal. Rheumatoid factor and anti-CCP sensitivity of about 70%. But specificity for CCP is 90 to 96%, very specific. So it is a better test and more expensive test also. Now, what if RF and anti-CCP are positive in a patient who meets the criteria for rheumatoid arthritis? We don't need these tests to diagnose a case. Diagnosis we can make even without these antibodies. But if a patient is meeting the criteria, they have prognostic value. RF and CCP positive means it is more severe disease. They may require more aggressive treatment. It may be an erosive disease if anti-CCP is positive. Now, if the patient doesn't have symptoms, firstly, we should not be doing RF anti-CCP in an asymptomatic patient. But if we do and they come positive, we should never treat them. This may mean that patient is having probably preclinical RA, which does not require treatment. But at the same time, if both RF is positive as well as anti-CCP is positive, the patient is very likely to develop rheumatoid arthritis later on. Chances may be of the order of 90 to 100%. So we should watch him carefully. Now, if patient is asymptomatic, we do rheumatoid factor as a part of body checkup maybe, and it comes strongly positive. Then what do? We exclude other causes, which may be like autoimmune disorders. All autoimmune disorders can be RF positive, chronic infections, miscellaneous conditions like malignancy, they can all have rheumatoid factor positive. If we don't find them, then we ignore the rheumatoid factor. That means it is not important. It may be present even in healthy people. Now, second antibody is ANA. It is very sensitive test, sensitivity close to 100%. So if it is negative, it is very rare to have SLE. Mainly for SLE, it is very sensitive, but specificity is low, just about 60%. And weak positive, 1 in 40, 1 in 80, we consider weak positive, which have many healthy individuals, 32% here and 15% here, may have weak positive ANA. But strong positive ANA is uncommon. So strong positive is much more important than weak positive. Now, if we do the test in an asymptomatic patient, it should never be done as a part of body checkup, but it is done very often like this, and it may come positive. Then what do? If it is low positive, we ignore it. It may be present in many normal individuals. But suppose it is strong positive and patient does not have symptoms. Strong positive, chances of having autoimmune disease are quite high. Then in those cases, then we evaluate for the presence of any underlying autoimmune condition. And if we don't find any condition, then we also look for
other non-rheumatological conditions like Hashimoto, Graves' disease, hepatitis, etc. Because these conditions also may have ANA positivity. Now, suppose patient now sometimes to save money, many people do ENA without doing ANA. It is quite common to do like this. It should not be done. Why? Because ENA can also be false positive. We don't do ANA. ENA may be false positive because the antigen on the slide may get denatured and it may become false positive and we may be misled. So always ANA should be done before doing ENA. Second, ENA can be negative even when ANA is positive. This we all know that ENA can be negative and ENA can be positive with so many other conditions, and even in lupus, ENA may be negative because ANA is much more sensitive than ENA. Now, suppose patient has 1 or 2 features of systemic connective tissue disease and ANA comes positive. That means he definitely has some underlying connective tissue disease. Either it is undifferentiated connective tissue disease or definite connective tissue disease. Typically, there are 6 ENAs. ENAs are extractable nuclear antigens because they could be extracted, and earlier there were only 6 ENAs. Nowadays, we call them sometimes ANA profile, and we do battery of 10 or 20 tests also in many labs. These ENAs were anti-SSA, SSB, SCL70, RNP, anti-SM, and anti-Jo1. Now, we have already evaluated the patient, and we know which disease patient is likely to have. Like even say we suspect systemic sclerosis. For diagnosing systemic sclerosis, even ANA positivity is not a must. ANA is positive in only 85% cases. So before doing ENA, we already know that patient is likely to be having systemic sclerosis. And then we do ENA, then these investigations have confirmatory importance or prognostic importance. Now suppose anti-centromere antibodies come positive. So this confirms our diagnosis. And we know that patient will less likely to develop ILD and more likely to develop PAH. Similarly, anti-SCL70 positive means more likely to develop ILD. It can develop ILD, PAH both. Anti-RNA polymerase means patient can develop scleroderma renal crisis. And then there can be other antibodies like U3RNP, PMSCL, QOTH. They can be associated with diffuse ILD with diffuse scleroderma with ILD. Now, suppose patient has features of Sjogren's syndrome. Anti-Rho and La come positive. Now, this can be positive with Sjogren as well as subacute cutaneous lupus, neonatal lupus, and congenital heart block. There are 3 antibodies, anti-Rho 60, anti-Rho 52, and anti-La. Usually all 3 are present together. But what if anti-Rho 60, it is against 60 kilodalton protein, is positive, and anti-Rho 52 is negative? Does it mean different? It still means that patient may be having Sjogren's syndrome, but alone as anti-Rho 60 is more common with SLE. If all 3 are present, it is more likely to be Sjogren's syndrome. If anti-La is positive, it usually does not happen. But sometimes if anti-La is positive, this doesn't indicate Sjogren's syndrome. It can happen in, say, liver diseases like chronic biliary cirrhosis, etc. Now, coming to anti-Smith bodies, anti-RNP antibodies. These are always taken together. The reason is both these antibodies are for same antigens, which are spliceosomes. Spliceosomes are the antigens which supplies the messenger or pre-messenger RNA to messenger RNA. They remove redundant nucleotides from pre-messenger RNA. If they don't remove it, then messenger RNA will be defective and protein synthesis will be defective. Now, both are against spliceosomes, but if they are under low molecular weight spliceosomes, then they are anti-Smith. Then disease will go towards SLE. If they are against higher molecular weight spliceosomes, like 68 to 70 kD, then it is U1 RNP, it will go towards MCTD. It has to be positive in high titer to be called MCTD. But in SLE, anti-Smith is quite specific. About 20-30% patients will have it, but its specificity is there, but sensitivity is low. Now, anti-dsDNA antibodies, we all know we do it by ELISA, positive in 78 to 80% cases. Specificity is about 70%. It's a high titer in active lupus nephritis, and its level sometimes may fluctuate with disease activity, not always. If the patient during active disease has higher level, which comes down with treatment, that means it can be used to measure the activity of the disease. Next are antiphospholipid antibodies. These can be primary, secondary. Secondary can be with associated autoimmune diseases. They can be present with antiphospholipid syndrome features or without them. There are 3 subtypes. Now, here significance of titer. When we do this, we all know titer has to be more than 1 in 40 GPL or MPL for anticardiolipin antibodies. Then only it is significant. Low titer can happen with viral infections also. Significance of repeating all these should be repeated after 3 months. If after 3 months they become negative, then it is not antiphospholipid syndrome. It was probably because of viral infections. If 2 or 3 are positive, if 2 are positive here, they are high-risk patients. And if only LSA is positive, that means it is more thrombogenic than alone as anticardiolipin or beta-2 glycoprotein. If they are positive without symptoms, we usually do not treat them unless some other conditions are there which are thrombogenic, which make the patient more thrombogenic than usual. Next is the complement level. There are 3 pathways we know: classical pathway, lectin pathway, alternate pathway. Most important is the classical pathway. This is used by all systemic rheumatic diseases, vasculitis, etc., mostly by SLE. Now here, this C1q attaches to the immune complex and activates C2, C3, C4. So level of all these, they become low during active disease, active SLE. But sometimes only C4 may be low and C3 may be normal. When this can happen? One, it can happen if C4 deficiency is there. Secondly, in angioedema, when C1q is low, C3, C4 are activated, but somehow they don't need to form a membrane attack complex. So in those conditions, C3 may not fall, but C4 may fall. So in angioedema, only C4 may be low. Lectin pathway is low efficiency. These C3 in this C3, C4 usually do not fall. Alternate pathway, this can be in some patients with SLE can also take on this pathway, but it can be in rheumatic fever, post-streptococcal glomerulonephritis. They may utilize this pathway. Here C3 in a way can be self-activated and it does not require C4. So in this only C3 will be low, C4 will not be low. But most importantly, C3, C4 both will be low in lupus. In many patients, not in all. If during activity, when we see the patient, if they are not low, then they are not correlating and they may not be used for seeing the activity of the disease. Now coming to ANCA. ANCA, this is C ANCA. This slide is showing C ANCA, cytoplasmic, and this is perinuclear. This black thing is nucleus, around it is the inflorescence. Here it is in the cytoplasm. C ANCA corresponds with PR3. This corresponds with MPO. Now, gold standard for ANCA is ELISA and not the immunofluorescence. Unlike in SLE. SLE gold standard is immunofluorescence because that is more sensitive. Here, ELISA is more sensitive, so that is gold standard. And we need to do both the tests, ELISA as well as immunofluorescence, because then the specificity increases. Now, if ELISA, and these both are positive, and the patient has GPA, then we don't need the biopsy. They are so specific that it will be positive in more than 95% of the patient will have the disease. So biopsy will not be required. If only one is positive, then we need to do the biopsy for confirmation. ESR and CRP, we all know ESR and CRP main difference is ESR changes slowly. Over a period of weeks, it goes up, and over a period of weeks, it comes down. While CRP changes rapidly. CRP goes up in a matter of few hours, and it comes down in 1 or 2 days. So both are markers of inflammation, but ESR is much cheaper than CRP. In certain conditions, we may need to do CRP. And what are those conditions? Like when we suspect infection. Infection ESR will not change fast, but CRP may go up, and after treatment, it may come down fast. So for infection, we may need to do CRP along with ESR. Similarly, in, say, SLE relapse, in SLE relapse, it is believed that CRP doesn't rise very much. If it rises very much, then it goes in favor of infection, more than 5 times of normal. And but again, we must know that none of these things are sacrosanct. In osteoarthritis, we need to do both ESR and CRP both to see for the activity. And if we need to see the response to treatment, CRP changes faster. If we give steroid pulse in a disease and we want to see whether it is working or not, we do CRP in place of ESR, or we do both of these. If there is extreme elevation of ESR, say more than 100 millimeter, we should suspect these conditions. But if none of them is there, then we just ignore it and repeat it after 3 months. And if after 3 months it doesn't come down, we again evaluate the person. But it does not always indicate that person has a serious disease. Sometimes ESR may be raised, it may come down on its own. To conclude, we should know which immunological tests are present in which condition. This is important, but interpret them only in clinical context. Thank you. I've finished before time.
Thank you, sir, for such a comprehensive, simplified coverage of the topic. I think there's no time to take questions, and we can move on to the next session. Thank you to all the speakers.
Thank you.
Session. First, I invite Dr. Vivek Rana, sir. Dr. Vivek is currently working as consultant in the Department of Medicine at Baba Saheb Ambedkar Hospital, New Delhi. Next, I invite on stage Dr. Kiran Seth, ma'am. She is consultant rheumatologist, Metro Hospital, Noida. Next, I invite Dr. Nikhil Gupta, sir. Dr. Nikhil is currently working as senior consultant rheumatologist at Sant Parmanand and Saroj Super Speciality Hospital, Delhi. He has more than 70 publications in various national and international journals. Now, I'd like to invite Dr. Neeraj Jain, sir, to deliberate on the topic post-COVID systemic autoimmune inflammatory diseases. I request respected chairperson to introduce Dr. Neeraj, sir.
Good evening, everyone. And at the outset, I would like to thank Professor Dr. Uma Kumar for this kind invitation. It's really a privilege and honor to be speaking at JLN Auditorium of All India Institute of Medical Sciences, which is a dream for everyone in India, at least. I would also like to thank Professor Dr. Ved Chaturvedi, sir, for sitting here and for encouragement. And any talk in this pandemic can't be finished without talking about COVID, you know. And since this is the last medical talk before Dr. C.S. Yadav takes over, so COVID needs, still COVID needs a lot of attention. And you all will agree that we all are facing a lot of problem in our clinical practice. Patients are presenting with classical lupus symptoms, classical rheumatoid symptom. But the dilemma continues in our mind whether it is it a classical lupus, it's a classical rheumatoid, classical SPA, any vasculitis. But since COVID is like in our mind, क्या ये COVID हो सकता है? Everyone is asking this question, and even the patient is asking कि मैं तो बिल्कुल ठीक था, ये COVID के बाद ही हुआ है. So thank you, chairpersons. I will start my talk now. So as you all know that COVID has caused unprecedented hardship in the 21st century with more than 150 million infections all over the world. And I was just 5 minutes checking my internet, and it's almost 51 crore people have been affected in the world over with 65 lakh deaths. But even rheumatology, though it may be a budding field or is a nascent field, but we are very much concerned about post-COVID issues because various immunological phenomena have been described during the course of the infection, and this infection has also triggered autoimmunity. And rheumatological illness have been described following resolution of acute infection. This is very important. So what are the key questions in our mind? What is the molecular mechanism behind that triggering autoimmunity? What are the genetic, do we have some genetic predisposing factors? Are autoimmune or an auto-inflammatory response associated with various variant different in SARS-CoV-2? And what is the nature of SARS-CoV-2 pathogen, which is associated with molecular patterns that triggers autoimmunity? I will try to answer most of my key questions. So we all know that viral infections are known to have a complex relationship with autoimmune diseases, especially lupus, rheumatoid arthritis, Sjogren's syndrome, celiac disease, and multiple sclerosis. And a lot of autoantibodies have been reported in patients with COVID-19 in different frequencies, especially anti-nuclear antibodies, which is present in almost tune of 35.6% in the literature search so far. And anti-Rho, SSA, rheumatoid factor, almost 19%, lupus anticoagulant, and antibodies against interferon. Yeah, definitely genetic predisposition has been shown, which involves human HLA polymorphism and some non-HLA genes as well. Female gender have little predisposition, age being more common in reproductive age due to effect of estrogens. Definite some family history of autoimmune disease leads to trigger of this illness, and individual history of autoimmune is definitely a strong factor, and presence of autoantibodies as such as anti-nuclear antibodies. So I will just briefly touch upon what happens exactly in SARS-CoV-2. If you can see this SARS-CoV-2 virus, the main receptor which involves is ACE angiotensin converting enzyme 2 receptor. So once the virus enters the membrane and touches the ACE2 receptor, there is a surge of NF-kappa beta and NLRP3 antigens. And ultimately what leads to overexpression of ACE overexpression and ultimately leading to increase in viral load, increase in viral reservoir, and which leads to cytokine storm, increase in reactive oxygen species, tissue damage, extrafollicular B cell productions, and autoantibodies. And simultaneously, decrease in interferon leads to decrease in antiviral macrophage activity and decrease in NK cell activity, which ultimately leads to increase in infection. I won't go in detail because paucity of time. So ultimately what happens is there is an increase in thrombosis. Lymphopenia is a main factor, transitory decrease in this sentinel effect. And this, if you see the last part, once the infection settles down, there is an increase of lymphocyte. And this is known as immune reconstitution of an unregulated immune response, and which is one of the major factor for autoimmunity. So what I did was that since this pandemic has been going for 2 years, I thought I will search the literature. And I found few studies. They have searched almost 1900 articles in this study. And out of this, 90 articles were very relevant. And they did put a lot of search like vasculitis, lupus, rheumatoid, scleroderma into these search items. And what they found was that every organ involving from top to bottom, if you see giant cell arthritis, sarcoidosis, systemic sclerosis, focal aortitis, rheumatoid arthritis, reactive arthritis, everything you name it, and it was present in their search items. So clinical spectrum of autoimmune related manifestation COVID-19 may be divided into organ specific and systemic autoimmune and inflammatory conditions. Cutaneous vasculitis, ITPs, transverse myelitis, GBS are more of an organ specific. Systemic vasculitis, multisystem inflammatory syndrome. I won't touch into detail about MIS. I will be restricting to rheumatological illness and SLE. So if you divide into 3 different items, this on the left-hand side panel, if you see, it's more of vasculitis, ANCA-associated vasculitis, cutaneous vasculitis, IgA vasculitis, and polyarteritis nodosa, anti-GBM disease was more common. In musculoskeletal reactive arthritis, axial and peripheral SPs, rheumatoid arthritis, and in CTDs, inflammatory myopathies, lupus, sarcoidosis, systemic sclerosis was more of reported. So this is the gist of their studies they did. And if you see the 4th column from the bottom, days after COVID-19 infection, the coming up of autoimmune rheumatic disease, even after settling down of infection, 3 to 4 weeks later, there was a surge in immunological response. So what they found was that most common new onset rheumatic disease was vasculitis and arthritis. And this we all are facing in our day-to-day practice, and I think everyone will agree with me. So I will start one by one. What is initial presentation? Vasculitis, initially we started seeing a lot of, in 2020 early, we started seeing a lot of patients with acral skin lesions, chilblains, and a lot of COVID-19 involved toes were reported. The photos were coming on WhatsApp, what is it, what is it? Then we came to know that it's probably COVID-19 possibility. Then cerebral and GI vasculitis, maybe DIC or a systemic thrombosis was the mechanism for primary vasculitis. All vessels, small, medium, and large, were mostly reported subsequently. In fact, in children, Kawasaki disease was one of the most common vasculitides, which was encountered in post-COVID-19. And this is just a one slide about Kawasaki disease. Is this Kawasaki disease post-COVID-19 same as the classical Kawasaki disease? No, there are some differences. This COVID-19 post-Kawasaki disease was more in older patients. There was a higher rate of cardiac involvement with myocarditis and pericarditis, and many patients went into Kawasaki disease shock syndrome with macrophage activation, lower platelet counts. They were more resistant to IVIG treatment, and they have a lot of initial GI and neurological involvement. And the most common vasculitis was ANCA-associated vasculitis, and all phenotypes of AAV were reported, and most patients had kidney and lung involvement. So whenever there was a patient with COVID-19 and kidney injury, so you just need to check the urine analysis, and if you find RBC cast or a dysmorphic erythrocyte, there should be a strong suspicion of vasculitis, and ultimately ANCA should be done. But one thing was very clear, that there was less of diffuse alveolar hemorrhage in COVID-19 positive patients. Then there were case reports of cutaneous vasculitis presenting with palpable purpura, hemorrhagic bulla, or arterial vasculitis. Large vessel involvement was reported with aortitis and GCS, and commonly the thoracic and abdominal aorta was reported. The etiology was not clear. Many cases were reported with IgA vasculitis, PAN, and anti-GBM disease. But one thing was very sure, that most cases responded well to standard immunosuppressive treatment and had resolved or improved on the follow-up management. This is very important, articular involvement. So there were a lot of cases were reported during the prodromic phase, during the active phase, and the recovery of SARS-CoV-2 infections. So what was the mechanism? Possibly molecular mimicry between some viral epitopes and the synovial membrane. So first scenario was that what happens in prodromic or an active phase? Definitely it was short-term, limited, does not lead to chronic joint involvement. And many times they were associated with hepatitis virus, parvovirus, enterovirus, rubella. And definitely there was some molecular mimicry between viral epitopes and synovial membrane. The other scenario was articular symptoms, which happened after the resolution of SARS-CoV-2. And most of these patients belong to this group. And mind it, these patients definitely fulfill the classical classification criteria of rheumatoid arthritis or spondyloarthropathy. Possibly the RA triggered by the virus, probably through the production of rheumatoid factor or anti-CCP. And definitely induced antibody, they differed from the normally found RA was not clear. The second group in arthritis was spondyloarthropathies, and this group involving inflammatory rheumatic diseases involving the joint of the axial skeleton, even the enthesial involvement, peripheral joint, and most common and characteristic initial symptom reported in this patient was chronic back pain and in the buttock pain. And reactive arthritis, in last 3 months, I have seen 3 patients with presentation with reactive arthritis, and it was definitely a sterile arthritis that occurred after 1 to 4 weeks of a genitourinary or a GI bacterial infection. Mostly it is mono or oligolar arthritis, can present as balanitis, and they all responded well to NSAIDs or short courses of steroid or a local intraarticular injections. And another important cases reported was idiopathic inflammatory myopathies. Myalgia was the most prevalent constitutional symptom reported in literature in almost these 1900 articles searched. And muscular injury, which was defined as presence of myalgias and a CK of more than 200, was documented in almost 10% of hospitalized patients by COVID-19. An increased level of CK was definitely associated with the COVID-19 severity. And one thing which I observed, that inflammatory myopathies happened more in patients who had moderate to severe COVID-19, who had hospitalization rather than mild COVID. And the clinical spectrum of muscle damage due to SARS-CoV infection varies from asymptomatic elevation of CK to a very severe rhabdomyolysis. Few cases of rhabdomyolysis has been reported in literature. And what was the mechanism? Possibly there was a direct viral muscle invasion, maybe immune complex deposition in muscles, and there was probably some release of myotoxic cytokines. And damage was due to homology between probably a viral antigen and a human muscle cell. Lupus, this is like the most talked after disease in patients with COVID-19. Definitely, it was because of induced developed and autoantibodies like ANA, anti-Rho SSA, and anti-phospholipid. And they were with presentation was almost similar like a classical lupus, fever, fatigue, arthralgias. And in patients with SARS-CoV-2 infection, thrombocytopenia was little unusual. They didn't drop below 1 lakh. Pleural effusion was detected by chest CT, and kidney injury was more associated with severity of illness. And management didn't differ. It was like similar to a standard classical lupus management with methylprednisolone, hydroxychloroquine, chloroquine. Even few patients received rituximab during COVID, cyclophosphamide, and plasmapheresis, and some even got IVIG. What were the other autoimmune diseases reported? Sarcoidosis, antiphospholipid syndrome. And what was the timing of autoimmune manifestation? This is important for the postgraduates here. The type of immune-related manifestation could be linked with the severity of COVID infection, and more than 50% of cases of articular disease like RA, SPA, and reactive arthritis appeared in patients with mild COVID. And more than 50% of inflammatory myopathies cases occurred in patients with severe and critical COVID-19. And definitely, IIM and SLE presented predominantly during the acute phase of SARS-CoV, while the rest presented after the acute phase settled and into the recovery period. And what are the differentiating features and approach to management? The clinical presentation is similar to what occurs with other autoimmune diseases unrelated to COVID. And cases of inflammatory myopathies and lupus were more reported in women. SPA, reactive arthritis, and vasculitis occur more in men. And patients were treated with similar management as their non-COVID counterpart. And I've just put a few slides on what happened to the prevalence and clinical outcomes of COVID-19 in patients who already had an autoimmune disease. So this was a big systematic review and just published recently in September 2021 by Akiyama. And see, on the left side of panel, there is a class of patients who had a pre-COVID immune landscape, but they already had a pre-existing immune-mediated disease. Plus, they were on targeted immunosuppressive therapy. So once they got a COVID-19 infection, so what happened to the COVID-19 severity and what happened to the underlying autoimmune mechanism? So definitely effects of infection on pre-existing immune disease state or a new onset disease was affected. Their autoimmune flares were noted. So why? Because they probably newly acquired autoantibodies or an immune-mediated disease like MISCC or an GBS. And another important entity is the long COVID. So this is very important. Probably you had an underlying autoimmune disease, you were on immunosuppressant, then you got COVID. So maybe like both affected each other. Probably COVID went haywire or your underlying autoimmune disease went haywire. So this study, what they showed that the prevalence of COVID-19 in autoimmune disease was around 0.011%. 0.011%. And those who were on glucocorticoid, they had increased risk of COVID-19 and its severity outcomes. Conventional synthetic DMARDs, biologic DMARDs, or a targeted synthetic DMARDs. Out of these, those who were on conventional synthetic DMARD had a higher chances of COVID-19, and probably those patients who were on anti-TNF therapy had a reduced risk of a severe COVID-19 infection. And this slide, I have specifically put what were the immunosuppressant therapy used in COVID-19. Hydroxychloroquine, we all know, had a lot of hype. Colchicine was used, tocilizumab was used, anakinra was used, but no guidelines supported their practice recommendation. And last two slides on COVID, long COVID-19 and rheumatology. This is what we have to face. We are still not sure. I will be finishing 2 slides last year. The most common or unknown is yet unidentified population symptom who persisted after recovery from both severe and mild COVID-19. So this is very important. Possibly long COVID, the etiology is an end organ damage or a persistent acute viral infections, or there is an exacerbation of underlying comorbidities like occult autoimmune or autoinflammatory disease state. And probably we still don't know what is the exact mechanism. So can we predict? Yeah, definitely there are some genes which can predict whether you can have a post-COVID-19 rheumatic illness. So these are few case reports like ANCA vasculitis after COVID-19. Then there were case reports with rhabdomyolysis, pauciimmune crescentic glomerulonephritis. Done, ma'am. Yeah, done. I know. So in the nutshell, it's a new onset rheumatic disease. It's rare.
Very deliberate, very good. But I like to ask a question, Dr. Neeraj.
Yeah.
I was working in a COVID-dedicated hospital with 500 patients at the time admitted with us. And we encountered situations where the patients were absolutely doing fine, and next day when you come to the round, the patient is gone because of thrombosis. Because primarily it is an endotheliitis, and we have a planned thrombosis. So what I want to know is, first of all, you said vasculitis. So is there any time interval which you noticed the vasculitis usually occurs after this much time of the patient?
That's what the study I quoted. The biggest
And
study.
how to differentiate? Because I have seen this thrombogenic potential is there for some around 6 to 12 weeks. So because the treatment is different. So how do we know this patient is going into vasculitis or it's a planned thrombosis?
That's what I was trying to.
That is very important because we lost
it's
quite a few patients.
Sir, actually, we are still not sure whether they had some underlying autoimmune disease going on and the COVID just triggered it off. We're still not sure, or just COVID has per se caused the thrombosis to occur. So I think it's a big gray area, and I think probably maybe Dr. Uma Kumar, who had seen thousands of patients of COVID, may throw some light. But even in Gangaram, we had a big COVID-19 ward, and we saw a lot of patients and few patients with sudden death.
Yeah.
So we could not come across what was the cause of sudden death actually. So probably some cardiac mechanism, cardiac myocarditis or some endocarditis probably.
No, what I was thinking was we had quite a few slides on vasculitis. So it is not possible to go in for biopsy and all those things in each and every patient. Something which tells us that maybe here we are dealing with vasculitis in a normal OPD or a normal scenario.
We need to keep our eyes open whether like we need to follow them, what happened actually. So that's why I put a slide on long COVID, because we will be facing for another year or 2 or 3 years.
Yeah, we are just
I'm not
entering the
sure,
fourth
actually.
wave also now.
So it's just an eye opener for us also.
Thank you,
Thank you,
Dr.
Dr.
Viraj,
Viraj,
for the wonderful talk. And I'm sorry I couldn't introduce you because there was nothing written here. But I think everyone knows you. Everyone knows you. So you do not need any introduction.
Now I call upon Dr. P.S. Yadav, who is the chairman and head of Department of Orthopedics and Joint Replacement at Primus Super Specialty Hospital, to give his deliberation.
Thank you. Good afternoon. Thank you, Dr. Uma. Thank you, Delhi Rheumatology Association for invite. And this lecture is basic lecture. And yeah, sure. After working 22 years at AIMS, then 2 years at Gangaram Hospital, now I am working in Primus Hospital. I am president of one association as well. So there is a confusion about the management of rheumatoid arthritis, but I am very clear about it. I have not written demand even to one patient in my life. So what I feel, we need you more than you need us. It is very simple. So it is an integrated teamwork, and we are part of that team. About the joint replacement, in Western world, it is increasing at the growth rate is around 10%, but in India, it is more like 30%, 3 times more. It is all, these are the all factors. I will not mention in detail because all you are bored since morning. So, but one thing is that this replacement surgery, it is considered to be costly, but it is not costly. It is because it is a one-time expense and you save the recurring cost. If you compare in this HIV management, liver, kidney disease management in this graph, they are very costly. It is one time and your day-to-day cost is saved. So, and processes cost is less than 1 lakh. It is nothing. So, before offering the joint replacement, find out the exact source of pain. That is most important. Sometimes we are confused. Knee ke charon taraf pain hai. It may not be of arthritic origin. It may be because of tendinitis, bursitis, or it might be coming from the hip joint referred pain, or even from the spine. So find out exact source, then offer him whatever you want. So knee and hip joints, they are most commonly replaced joint because results are excellent. You change the quality of life patient tremendously. And osteoarthritis is the most common cause. And it is really satisfying surgery. It has revolutionized the life of the patient. And about the survival, why it is most popular, more than 90% survival for 20 years. It means it is a lifetime surgery. And why joints are replaced? Pain is the most common factor for which joints are replaced. Sometimes pain is not much, like quality of life because of stiffness and deformity. Patient cannot lead life in these deformity. So sometimes pain becomes secondary, and deformity and stiffness, if these things has affected day-to-day life, then joint replacement should be offered. And but in our country is really unique in every aspect. Sometimes patient comes with these gross hip joint damage, but you can see the face of the patient. He is squatting cross. He is not in pain. So do not offer joint replacement to him. And we should try to preserve the joint as much as possible. What I feel, natural joint, but it is definitely sometimes they are replaced. And expectation of both the farmers, they are not same. We are India, we are unique country. So why inflammatory arthritis is different? Because overall nutrition level of the patient immunity is also compromised. And the tissue like bone and ligament, they are all fragile in the inflammatory arthritis. So when we are operating, we are careful, we are more gentle in hammering the component and releasing the soft tissue. So we have to be more careful in your patient. But these patients are more satisfying than the degenerative arthritis patient. Now, once you have decided you have to operate the patient, what precautions you have to take patient to patient. Most of the time, it is same precautions. Rarely, in the unique situation, patient may need different protocol. Which implant you have to use? About the implant, it is now 15 minutes lecture, not the 20 minutes. Okay. So more than 150 types of implant is available in the market. And you can imagine how we might be or patient might be confused. 150 type के joint available हैं. So only, honestly speaking, one thing is important. Choose any except Indian implant. I have no faith in Indian biomaterial, frankly speaking. Choose any good implant from the, the which countries. Then it is the surgical skills which matters for the joint replacement. Implant comes secondary and infrastructure, so it should not get infected. Even infrastructure is secondary. I will give an example later on. So now about the few point about the joint replacement. In a half joint replacement, one medial condyle of tibia and femur, they are replaced. And basically, they are shaped off. What we do, and the prosthesis is glued over that. So, but this is not commonly done in India. Results are not good. And in wherever this is a unicompartmental arthritis, we offer them non-operative treatment. Even HTO, high tibial osteotomy, is better. So I'm not in favor of uni most of the time. Even this meta-analysis says the same thing. What is done in total knee replacement? So both condyle, they are shaped off and prosthesis is glued over that. And total hip replacement, the femoral component and acetabular component, both are changed. Now about the total knee replacement, foundation is three most important component. Soft tissue balancing, joint has to be properly balanced. The stiffness of medial and lateral sleeve, they have to be equal, and anterior and posterior. All three dimensional, all the four direction, joint has to be balanced. That is most important step. Second comes proper bone cuts. Third, proper gluing, cementing. I have seen more big surgeons doing live demonstration surgery. They do good surgery, but they do not give respect to the cementing. If you do not give respect to the cementing, everything is fine. Joint will fail within 5 years. It will not fail early like 2-3 years. But if you do it properly, it will last more than 20 years. So this is how the joint is replaced. I will not go into the detail. चल रहा है ये video? नहीं. So it is brief about the how we do total knee arthroplasty. As I told you, surgeon is the most important. Then comes the infrastructure. Lastly, the processes. And about it is not the ordinary orthopedic surgeon job. Surgeon has to be dedicated, trained, and skillful, honest as well. That is most important. Sometimes we offer treatment, we offer the processes which is costlier, and we have our motive about the costlier process. It is true in every field. So basically results are with lower cost processes, but you are offering higher cost. I have seen in practice, I have seen at AIMS, even in private practice. So honesty is also important for the good result. Proper infrastructure and proper patient selection. So this lecture is very close to my heart, and I am delivering it for last 15 years. And this highlights the market forces. In every field it is there. In arthroplasty, it is very much there. And malpractices, or you can say it is wrong practice just to earn little more money. And we have this also highlight our unique practice, how we do it differently from the other surgeon. And it is this is also done by only handful surgeon, what we do. So we do with the mid-vastus approach. We do not cut the Q tendon. If you do not cut the Q tendon, only 5-7 surgeons in the country, they use this approach, not cutting the Q tendon. If you do not cut Q tendon, there are two advantages. Patient can do SLR second day, full. Second, tracking of alignment of patella is better. And other thing is that we use cruciate retaining knee. We do preserve PCL, we do not cut, box cut in the center and do minimum release. If you do minimum release, patient will be happy, natural and confident from the second day of surgery. It is done by only handful surgeon, but most of the surgeons, they do it differently because that is more easier. Our practice is little tougher. It needs, you have to work only in 2-3 millimeter where they get more than 5 millimeter space. So you should have good control over your saw. That is most important. So what are the advantages? I say in my OPD, no need to call physiotherapist at home. Do yourself. We teach them and it is, we give in writing on there. If they call themselves, we have no problem. And we do not give any blood to any patient because hardly blood loss is there if you do it differently. And less post-operative symptom, more natural joint and more natural feeling and early recovery. Every our patient go up and down the stair before the discharge. We discharge in 4 days. As I told you, it is the surgeon which matters most. We have matters most. We have done 218 joint replacement at Leh Ladakh. And each and every joint was successful. There is a queue. Dr. Uma knows that. Long queue over there. Last October, we did 42 joint replacement. We left around 15 joint replacement over there. And this our work has been appreciated in BMJ award nomination. Ladakh work. We also go to one village in Dasmal. We have done 89 joint replacement and all successful. It means it is the surgical skills which are most important. Other things are secondary, they are important, but quality of surgery most important. So my big no, as I told this, I give this lecture to practice, my big no to all these things, because these things benefit implant company, hospital and surgeon, not to the patient. So I always speak against my big yes, this is good for the patient. So about the joint replacement for the patient general, it is very satisfying surgery, and because more than 1 million joints they are replaced every year, and rarely any complication. And overall, as I told you, it is a lifetime procedure. If you do at the age of 50, if you do below the 50 age, it can patient may need revision, but revision can be done very easily in a skilled hand. And there is a no age limit for the surgery. After the skeletal maturity in the young and in elderly, if they are willing to lead good quality of life and they are fit, it can be offered. And only 5 days duration, patient start from the second day, and in 3-4 days they go for walk up and down stairs, and up and down, as I told you. So overall rehabilitation is faster. Why we do up and down stairs in 3 days? Because we preserve the PCL. So other surgeons, they start walking, but they do not allow up and down stairs. So sound practice is also, we never give blood, as I mentioned, because blood loss is minimum, except in bilateral total hip replacement. How patient is benefited? It is the pain goes, deformity goes, even range of motion improve. And all the activity patient can resume except high impact activity like these. And these activities have to be avoided. Otherwise, even these activities like swimming, no high impact, patient go for swimming, hiking, cycling, all these activities are allowed. Sexual activity, once you are comfortable, it can be done usually after 4 weeks. So there is a few points about the market forces. We have 2 minutes. There is only 1 letter difference between hype and hope. Only 1 letter. So many things came with the towering claim. Either they disappear or they withdrawn from the market. It is routine in every field. So it is surveyed, thousands of drugs, many interventions, many components, they are useless to the society, just delivered to earn more money. So it is dollar-driven degradation. So about the navigation robo. So these things, overall conclusion is cannot replace the surgical skills, because there are more than 24 steps in total knee arthroplasty. These things do only few steps, and each and every step is important. and it has to be good for the good long-term result. These are the various designs. They are hyped, as I mentioned, mobile bearing, it with the runover processes, came with the towering claim, disappeared. Now nobody use it. Gender needs, it is for the female, came, company came, but it is also disappeared. So these are the overall messages. Management of arthritis is teamwork. Orthopedician has only surgical role. We do not write demand. Rheumatologist had the medical management. Orthopedician should not hesitate to take care of I always take care opinion and refer them. And orthopedician should try to preserve the joint. Do not offer them early joint replacement. Results are excellent, provided basically excellent surgical technique is the secret of success. All designs gives a good result, and be cautious, beware of newer design and hype by market forces. Thank you.
Dr. Yadav, very deliberate, very good deliberation. I was just wondering, like the initial 15 years, like when the patient is suffering from osteoarthritis, do you think it's the domain of rheumatologist or the physician or hand in hand, like we should manage the patient?
Osteoarthritis?
Yes.
Basically, thing is that when I sitting in the OPD, I see X-ray, how X-ray is damaged. Then I see the gait of the patient. Sometimes it's a bad gait. So bad gait is not good for the spine as well. And the activity of patient like walking has limited significantly. All these things, once they are correlated, we offer them definitely joint replacement, and patient is above 50. If
The role of rheumatologist, like in the initial
initially the osteoarthritis can be treated by you and by us as well, but inflammatory we should not treat them. I am very clear about it. Orthopedician should not treat the inflammatory or degenerative. We can treat both.
But sir, like what it seems to be degenerative in the initial phase, but if the correct evaluation is done, sometimes like we find out the other things and become like 1 in 11 and it's
agree. That's why I mentioned we should not hesitate to take opinion of rheumatologist when we feel something
it was
is
very, very encouraging, like sitting here in the August gathering of rheumatologists. Your last slide was really, very encouraging. And I think rheumatologists and orthopedicians, they really do good, to the patients, and that is really very important. So we both are friends, not the enemies. That is really important. From the audience? So I think we should call it a day, because we have really a very tiring day. Whole day we were sitting in this thing. Thank you, Dr. Yadav.
Thank you, ma'am. Thank you, everybody. Delhi Rheumatology. Sir, boss Dr. Chaturvedi is sitting there. Thank you. Thank you.
Thank you, sir, for this wonderful discussion. I am thankful to chairpersons for successfully conducting this session. Before formally ending this session, this entire scientific program with vote of thanks, I would like to recite few lines by Ramdhari Singh Dinkar, and I think these are very appropriate for role of doctors during COVID crisis. वसुधा का नेता कौन हुआ, भूखंड विजेता कौन हुआ, अतुलित यश क्रेता कौन हुआ, नौ धर्म प्रणेता कौन हुआ, जिसने ना कभी आराम किया, विघ्नों में रहकर नाम किया. Now I call upon stage Dr. Danveer sir, Associate Professor AIMS Rheumatology, for presenting vote of thanks.
Thank you, Israr. Very good evening to all. Myself, Dr. Danveer Badu, would like to express my gratitude to all the esteemed delegates and faculty members to be the participant and contribution for this Rheumatology Update 2022 to make a great success of this event. I extend my gratitude to our chief guest, Dr. Randeep Guleria, to take time out from his busy schedule to grace the event. Special thanks to DRA for providing this opportunity to make this event. I also extend my sincere thanks to pharmaceutical companies which has contributed this, and without this it would not have been possible to organize such a big event. Last but not the least, I would like to express my gratitude to supporting staff such as lab staff, office staff, auditorium staff, sanitation staff. Please accept my deepest thanks. Thank you.
I thank all the faculty and delegates, and thank you for your patience. We have extended our time limit, but thank you everybody for participating. Thank you. Thank you so much.